Then we said also that the person should not have done exercise or be doing exercise in the last 30 minutes, no smoking in the last 1 hour, no coffee in the last 1 hour. Then you check the blood pressure. Then we talked about stages of hypertension. Remember? Yes? Hello? Talk about stages of hypertension. Who remembers the stages of hypertension? Can somebody help? Stages of hypertension. Oh yeah, now don't follow our hand. So they are following your hand though. Stages of hypertension. Who remembers?
Who wants to try?
Okay, just try. Try. Bring it to the front so that there are some people in the front.
If you jotted yesterday, it might be in your jottings.
That's why I said right. What about in 6 months' time? Yes, please.
Good morning, everyone. According to ACS/ESH classification, hypertension is classified into optimal, normal, high normal, then grade 1, grade 2, and grade 3 with different readings.
So what's grade 2?
When the blood pressure is between 150 to 169 systolic and diastolic of 90 to 99 diastolic blood pressure.
It's like 100. It's the next step now, 100 and above. So anytime you're getting above 150, 100, you typically may not need to say, come and measure again. You probably need to start drugs. And when you're getting more than 150, 100, you probably need single dose, dual dose combination. I mean, we talked about that yesterday. We also asked a question. Does everybody need to have investigations when they have hypertension? What was the answer? Yes, a resounding yes. And even those that have just systolic or just diastolic, they need to have what? Investigations. If you find abnormalities in investigations, you need to treat. I think that summarizes hypertension largely.
And then we talked about what we should not do in people that are found to have hypertension. We talked about sublingual nifedipine yesterday.
Never, ever, one more ever give sublingual nifedipine. Please make it your WhatsApp status for 1 week, just to help us pass the message across. And in hypertensive crisis, we want to bring down the blood pressure gradually. We like to use more of labetalol. In this environment, based on what is available, we like to use more of labetalol IV, given slowly in an ICU setting. And if you don't have that, you can give oral medications under supervision and reduce the use of hydralazine, because it raises intracranial pressure and it can be very erratic. You should be careful about that. I think that summarizes hypertension. For next one we talked about was heart failure.
Absolutely.
And the main things we talked about in heart failure were diagnosis, effort intolerance, right? And we said that the diagnosis must always be secondary to something. And the most common cause in Nigeria is hypertension. Ischemic heart disease is also there, dilated cardiomyopathy is also there. And everybody that has heart failure must have what test? Hello? Say again? ECG number 1.
Echo number 2.
Echo number 2. Huh? He talked about tests that you must do. ECG number 1 and echocardiogram number 2. What again? Huh? Chest X-ray. Chest X-ray is good, yes.
Exactly. Yeah.
TSH, thyroid function. And you don't need to do the full thyroid function, you need to do TSH. Okay? You need to check the cardiovascular profile, cholesterol, and the blood sugar, because they typically go together. We also talked about the drugs to use. Is there another thing?
Before the drugs, we talked about the NYHA classification.
Correct.
And we talked about when we are treating, you want to be able to degrade the class of the patient or improve the class of the patient, okay? So that's important, and that's one of the key things that we should assess on a day-to-day basis. We also talked about the ACC classification, and very importantly, the classification based on the ejection fraction. And we talked about it's being changed from, so we have with normal ejection, we preserve the ejection fraction, we reduce the ejection fraction, and then with the mildly reduced ejection fraction. So important for us to know that someone can still have heart failure despite having what appears to be a good systolic function. So heart failure, at the heart of it is a clinical diagnosis, and then we also talked about the Framingham criteria for establishing the diagnosis of heart failure. There was a question yesterday about someone who had been on diuretics and some other medication that the heart failure is seemingly not doing so well. And then we reminded ourselves of the neurohormonal basis of the pathology of heart failure and the neurohormonal basis of the treatment and the medications that must be included in management of heart failure, what we call the guideline-directed medical therapy.
So when you get an echo, somebody with heart failure, don't just go to look at ejection fraction. Ejection fraction is normal and say, fine, it's not heart failure. No. Heart failure can still have normal ejection fraction. If you are absolutely not sure what is causing breathlessness, there is a blood test you can do that can help you. Yes, what's the name of that blood test? Hello? There's so much silence here. N-terminal pro-BNP. So there's also BNP. You can use plain BNP. In our center, we have N-terminal pro-BNP. A little bit more specific. So N-terminal pro-BNP. It's called a heart failure enzyme. If it's high, you are very likely to be dealing with heart failure. Okay, so if you are not sure, you can do that blood test, and that will help to differentiate the causes of breathlessness. Now, when we are treating, we said there are some drugs that are of mortality benefit and there are drugs that are not of mortality benefit. They help, mobility benefit. Furosemide helps, the dioxin helps, all those things they help, but they don't necessarily change the length of life. We talked about the drugs that change the length of life, that you should make sure they are there. What are they? What are they? Number one, MRAs like spironolactone, that's mineralocorticoid antagonist, spironolactone, number one. Every patient with heart failure should be on it. Number two, beta blockers, yes. Number two, beta blockers. Number three, Euperio. Novartis will be very happy that as you said Euperio. Sacubitril, valsartan. Sacubitril, valsartan. Please, those drugs cause hypotension when you are starting it. You need to start very slow and increase gradually. Yes, and what's the other one? SGLT2 inhibitors. And Novartis talked about one yesterday. What's the one that they talked about? Empagliflozin, and I think their brand is Jardiance. Is critical. Those things actually change lives. So please, they might be costly, but you try your best to get the patients on all these drugs. Furosemide, the other ones are useful as necessary, and once you are getting them dry, that's fine. And then they also talk about the need for devices. If your patient is still not getting better, they need to have a device. We said the commonest indication for an ICD. Who remembers we talked about ICD? The device that we put in and can shock. Who remembers the commonest indication we talked about yesterday? Ejection fraction. I need to have a gift for somebody. Okay, so I'm owing you a gift. I will give you algorithms that you can paste in your clinic. Big algorithms.
So symptomatic heart failure with persistently low ejection fraction, less than 35%, despite at least 3 months of guideline-directed medical therapy.
So once you have given the drug for at least 3 months and ejection fraction remains less than 35%, especially with symptoms, you should consider putting an ICD. If the QRS is prolonged and the patient remains symptomatic, you should put a CRT device. Now, the devices are a little bit expensive, but they are worth it because of the number of years they add and the improvement in quality of life. So you should offer it to your guest patients, and if they can afford it, great. If they cannot. And then we talked about the fact that we also have a program for indigent patients for reused devices. I think that's
and just additionally, another advanced evaluation for heart failure is coronary angiography, particularly if the cause is not definite. Okay, so ischemic disease is one of the known causes of heart failure as well.
Then we talk about chest pain yesterday. Who remembers? Chest pain. How soon should you have an ECG when somebody comes to you with chest pain? 10 minutes. 10 minutes. And we are all going back to our hospitals to advocate. So this is a platform for training, yes, but also for advocacy. We are trying to make cardiovascular. Everybody should not talk about malaria, HIV. They should remember this is what kills. It's still killing more than every other thing. So you should set up your hospital in a way that people can get an ECG as soon as they come in with chest pain.
It should not be locked up in the CMD's office. Exactly. That you can only access it on maybe Monday morning.
Or something like that. So everybody should know how to do it. Teach all your staff. Everybody can learn how to do an ECG. We're going to make sure that you can read an ECG today. So ECG should be done. What other tests is very important to be done? Cardiac markers, and the important one is troponin I or troponin T. And you can get a sample, send it to our center. You can make sure you can get the machine, negotiate with one of our sponsors, Codex at the back. They have the machines there. I think you can make sure that you have it so you can get the result within 15 minutes. Okay? And we showed you an algorithm. After you do the ECG, you should classify the patient into risk. Abi? Who remembers? Into risk. We should also determine what kind of chest pain it is. Having done that, we should be able to decide whether this is MI, pericarditis, and if it's just muscular pain or nothing at all. Those are the main things. Now, if somebody has an MI, we said all patients must have what kind of management before you start referring? Medical management. Medical management consists of Monash, ABC. Who remembers? Pain management, oxygen if necessary, nitrates, especially if there's no inferior MI. What again? Aspirin, antiplatelets. So aspirin, 300 milligrams chewed. Clopidogrel, 300 milligrams swallowed. Then what again? Statins for the S. S for statins. High dose statin therapy, 80 milligrams. All of us can do this, right? 80 milligrams atorvastatin or 40 milligrams rosuvastatin. And what again? Heparin or anticoagulation. Give a low dose and then try and get the patient to be reperfused. What are the reperfusion you can do? Two major ones to open up the blood vessel. I showed you a video of one. PCI, so we do an angio and we put a stent in. That is the preferred, especially if the patient is presenting early. That is the preferred one. If you cannot get that done, what else can you do? Thrombolysis, and we said one of our sponsors also has some generic tenecteplase. So that can be helpful. It's a little bit expensive, so it's good. So, but you can have that in your facility or at least know where it is available in your town because that can really save life. Okay, so we have so many cases that we've done it for and it's fantastic. I mean, the people are literally still praying for us today. Okay, that's why I'm alive today. All right, so, and then we said next thing, ABC, beta blockers, AC inhibitors as necessary, managing an ICU and get specialist review as soon as possible. Yes, and then we did BLS.
We'll talk about diabetes as well.
Diabetes, and we did BLS. What are the main things on diabetes?
The main things we talked about on diabetes, we talked about establishing a diagnosis. We talked about being careful and being aware of hypoglycemia. We should counsel our patients. We should select our medications carefully. We encourage ourselves to make sure we try to do an A1C at the time of diagnosis and also routinely for monitoring.
How many people do A1C routinely? How many people do HbA1c?
Routinely for diagnosis?
For diabetes, not many people. So today now we know that we need to do A1C for all our patients with diabetes. Not just with following sugar. It's not enough. You need to look at the A1C profile.
Some patients can eat wrong things for 15 days or 20 days, and then 2 days before coming to your clinic, they live righteously, and then you check the sugar looks good, and then both of you are happy. Right? If you check the A1C to tell the story of what has been going on for the last 3 months, it's tell you the A1C will be off, and you know that this fasting sugar you're getting today is not representative of the last 3 months. So the A1C is critical in the management of diabetes. And then beyond that, of course, there's an algorithm in the booklet that we should try to use from time to time. It can guide us in selecting medications in the management of diabetes. We also talked a bit about peripheral neuropathy, and that's when you see one complication of diabetes, you should look for the rest. It is ridiculous for you to see one complication. There's something that Dr. Isoko always says, if you see one cockroach in a house, there's likely tons more, and that's the way it is. So if you see a patient having neuropathy, please check for nephropathy, check for retinopathy. Don't wait for the patient, check for coronary artery disease. Look for those complications. Otherwise, while you are working up a patient for treatment of the retinopathy, patient can have an MI, like the patient we discussed yesterday. So I think that's an important point for us to note.
And all patients with diabetes, you must examine their feet. Check for the peripheral pulses. Nurses, when they come in, when they are going to the clinic, check their feet, check that there are no wounds, check that there are no calluses, and check the dorsalis pedis. All doctors. Now, this is what I want you to do. Tell the patient as well. I tell the patient so that in case we forget and we have not done it for 6 months, say, oh, God, you never check my foot. Okay, tell the patient so that they hold you accountable. Okay, we typically have a form where you would do it, but if you in your place, tell the patients and check the feet every time. Don't wait till they have an ulcer. Once they don't have adequate blood supply to the foot and they start having things like that, please send them. Let's do a peripheral angiogram. Let's do, Dopplers and pick anything. It is always better for us to open it when there's no gangrene. When there's gangrene, it's bad. It's bad. It's always very difficult. Okay.
think that's about it before
That's
we go to
about it.
BLS.
And then BLS, you remember BLS? What do you do first in BLS? Huh? Safe. The HR is safe. That's not even the first thing. The first thing is to preempt. You should predict, as in you see somebody already somehow like this. Person comes with MI. You should be ready. You don't wait on the person start gasping before you say, or you wait, Kai, my shift is about to be over. Just make it. Just cross. My shift has gone. So start preparing. It may come before your end of shift. Okay, so prepare that. Then call for help. Call for help. Well, before you call for help, I sure the person is not sleeping. So you just start calling for help. Somebody is sleeping. Everybody come and help. So you, Mr. Digbambambiekun, who remembers yesterday we used that. And then Gabriel. No, there's Gabriel's here. Then you check for responsiveness, check what? Breathing, and check what? Pulse. Check them all simultaneously. It should take you no more than 5 to 10 seconds. Call for help, and then what do you do next? Start compressions. Your help is bringing what? Ambu bag, AED, and people with good head. People, not people that will come and say, hey, or that will be doing the video Instagram live while you are doing it. No. People that can come and help. Okay, so you call a code. Okay, how many people call a code in their area? Okay, fine. Then what do you do next? When you are compressing, how fast? Well, that's the ratio of compression to ventilation, 30:2. But how fast must you compress?
How many compressions in a minute?
100 to 120. How deep must it go? 5 centimeters. Okay, and you must lock your fingers, lock your shoulders, and use your shoulders to push down consistently. Then you ventilate, put your C on the mouth, and then E, and raise it up. Remember, we practiced this yesterday. Please, if you did not practice it, please let us know. Maybe we'll have a few. Mr. Victor, maybe we can get some few mannequins at the back just in case. If you did not practice it, please practice it. The next time you may practice it, God forbid, let it not be on somebody you love, and then you start remembering Dr. Seko. By that time, I'll be sleeping at home. Okay, so please do that correct thing. Then what else after that? Defibrillation. Defibrillation. Once the defibrillator comes, attach the pads, don't stop compressions, and then follow the prompts. And then shock. Immediately you shock, continue compressions. Okay, and we'll go extra deeper into that. I think that was a brief summary of everything we learned, of the key points we learned yesterday. And I think right now, everybody that is later than this is too late. So we'll have an opening prayer. Dr. Miseko, let's have that, and then we go. Thank you all. I hope it's been valuable for your time. Please, I want us to remember to tag Limi Hospital, Cardio Care Limi Hospital, ACS 2022. And we want to have some interviews. So we might ask you, one or two of you, to just tell us one of the key points and the highlights you learned. We also put a QR code to give feedback for yesterday's lectures. Please just take a few minutes and give us some feedback so we can know how to improve it against next year. God bless you.
Good morning, everyone. Please, can you all stand? Let us pray. We will use this to pray. Let's go. O God of creation, direct our noble course. Guide our leaders right. Help our youth the truth to know, in love and honesty to grow, and living just and true. Great lofty heights attain, to build a nation where peace and justice shall reign. And we ask that, Lord, you will direct us in all we do, that when we live here, our practices will be better. We will have excellent medical centers where people come in and get well. Thank you, Father, because we have prayed in Jesus' name. Good morning, everyone.
Good morning once again. Good morning. Good morning. Excellent, excellent. My name is Obajilo Oluwasomi, and I'll be serving as your Masters of Ceremony for today's program. Coming up next, we have a short presentation by Limis Children's Hospital, and this will be taken by Ms. Shakirat Abdul Kadri. Please kindly make her welcome. Okay, Ms. Shakira, ladies and gentlemen.
Good morning. How are we cold? Okay, don't be cold, please. Today is fantastic, and we have a lot in stock for us. My name is Shakirat Inyonda. I'm the branch administrative manager for the Limit Children's Hospital. So I'm here to just let you know a few things about us, because the time given to me won't be able to discuss all about us. Okay, it's just a minute. Okay, Limit Children's Hospital is a branch of the Limit Hospital Group. And Limit Children's Hospital is a multi-specialty hospital mainly focused on pediatrics. It's a specialist hospital, and all we do there is pediatrics. I'm sure you'll be wondering, why would they open a branch that all we do is pediatrics? Okay, so I'll just talk about our location first. We are located at 39 Adetokunbo Ademola Crescent, we'll say so. Don't get bothered about that. If you need more information about our location, our booth is behind and I would be there. My team are also there, so we can always give you more information about us. Okay, so we are 39 Adetokunbo Ademola. Only pediatrics, that's what we do there. Why are we doing that? We discovered a few years ago that a lot of children are dying due to lack of proper neonatology care for them. And in our branch, one of the key things we do is neonatology and intensive care units mainly. We have other specialties we run there, but I'm going to start with that. Who we are. We are out there to ensure that we save premature babies. In our record presently, we've saved babies come too soon as low as 26 weeks at birth. 26 weeks at birth, I'm sure you're wondering, how is that possible? It is only possible because we've been able to look around Nigeria and discover that there's a need for us to still do this. When babies are born, hope are lost. We have hospitals with enough facilities to ensure that emergency CS can be done easily and with high success rates. But what happens to this baby? Most times, little things are done, and with the hope of God will do a miracle and something will happen. But our center is there to ensure that irrespective of where you are, we can ensure that we pick up these babies, and that is why we are partnering with you. There's a slide I'm going to discuss more about that. We are not just there for you to refer this baby. We are in partnership with hospitals in Nigeria. Another thing I want to talk about is, what is our goal? If you see there, we save there. We aim to save preterm babies and unite families together. We are out there for preterm babies. So anytime you think about Limit Children's Hospital, just think about babies, a center saving babies, a center working through the pediatric process for these babies. We are there from 0 weeks. We are there from 26 weeks We are there from when they are a year, when parents get to discover there are other problems. Oh, this child needs to start crawling, but the child is not crawling. We are there all through the system till the child is like 15, 16 years old. So when parent comes to us, we let them know we are not just here for the pediatric care. We are not just here for the newborn care. We are there all through for you. In our neonatology units, we've been able to save up to 2,000 babies within a few years of opening. How is this possible? Thank you. How is this possible? I'm sure that's what comes to mind. This is possible because we have the team of pediatric consultants. We have pediatric cardiologists, we have pediatric neonatologists, we have the pediatric neurologist. We have all these I've mentioned as our in-house specialists. So when you call us, for example, from Kefi, that you have a baby, we have a woman who you need to do an emergency S for. What do? We support you. How do we support you? We follow you through. We get a consultant to start talking to you, give you instructions on things you can do to ensure that this baby survives. When this baby survives, we come to pick up these babies. As much as possible, we come to pick up this baby with a mobile incubator. So this is a picture from our NICU. And if you can see here, it stated that our neonatology unit is highly equipped with some functional equipment. We have mobile incubator that we can use to pick up these babies from this facility. Our mobile incubator has gone as far as states that I'm sure you can imagine. What happens? We have a team readily available to pick up. When you call us, we pick up these babies and we move the baby with our equipment installed in the ambulance straight to the hospital. And that process, what happens? Immediately, preterm babies are born and they receive the efficient and effective care they are supposed to receive at that time. It helps to stabilize them. And immediately they are stabilized, you can get better results with these babies. But immediately they are born and the necessary things are not done, the survival rate for them drops immediately. And this survival rate I'm talking about must happen within 5 to a few hours of birth. So in Limit Children's Hospital, we aim to ensure that every time a child born too soon comes alive, we pick these babies up and we help them to survive. Another of our specialty is speech and developmental clinic. We ensure that when these babies are born and things are noticed in the process of growth, we have a clinic and specialty involved to ensure that this is detected on time. Imagine a baby born too soon and the mother discovers later, maybe like 9 months later, that the child can't see. The child is blind. What happens to such mothers? Even as the doctor that did the delivery, and luckily in most hospitals they just try, let's try it out, and the next thing you see, the child survived. Oh, we did fantastic. Yeah, it's fantastic. But what happens after a few months? What happens after a few months is very important. And that is why the specialty hospital is there to ensure that these things are detected on time. And we give appointment later for them to visit at intervals. So what does that mean? They don't have to continue with us. When we discharge, we give you a detailed medical report. We give you information. Even in the process, you get to talk to our consultant about these children and the growth. And even if you are from another center, another location, we can always talk to you on the phone and tell you things you can do at every stage to ensure that if anything happens, we can always get them to come back, do necessary checkup for them, and we give you a report for you to continue the journey with these children. Okay, I just want to talk about a few of our team. We have the pediatric cardiologist as an in-house cardiologist, and cardiology is another key specialty we focus on. Pediatric cardiology in Nigeria is something that is, if you look at the rate at which they are happening, cardiovascular diseases in pediatrics is really getting high. And these things are not known on time. What our parents and most centers saying is malaria. This child just started coughing, and the next thing, we went to the hospital and the child died. Cardiovascular diseases is as much as the way it is in adults right now. It is getting really much. One of the babies we just discharged recently, I think last week, is on pacemaker. The child has a pacemaker installed, and this child is doing well for the past 3 years. This mother is happy, the facility is happy, we are happy. At the end of the day, we are all ensuring that children are doing fine in Nigeria. Pediatric care in Nigeria is getting better. That is the overall goal, and that is why we refer them back to you at intervals. I'll talk about pediatric neurologists also. This is one of the key things in Limit Children Hospital we also focus in. For children with such cases, we have a specialty. For children in such cases, with such cases, we have a special clinic to attend to them and a specialist always on ground. Okay, because of my timing, I'll just want to go to how to refer to us. Like I said earlier on, we are partnering with you. We are working with you. At the point where most mothers come in, pregnant women come in to the hospital, it's not that time you want to start planning, you want to get an incubator, you want to get a ventilator, you want to get a CPAP machine, and all of that. Most times, you don't have a center to, you might need to even call to get a mobile incubator. And that is why I'm coming up today to let you know we can pick up your babies, we can take care of them, and we can always refer back to you. Another opportunity you have is talking to our consultant all through the journey. We give a feedback, so should in case the parents are not in Abuja with us, you have the feedback to always give them. You are in conjunction with the consultant here all through this child's journey. So to locate us, we are 39 Ademola Adetekunbo. Our booth is behind. My number is on the screen, and you can always see me after the program. We are ready to partner with you, and we hope to ensure that at the end of the day, we improve pediatric care in Nigeria, and survival rates for child born too soon get better in Nigeria. Thank you.
Good morning, everybody. Thank you very much, Shakira. You can follow Limi Hospital on Facebook, Instagram, Limi Hospitals, Limi Children Hospital, and Cardio Care. We'll be going on into the next program on the agenda. If you look at your books, we're going to be taking the stroke presentation, but I just want to apologize that, sorry, one of our facilitators is unavoidably absent. That's Dr. Osamwe. However, not to worry, you're still going to get the very best. So to handle this unique session, I'd love us to make welcome heartily, because we're in Abuja Cardiovascular Symposium. So let's welcome heartily Drs. Ilo Dibia and Dr. Abu Kadri.
Good morning, everyone. Thank you so much for making yourselves available this morning, and we hope we'll make things worth your while. Let me just start by saying that I was told that we should compress this into 30 minutes. and he came late, and that's exactly the way a stroke comes. A stroke can come suddenly. So that's, I think, something that helps to put into context what we're about to discuss. And a famed, though departed boxer once described things like this. He said that the one punch you don't see is the knockout punch. You see every other one, but the one that lays you low, you don't see. So we can start by defining stroke as basically a sudden onset neurological deficit, which could be global or focal, and which arises from a vascular cause and either persists till death or lasts more than 24 hours. So these are very old definition, but still very, very, very important. Now, the outline that we showed earlier probably talked about the learning objectives, and I think it's also good to bring in the caveat of things that we are not necessarily going to treat. You know that when we were in medical school, one of the fastest ways to sleep was to read neurology. So we are not going to bore you with a lot of things about nucleus ambiguus, the nucleus of the tractus solitarius, very dangerous sounding names that sound more like masquerades. So we try to avoid that. We try to make it very simplified. We look at things that actually have very clear clinical relevance. The epidemiology is very simple. I think two things are worth highlighting. One is the fact that stroke is the second leading cause of death globally after heart disease. The second one, which I think is quite scary, is that 25% of people who are 25 years and above will have a stroke in their lifetime. I think that's very scary, actually. And the longer we live, the more the chances that will happen. So if nothing else, for the sake of that unknown factor, I think we should all pay attention. Generally, we have two types of stroke historically. Hemorrhagic stroke, which accounts for about 80 to 85% of strokes, and then ischemic hemorrhagic stroke, which is the remaining 15% or so. We won't really go into more detail about these types of stroke, lacunar strokes, cardioembolic. They are all in the slides. So we'll proceed to some very, very pertinent physiological concepts. The brain is small in size, but mighty in what it does. It accounts for just about 2% of the body weight, and yet takes about 20% of the blood flow, also takes about 20% of the oxygen, and also takes 20% of the body's glucose requirements. So it's a very, very important organ. And what that translates to is that if there is a disruption of blood supply to the brain for as little as 5 minutes, a lot of those things start ceasing. In fact, within 5 minutes of disruption, the patient starts suffering neuronal death. And therefore, since most patients with stroke will come much later than that, effectively what we are trying to do is to salvage the penumbra, the area around the lost cells, really, and which is sad, really, but the truth is that with earlier presentation, we can actually achieve much more. Just a point about watershed zones and watershed infections. We've probably seen scenarios where people with chronic hypertension, long-standing hypertension, had things like maybe just a very, very severe episode of acute watery diarrhea and ended up with an infarct. So that can happen because, as we know, one of the things that happens with chronic hypertension is you have marked arteriolosclerosis. So the small blood vessels distally supplying the neurons, many of them get thickened, narrowed, and therefore they are very susceptible to infarction events. And those around the boundaries of the major arterial territories, so the boundaries between the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery, they are all very vulnerable. The way we can think of it is like, for instance, if you are in Nigeria, those towns, those communities at the edges of states where people have struggled for boundary allocation and boundary distribution and all sorts of things, so they are more susceptible to strokes. Now, Dr. Mariam will talk to us about stroke mimics. That's something we must have seen a lot, so she will shed more light on that.
Good morning, everyone. So as much as stroke is quite common, it's actually more common for you to see patients that may present with something that looks like a stroke but actually isn't. So it's quite important for us to be able to differentiate whether or not it's a stroke. This misdiagnosis is one of the most important things. Imagine you see a patient that you think, oh, left-sided weakness, it may be a stroke, and it actually could be something else. Treatment would reduce the efficiency of what you're trying to gain. So a non-contrast CT is the first thing that we do, but a non-contrast CT is not sufficient enough to make a diagnosis, as it may be too early enough to show signs on the CT. So it's about history. As all our consultants tell us in the hospital, history is extremely important. If you have known this patient before, let's say the patient you know is diabetic and takes insulin, and they present with weakness, somnolence, you may suspect, okay, it may be hypoglycemia. So you do the normal things that we do when we have an emergency. You check the patient's RBS, which is a very small but very useful tool. So things such as that, and then also hyperglycemia on the opposite end. It could also be intoxication. If you know the patient has a history of alcohol use or use of illegal substances or drug abuse, it may present something typical as like a stroke. Now, one of the things that, yes, it may not show ideally in front of you, but you may require a brain CT for, would be a brain mass. It could be that the person has a brain mass, or they've suffered a hemorrhage or a contusion. So if you've been given a history of a recent trauma, you could possibly predict that, okay, this could be this. Now, if it's a patient that you're also treating for epilepsy, or somebody who has an epileptic syndrome, you may also think, this could be something else. So it's important for us to be able to differentiate what stroke could be. Let's not just assume, which is what we typically do. Patient presents to you with weakness on one side or some other symptoms, and you think, it's just a stroke, and you start giving normal saline, and you start doing all the things that you typically do. They may be harmful depending on the etiology of their presentation.
Thank you very much for that. Just to add that about in people who present with presumed acute stroke, up to 20 to 25% of them actually have stroke mimics. And that's a very high percentage. And that's one of the reasons why we basically in the 21st century, we insist on neuroimaging as part of the workup for stroke. And that you also should, in fact, even if you are considering treatment, so for instance, thrombolytic therapy in the case of patients who present early enough in acute ischemic stroke, you must, for instance, check the blood sugar. It's actually in all the guidelines, check the blood sugar before you even proceed. So how do we recognize stroke?
So this is a take-home message for everyone, whether you are a health professional worker or not. Ways for us to be able to recognize stroke, I've given a mnemonic which everyone should maybe be able to take home. BEFAST, which is be fast, which is what you want to do if you have a patient that presents to you with symptoms that may be stroke. So the first thing you look for is the B, which is balance. The patient may come to the hospital and there's a bit of dragging of the leg, or they drag their hand, or they tell you, oh, my left side or my right side is weak. So there's a balance loss or weakness in one of the limbs. Another is the eyes. So look at the eyes, they may present with visual deficits. Facial weakness. Some strokes may present with a left-sided or right-sided facial weakness, or a deviation of the mouth. So it's good for you to be able to recognize those phenotypical features in patients. Another is A, which is arm weakness, as I spoke about, loss of balance. The limbs, upper and lower limbs, may be affected. Also speech. They may come to you slurring in their speech. And then T, which is the most important of all, time is of the essence.
This be fast is actually an improvement on an earlier mnemonic of fast. And what was noticed was that a number of strokes were missed with fast, tilted towards lesions of the middle cerebral artery, whereas by adding balance and visual field deficits, you extend more into the vertebro-basilar circulation as well. So it helped to reduce stroke, mixed strokes by up to 5 to 10% in a particular. Can you present the first case to us, please?
Okay. So the first case is a 47-year-old man who was referred to our facility from a private trauma facility where he had an ORIF and an IM nail implant of suddenly developed confusion, left-sided weakness, and seizures 2 hours after the surgical procedure. Significant history is that he's a known hypertensive with unknown treatment adherence and also has a vague history of a heart condition from childhood. Is it likely to be a stroke? Yes or no?
Please, the poll.
We'll give you some time to log in. Okay, we have 100% yes. I'll give you a bit more time. cardiocare.ng/polls.
So we are hoping it's not a bandwagon effect, the winning party. Mm, 30 something, 35. A good synopsis of what I think most people here believe the scenario has painted.
Please, cardiocare.ng/polls. Cardiocare.ng. We use it to answer a lot of questions as we go on and make sure that we are in part. Cardiocare. That is the website there. Please go there. We use it to answer questions. You can also ask questions if you have anonymous questions where you don't want to stand up. But Cardiocare, please let's go there so that we can.
Okay. All right. Thank you for your responses. So that's the next one.
So, the person's risk factors. A, he's a hypertensive. B, this vague history of a heart disease, the surgery that he underwent. Or do you think it's A and B or all of the above? So you can, then we can talk further about it. Okay. I think we all agree.
Okay, so I think we are moving. Just a word on surgery. Surgery is very rarely associated with an increased risk of stroke, very rarely. Some series have said less than 1%. Are there cardiovascular or neurologic surgery? So just very rare, but it's possible. Now, for the risk factors, there's a whole list, and I think for the clinician, the most important part of the that's what you work on every day in the clinic to try to address. And hypertension, obviously, is in fact, if you look at looked at stroke demographics worldwide, the leading cause identified across all regions was obesity, interestingly, which is actually very strongly related with risk of hypertension, and then dyslipidemia and diabetes, cigarette smoking. And then I think of increased, those who have lived like me in the South before, particulate matter pollution is also has also been associated with increased thrombosis and therefore increased risk of stroke and relatively novel risk factors. Can we go to the next slide? Then for the genetic, I would say for the non-modifiable, I think the ones you should lay emphasis on are the gender, obviously. So men need to be a bit more careful. And then the fact that we are black, these are things we can't change. And we should remember to ask about family history of that. Cadacil, Melas, these are, and we don't really know their prevalence in our environment. Please next.
So we'll continue with the case that we presented earlier. An urgent brain CT was done for the patient, which revealed a right cerebral infarct, which is the MCA territory, with massive cerebral infarction and midline. About an MCA territory, the MCA supplies the lateral portion of the frontal and the parietal lobe. So the patient may present with different weakness, predominantly more in the face and in the upper extremities more than the lower extremities. Together with that could be a contralateral sensory loss as well, also more predominant in the face and the upper extremities more than the lower extremities. Another thing the patient may present with is an ipsilateral gaze deviation, and the Broca's area and the Wernicke's area, which then the patient will present with a Broca's aphasia, which is an expressive aphasia, and a Wernicke's aphasia.
And of course, if it's an involvement of the non-dominant hemisphere, we also have hemi-neglect, which is a very interesting phenomenon that we can see where somebody basically ignores, like that part of the world doesn't exist. So that's important too. And confusion also can be seen in non-dominant hemisphere stroke. And in this case, actually, that appeared to be what we had, because the man was confused, hemi-neglect, but the other things were there.
The patient subsequently had a decompressive right hemicraniectomy and was then referred to us for further stroke care, and he was admitted into ICU on presentation. So we have a poll for the medical management of race. You can go ahead and attempt to answer. Okay, so that's about 50 people voting and counting.
Okay, so just looking at the answers, yes, there was a reason why we had tweaked some of these things the way we did. Many people have the impression knocked into our heads from housemanship days and 250 meals, it's hourly to run over 15 to 30 minutes and so on. Now, if you look at the literature, it's a fixed dose. Very wide range. You will see some places talking about 0.2 to 2 milligram per kilogram and all that, sorry, gram per kilogram. And that's a very wide range. So many people just stop at, generally say 1 gram per kilogram. If you just use this fixed dose, it will be too much, especially people who are on the small side. And then for some who are very obese, it could also be insufficient. So it's true you may not be able to estimate visually and just estimate and act on that. Then if you are giving normal saline, which is isotonic saline, you are not giving it for the compression. And what you use actually for decompression is hypertonic saline, which we don't usually have, unfortunately. Transient hyperventilation basically acts by causing alkaline. It reduces the blood flow to the brain, so that helps to reduce the amount of blood going to the brain, and therefore the intracranial pressure also. Okay, so we'll just mention a few things about mannitol. Very useful in stroke, but could also be a double-edged sword. One is that it's fluid. Many of these patients are already on normal saline, and then especially if we are using the low concentration one, the 10%, we have to use a larger volume. So even though it will cost not immediate, usually takes about 15, 20 minutes or so to happen. So that means that before then, you can end up, for somebody who already has a vulnerable myocardium, left ventricular dysfunction, which you may not be aware of, and causing acute pulmonary edema. Secondly is that you can over diurese and tip the patient into acute kidney injury, very important. And then we also should be aware that in the first 48 hours, beyond that, you actually have harm because many of them develop hyponatremia with prolonged use, and with that, you have. So I think those are the most important things to highlight about monitor. Thank you.
So physical examination for said patient, he presented dyspneic, well hydrated, afebrile with no pedal edema, and meningismus. Pupils were equal reactive and accommodating. There was a peripheral nerve palsy of upper motor neuron type with left-sided hemiparesis. The pulse was 59 beats per minute, which was irregular. Blood pressure of 140. The heart sounds were S1, S2 with ectopics, and chest findings was bronchial breath sounds with bilateral cross crackles. Early complications of stroke, early manifestations. So for him, we discussed that he had seizures. Some late complications also could be seizure disorders and cognitive impairment with depression as well. So this poll is in respect to the patient. If you would like to attempt the question.
Please, let's attempt the question. Okay, all right. So the question perspective on this, atrial fibrillation is a known, very key risk factor for examination. We noted an irregular pulse in this patient, and we also noticed bilateral crepitations on physical examination. He had been vomiting, he had been fitting, so very likely aspiration pneumonitis is present, and an integral part of the workup of a patient who has stroke. So that has to be there. And then Holter ECG monitoring cannot be deemed unnecessary. It's also one of the things all these exhaustive investigations that you can end up with that category we call cryptogenic stroke. You've checked, you've looked for everything, you can't see anything, and you just give that designation. Okay, so yeah.
So this was the ECG of said patient, showing atrial fibrillation with frequent PVCs. The Holter gave us a report of myopathy, and this has already put the patient in an increased risk of sudden cardiac arrest. He also had some significant. This was the report of the transthoracic echo.
We can see the obvious left atrial enlargement. Indeed, in this case, it's actually biatrial. Left atrial volume index of more than 34 mils per meter squared is actually an independent risk factor for stroke and sudden death, actually. So it's important you do echo, and without doing the echo, we will probably not be able to drive hard when it comes to modifying his cardiovascular risk. Okay, so can you just talk us through the basic
principles of acute stroke care? First thing in all our centers is IV fluid therapy, like we mentioned earlier. Normal saline at 1 liter 8 hourly. Now you have to make a caveat for patients who are in heart failure, as we see typically in our center. So less than 2 liters and 20. Therapy in the form of alteplase, as mentioned, is given when the patient presents less than 3 to 4. In our current environment, it's quite difficult to catch a patient within this specific time frame. Something might have happened and then didn't present on time, or maybe took it to be something that was transient and would go away. Definitely a history more than 3 to 4 hours ago. Also, hemorrhagic stroke before you consider giving fibrinolytic therapy. Commencement of antiplatelets is very important and should be done as soon as hemorrhagic stroke. Also, prophylactic anticoagulation in the form of subcutaneous enoxaparin can be given within 24 to 48 hours of onset. Is extremely important. Early physiotherapy improves recovery rates in stroke patients. And in order for you to commence feeding, which is extremely important, to avoid aspiration. And then obviously IV mannitol, as we spoke about earlier, which we'll go into soon. Okay. It's not there. Okay, so here are some signs of raised intracranial pressure. He was vomiting, he was restless, and he did have seizures. So he presented with some signs. Mannitol was used as a management. Some late signs that you may see is further decline in the level of consciousness, chain histogram, pupils, papilloedema, posturing. So one of the important take-homes, I think, for raised intracranial, the triad of decreased heart rate, irregular respiration, and a widened pulse pressure. When you see this, now and we should aim to decrease the intracranial pressure by reversing the cause of the increased intracranial pressure and restoring blood flow. Hyperventilation, elevation of the head of the bed for the patient about 30 degrees, and additional medication depending on draining fluid, and rarely, like mentioned, the craniotomy, which this patient actually received. So, second patient, which I'll go back to, a young who was transferred to our facility with a 3-hour history of sudden loss of consciousness when she was noticed to be having an heated the known hypertensive were poor drug compliance, and her medications were unknown to us when she presented. Prior to her transfer, she was given she arrived with a GCS of 3, which means she was deeply unconscious, normal size but poorly reactive pupils, with an elevated blood pressure of 206 over 180. So regarding this patient, maybe we can quickly do an answer poll. Okay. Young female transferred to our facility with a 3-hour history of sudden loss of consciousness, with a history of hypertension of 8 years duration with poor drug compliance. Her medications were unknown. Prior to her transfer, she was given mannitol, and she arrived with a GCS of 3, poorly reactive pupils, and an elevated blood pressure.
Blood pressure was 206 over 80. All right, let's answer the polls. Let's answer the polls. Only 10 people have answered. cardiocare.ng/polls. You remember it better. And nobody knows what you answered anyway.
Okay, fine. Okay, so we are, yes, so some people believe, most people believe she has a hemorrhagic stroke, which is true. And she may have ST segment changes, and that's important because stroke, and you might actually think you are dealing with myocardial ischemia or infarction. So it's good to highlight that it's one of the causes, non-specific causes of, if you can, and you should, do a troponin as well. I've actually had a case of a patient who had synchronous cardiocerebral infarction. Very rare, but it can happen. Now, so this kind of patients definitely requires intensive care unit support. You can't manage this kind of patient in the open ward, and that's why if you are not in a facility where you can give that kind of care, you should actually move the patient on. Somebody as deeply unconscious as this requires protection of the airways, requires ventilatory support. You can't do that in the open ward, so you need to refer to an ICU. And in view of the marked degree of elevation of the intracranial pressure and the hemorrhage into the ventricular system, this kind of patient will require, as in this case we actually did, that's one of the indications for neurosurgical intervention in stroke. The other one we saw earlier, when somebody has malignant middle cerebral artery infarction, is also an indication. In that case, we did a right hemicraniectomy. So basically, these are the criteria for ICU admission. So somebody who has very severe stroke, and you generally for objective health stroke score to determine that. Then somebody who has bulbar stroke, because by definition, and there's people who have large middle cerebral artery strokes, especially of the dominant hemisphere, and then those who have refractory seizures.
So our final case is a 67-year-old male, hypertensive patient, persistent bradycardia. He presented to our facility with complaints of generalized weakness, recurrent tonic-clonic seizures, and altered consciousness 8 hours prior to, and his admitting RBS was 8.8. On physical examination, he had a right upper motor neuron facial palsy with hypotonia in the right limbs with a reduced power, and the blood pressure was elevated 150/80 with a pulse of 44 beats per minute. This was his ECG, which showed a morbid type 2 AV block. Do you think this is a stroke, yes or no? I think this is one of
Okay, so I think we can, most people are moving in the right direction. So yes, this is a stroke. Now, we remember that we talked about stroke mimics, and one of them, of course, talked of seizures, another stroke mimic, and it's important here because he had a syncopal attack. He also had seizures, so it's a bit difficult, but we know that seizures can happen for the first time in a patient's life in the setting of acute stroke. We also know that people who have thought paresis, or rather people who have seizures, can have residual focal neurologic deficits. In fact, motor dysfunction can persist for up to 11 to 36 hours after a seizure. So it's actually important that people like that, we shouldn't just assume, oh, it's a seizure. You should remember, an adult having seizures for the first time, is good to investigate further. And so we did the ECG, and in this case, we found out he had a high-grade AV block, and therefore, one of the things that was done for this patient, beyond the normal stroke care, was that we also implanted a permanent pacemaker for him. And I even saw him last week. His man is doing very well, and that's the wonders of modern medicine. So in terms of the conclusion, so in terms of the prevention of stroke, we talk of primary prevention, secondary prevention, but beautifully, both of them can be encapsulated in a very easy-to-use mnemonic, which she will run through now.
Okay, so this secondary prevention of stroke is as easy as ABCDE. A being antiplatelet, anticoagulation therapy where need be, and also counseling the patient on alcohol, either use or withdrawal, and reduction, most importantly. B would be blood pressure control. A patient with a history of stroke should aim for a target blood pressure of less than 130/80 with a risk of harm when going below that, which is what we call the J-curve effect. C would be cholesterol optimization. When doing a lipid profile, you should aim for an LDL less than 70 to 100 milligrams per dl, depending on the risk category of the patient. And also C could also go into lifestyle modifications such as cigarette smoking cessation. D would be diabetic control. So if you have a patient who has a history of stroke and is a diabetic, you should aim for a HbA1c target less than 6.5, and most importantly, also exercise. So to conclude, stroke requires a multidisciplinary approach from all different aspects, from doctors, be it cardiologists, neurologists, endocrinologists, neurosurgeon where need be, nurses, physiotherapists, speech and language therapists, neuropsychiatrists, as well as dietitian, because as mentioned earlier, it's a multidisciplinary disease. Hypertension being the main modifiable risk factor for us here in Africa and Nigeria, and treating hypertension and other modifiable factors such as diabetes, dyslipidemia, and obesity to target is key to primary and secondary stroke prevention. Having a low threshold for neuroimaging for us healthcare professionals is key in improving our stroke diagnosis and giving us the objective way of differentiating from it and mimics. And to conclude, stroke is ultimately a clinical diagnosis, so we should be fast in confidently making a diagnosis. Thank you very much.
Sorry, do we have any questions? Sorry. Is the mic?
Good morning, everybody. I want to use this opportunity to appreciate CardioCare for putting this together. More grease to your elbows. My name is Aino. I work in an occupational health setting. And well, even before I go, I should also say on the light side that apparently, that yesterday, all the cases that were presented were males. And in this era of gender inequality, that we should have more female cases of, so that you can balance it on both sides. But really, with the stroke, there's a particular scenario that usually plays out. There's some kind of rule that you should do a CT as early as possible. I don't know that maybe there are any radiologists here, but I remember a particular patient that I saw, and we were able to actually get the CT done within 2 hours. Down the line, we were able to establish that it was actually an infarctive stroke, but because in the early periods of after the incident, the patient's brain had not, would I say, displayed the rarefaction issues that could be seen on the CT. And they couldn't, usually with our ancillary lab, they didn't think to do a contrast CT, which would have helped anyway. What exactly is the rule now? Because of the fact that, okay, you might not be able to establish if it's infarctive, although with infarctive, you don't see pressure effects, you don't see certain other signs. What is the rule with respect to doing a CT scan? How long after the incident is actually gold standard, especially in this setting where, the funds that the patient may be accessible to is not exhaustive, and you cannot do serially those CT scans. You just have one opportunity, he has done it, and you're not able to establish if it's a infarctive or, hemorrhagic stroke. Thank you.
All right, thank you for your question. I think the first thing to establish is that the CT scan is plain. It's not contrast enhanced. So that's the first thing. We don't ask for contrast enhanced CT for making a stroke diagnosis. Then secondly, the CT scan should be done as soon as possible. So if the person gets into your hands now, aim to do the CT scan. In fact, some places will say as within 30 minutes of getting into your care. So that's the first thing. And then you should also be aware of why you are doing the CT scan. The most important reason is to exclude hemorrhage, not necessarily to confirm infarction. Is to exclude hemorrhage because that's the one that the treatment pathway is a bit different. And then if the person comes in within the window period that you are that bears hope, which is within the first 3 to 4.5 hours. If there is no evidence of hemorrhage and you are clinically convinced that it's a stroke, then the patient can benefit from thrombolytic therapy. So that's actually the reason for doing the stroke. You might also be lucky, but with that CT scan, you can find out that there is a stroke mimic in place. So it could just be a mass rather than an actual stroke. Then part of it too, we should remember that, yes, you may not see anything, but you know, it's just like seeing something with the naked eye, seeing something with magnifying glasses and so on. So there are some early signs which probably only radiologists will pick. You usually talk of like the hyperdense medullary artery sign. You talk of the insulary bone sign. These are things that can be seen by very experienced eyes. And you can also see a mass effect. You may not necessarily see an obvious area of hypodensity or hyperdensity, but you may also see a midline shift. So it is still very important, and the guidelines put it at the top. It's a class 1 indication. You cannot manage stroke in the 21st century without actually doing a CT scan. And please, it is a plain CT scan. Thank you.
Thank you so much, presenters, for the presentation. Symposium. My questions. I practice in Nasarawa State, and we noticed that more of our patients have their, according to the books, hemorrhagic stroke is about 15%, ischemic stroke is supposed to be about 80%, but we noticed that we have an increased number of patients coming down with intracerebral hemorrhage. I don't know if that is a trend in certain regions, and what can be the possible explanation for that we see more patients now having hemorrhagic stroke, almost about 40% of patients that we see recently. So is that a recognized trend, and what could be the possible explanation for that? Then some neurosurgeons are pretty skeptical about commencing IV monitor for patients who have intracerebral hemorrhage, that it encourages hematoma expansion in the acute period of an ICH. So what is your take on that? And is there any evidence to indicate that that is something that we should be? According to the presentation, enoxaparin can be commenced between 24 to 48 hours of an acute stroke. So are there some situations where we'll be wary of that, given a hemorrhagic conversion of an ischemic stroke? Thank you.
Thank you very much. So I think we can easily identify that you're not one of those lulled to sleep by neurology because of the beautiful questions you've asked. Now, let me just start with the demographics you've mentioned. You know, demographics are not fixed. You can go to, like in these data we have are usually from the Western environment. So you have a lot of, much more of ischemic stroke there. But incidentally, studies have shown that those are fairly replicated across the world. But having said that, even in the West, there's an increasing prevalence of hemorrhagic stroke. And I'm not surprised too, it's happening here. Hypertension is underdiagnosed here. There's a lot of alcohol use here, and we know alcohol raises what do you call it, blood pressure acutely. So that increases the risk of upsurge in the use of illicit substances, amphetamines, cocaine, and so on. These things are available right now in our environment, and these are things that are more found in people who have intracerebral hemorrhage. We also should know that a number of patients are now, we actually have more patients on anticoagulation. Therefore, it is very likely we're going to have more and more intracerebral hemorrhage. Now, for the issue of mannitol and increased intracranial pressure, it's a very controversial thing. What we have done is to adopt a middle of the road. I'm not convinced that mannitol offers any benefits, quite frankly. If you do a Cochrane review, you will see a lot of divergent opinions. But anecdotally, it seems to work, but the key thing is selecting the patient's right. For people who have intracranial hemorrhage, we know that there is a very sharp rise in intracranial pressure at the beginning. It's like a peak at the beginning, and it does not seem to cause any harm. Whether it is always the best measure is open to debate, but as you can see from the presentations we made, there are other modalities. So if we judge with the neurologist, the neurosurgeon, if we judge that that may not be that point, there are other modalities, for instance, the compressive hemicraniectomy we talked about, and even the external venous ventricular drainage as well.
I'd like to chip in that SICH, spontaneous intracerebral hemorrhage, is still a medical diagnosis, and the treatment is medical. So treatment is by physicians, not by neurosurgeons. Neurosurgeons are invited in when there are certain indications. The benefit of mannitol needs to be carefully weighed. But in most patients with spontaneous intracerebral hemorrhage, there's rizatriptan, and the benefit from most of the studies suggest more of benefits and less of harm in that regard. The part I want to chip in again is towards the last question concerning prophylactic anticoagulation is important in stroke, and particularly when you have more severe deficits. But of course, you're right. And you need to dance between the devil and a deep blue sea, okay? And, but starting in 24, 48 hours, the risk of hemorrhagic conversion that will contribute is quite minimal. I think we need to individualize patients and do individual risk assessment of DVT and then assess the risk for hemorrhagic conversion. And that means that there will be a few patients in which you are reluctant to start in the first even 48 hours. You want to delay it a bit further. And sometimes you need to start quite early. So if you have a very obese patient, that have very dense hemiplegia, high. And we do know that, I mean, from my experience, I'm sure you've experienced patients starting physiotherapy and then clots, or you're about to discharge them, they throw clots. You want to prevent that as much as possible. Thank you very much for those questions. I think we can take one or two more.
Sorry, can I just add a little bit more to that? There are risk factors for hemorrhagic transformation. It doesn't just drop from the sky. One is reperfusion. So whether you've done endovascular treatment, that's thrombectomy, or whether you've done fibrinolytic therapy, these are established risk factors. They increase the risk. If the patient is elderly, glycemia, the risk is higher. So these are well-established risk factors. Of course, if you have up to more than a third of the cerebral hemisphere involved in infarction, the risk is higher. And also the thing about individualizing care. If the patient has a coagulopathy, and that's why your history taking is important, and you may need to go beyond the usual investigations to identify those risk factors. So if the person has thrombocytopenia, if the person has a family history of coagulopathy and all that, you may be you obviously will be concerned about starting anticoagulation. Thank you.
So thank you very much for the opportunity. My name is Dr. Yakubu. I have two questions. The first one is to do with the timing between ischemia and necrosis. I think before now, the knowledge is 3 minutes, but you said 5 minutes. And I think it's statistically significant, the difference. So I want to know what has happened. And then my second question is, some patient with stroke, you know, in some cases, she mentioned the wide pulse pressure, and that's where I want to address. I want you to address a specific thing, and that thing is, what is your drug of choice in a patient with a wide blood pressure of 170/70? 170/70 millimeters of mercury. Thank you.
Okay, thanks for the question. Now, with regard to the first question, very simple. It depends on the literature you have read. Whether it's 3 minutes, 5 minutes, all we know is that within the first 5 minutes, it is complete. Histologically, you start seeing evidence of liquefactive necrosis within 12 to 24 hours after a stroke. But the clinical event has happened within the first 5 minutes. So I think it's maybe statistically significant, but I'm sure that from the nursing station to the A&E will probably take more than 3 or 4 or 5 minutes. So I think that sorts itself out. Now, for the second question, wide pulse pressure. you know, there are a lot of cardiovascular risk factors related to blood pressure. So we talk of, for instance, people who have labile hypertension, people who have master hypertension, people who have nocturnal hypertension, people who have high blood pressure variability over a 24-hour cycle. We also talk of even this wide pulse pressure you're talking about. And then, among all of them, I think consistently, systolic blood pressure is the major driver of cardiovascular events beyond the age of 50. And in as much as you are worried that there could be a drop in the diastolic pressure when you institute treatment, the most important aspect, epidemiologically, clinically, is your systolic blood pressure. Now, the mean arterial pressure may also be of concern, but generally, in the setting of loss of cerebral autoregulation, at the end of the day, if you're able to maintain your cerebral perfusion pressure between 60 and 80, which you will achieve if your mean arterial pressure is between 65 and 110, there's really no issue. So at the end of the day, acute stroke, blood pressure control is the guidelines are very clear. Maintain it within certain parameters. Permissive hypertension in acute ischemic stroke, and then reduce to 140/90 or stroke. Thank you. Sorry, just to add, if you are concerned about blood pressure variability, of course, amlodipine is unique in that regard. And then long-acting medications like telmisartan, too, excellent profile, 24-hour profile. These are drugs that have been known to help with that. But practically, because we see a lot of patients with aortic regurgitation and all that, we have very high pressures as a result of the loss of the elastic recoil of the aorta. It is still the systolic pressure that determines our blood pressure reduction aggressive.
Good morning. Thank you very much for your presentation. Please, I have a question regarding the early initiation of anticoagulation therapy for suspected strokes. In resource poor settings, as the guideline states, as well as your presentation, you need to have a CT scan before you initiate therapy. However, for resource poor settings, it's noticed that you really do not have the facilities in those places. And by the time you send them out to refer them to go to the central areas to get those CT scans, the damage would have likely been done. And so my question is, could there be certain clinical symptoms, your patient presentation perhaps is complaining of increasing intensity of his headache, that could clue you in that maybe this patient is experiencing hemorrhagic stroke as regards to an ischemic stroke, seeing that in this our setting, the higher incidence of ischemic stroke as well. Could it be that you could just give maybe perhaps aspirin, and then you send the patient on to get the CT scan in the city? Thank you.
So thank you very much for your question. I do agree that we work in resource-limited settings often. First of all, while we said that it is critical to do neuroimaging in stroke, it does not mean that you cannot treat without neuroimaging. That will not be correct. Okay, so you should start treatment for what you can see, ABC of resuscitation, do every other thing you know, and but neuroimaging is critical in the management of stroke. And no, it will not be appropriate to give aspirin without knowing the subtype of stroke that the patient has, because a small bleed can behave like an infarct and vice versa. So it's until you actually see the brain and you see a CT scan that tells you that there's no hemorrhage, there's absolutely no other way to know. Now, there are several scoring systems, and none of them is near perfect enough that you can risk your license, not to talk to risk a patient's life on it. So none of them work near enough to be close to what neuroimaging will tell you. So if you're unable to get neuroimaging, just do all the other things you can see. Take care of the airways, maintain the breathing, watch the blood pressure, give IV fluids, start physiotherapy until the day that the patient can do a CT scan. And then once you subtype the stroke, then you can give the the pathway-specific treatment for the subtype of stroke that the patient has.
Good morning. I just want to add, like you said, in a resource poor center, using symptoms like we said, I know we used to talk about a hemorrhage, stroke, but if you use some symptoms, it may give you some clue. Patient with headache, seizure, stroke occurring after activity, vomiting, very early, very high blood pressure, all those things look closer to hemorrhagic than ischemic. But like we said, what you may need to do is play a bit safe. No aspirin until you are sure that there is no bleeding. You can do your normal saline. You can do your normal saline. Even statin, the use of statin is also controversial in patients with hemorrhagic stroke. So you need to be careful. There's no other way to say it. Neuroimaging is essential. It's like managing someone with hypertension without doing an ECG and echo. So we should try to do it. And like my chief used to say, we most of the time assume that patients don't have money. But when you tell them that this thing is life-saving, you'll be surprised that those tests will be done. But if you assume, because the way you are looking at them, that they don't have money, they too will tell you they don't have money. But if you tell them that their life depends on it, those tests will be done. But like I said, your normal saline, things that you know are safe, but aspirin, please, we should be very, very careful. Thank you.
Just one more question.
Is there any other question? We have time for just one more question.
Thank you for the presentation. My name is Dr. Jaffer. I had an experience with an 80-year-old man that presented with a CT-confirmed hemorrhagic stroke. It occurred for 48 hours prior to presentation, but he also had a right lower limb DVT, Doppler confirmed. So how would you have managed the situation? Thank you.
Thank you very much. So two things to say. Number one, now it's controversial and sometimes I'm scared of it myself, but after 2 to 4 days, 4 days definitely agreeable with most people. You can start anticoagulation in people with hemorrhagic stroke. Prophylactic though, not therapeutic, after about 4 days, but it's quite daunting many times. So that is in the guidelines, it's in the AHA guidelines. But when we have a scenario like that, it's quite tricky because giving therapeutic doses is quite high, and frankly, there's a high risk that can extend your hematoma in the brain. And your best bet in such cases is to put an IVC filter. So there are high IVC filters which we do put, and we've put in maybe 1 or 2 patients in that clinical scenario. An IVC filter is a filter that is a mesh that stays in the inferior vena cava and can prevent any clot from lower limb from going to the heart, and it can be a temporary measure until the patient is most useful in patients that have contraindications to anticoagulation, which would be like that in this case. In the absence of that, it can be difficult, but I'll encourage us that after day 2 to 4, you could actually place such patients on some amounts of enoxaparin. Now, whether you're comfortable enough to use therapeutic doses or not is going to be debatable. But the guidelines do recommend that after 4 days at most, I think the most conservative guideline says after 4 days in hemorrhagic stroke and actually start prophylactic anticoagulation. Now, that comes with a lot of caveats, which may not be practical in this environment. So you must be able to monitor both clinically and radiologically for extension of any hematoma in the head. So you must be ready to do serial CT scans or MRIs just to make sure that you're on top of the game. I hope that answers the question. Want to add something? Okay, time has gone. Let it start. We can take. We can take 1 or 2 more questions. We are still setting up for the next presentation.
Thank you. My name is Chinwe Ugochukwu. I'm a physiotherapist. So I have 2 questions. The first one is, we talked about spheric neglect. And as a physiotherapist, I'm concerned, in a ward when you have a patient that you're already aware that he has one side that is neglected. So how do you position such patients in the ward? Because I really need to know, how do you position such patients in the ward that will at least help the patients to, maybe focus on the neglected side. So how do we position such people in the world? Because of concern to me as physiotherapists. Then secondly, where do you place the IV on the affected or on the affected side? So please just enlighten us with that.
Thank you very much for the questions. So for the patient that has neglect, there's really nothing too particular about the positioning, but usually, of course, the things you want to get the attention of the patient has to be on the side that the patient is paying any attention to. It's a spatial issue. So if you want the patient to be able to pay attention to these things, that is, if the nurses are going to be coming in through here and things like that, then let that be on the side that the patient is paying attention to. Because if the nurses are trying to serve the patient from this side that the patient is neglecting, really you're going to have difficulty in getting the patient's attention on that side. So that would be what I would say about the positioning of that. But it can be a very terrible symptom, and sometimes it can make it difficult for you to even delineate some of the other symptoms that the patient has. So if the patient has sensory symptoms, the patient may actually be feeling the sensation, but because it's neglecting that side. So that means you can't make judgments on even motor or sensation and even vision when the patient is absolutely neglecting a side. That's one. Regarding the second question on placement of IV lines. So usually we try to leave the side that has deficits. We try not to measure blood pressure there. We try not to put IV lines there, ideally. Now, that is a double-edged sword, because typically you want the patient to be able to use a hand that is usable at least. So, because the hand that has IV, for example, the patient tends to not want to use it very well. But during that time, you should leave the hand that is affected so that the patient can focus on trying to restore the use of that hand. So that hand should not be used to check BP, should not be used for IV lines ideally. But hopefully, once the invasive components of treatment is done, then the patient can begin to use the normal hand. Thank you very much.
Thank you for a wonderful presentation. Please, a round of applause for them. I hope we're enjoying the breakfast menu. We're not enjoying the breakfast menu, don't worry. There's still more to come for lunch. So coming up next, we have a special presentation brought to us by Medtronics. And to take this presentation is Mr. Mohammed Gidado. Please kindly make him welcome.
Muy bien, Tata, muy bien. Vale.
Thank you very much. Good morning, everyone. My name is Mohammed Gidado from Medtronic. Okay. So now looking beyond medical therapy, we are going to look at medical devices and what are the innovations that have come up over time. Now, Medtronic is a medical device company where we specialize on innovations. In the last 24 hours, we've been talking about cardiovascular diseases, acute coronary syndrome, peripheral artery diseases, aortic aneurysms, then surgery, everything related to cardiac. Now, beyond medical therapies, Dr. Seko mentioned something about stent pacemakers. So, Medtronic produces most of these devices. Now, this man here started this company called Medtronic in the 1960s. His name is El Bakin. This picture you can see here, I don't know if it's showing, that big thing is holding there happens to be the pacemaker back then. So when a patient needs a pacemaker, he wears it around his neck. Imagine carrying a machine around your neck. Today, you can see the tiny thing there. That is as small as the pacemaker has become today. So a lot of patients now have the pacemaker buried underneath their tissue here without you knowing. So, beyond medical therapy, biomedical engineering has gone further to bring out medical devices. Now, this mission was written in 1960, and our key mission is to see how we can alleviate the patient's pain, restore his health, and prolong the life with the grace of God. I'm an advocate of do it here in Nigeria, because it's been shown that a lot of patients recover better here in Nigeria beyond taking the patient abroad. The recovery time has been shown to be shorter when they are within their family members than when they are outside the country. Am I right or wrong? Okay. So now, if we agree with that, so we brought the technology down to Nigeria as far back as 10 years ago. Now, the question a lot of people ask is, do patients have access to this therapy? Yes, they do. And my aim of this presentation is to make us aware of what is available in Nigeria in terms of medical technology in the cardiovascular space and other areas, especially for private hospital owners. In the cardiovascular space, we have the heart and vascular therapies, starting from control of arrhythmias, bradycardia, tachycardia, down to heart failure, cardiac surgery, peripheral artery diseases. New in Nigeria now is the aortic aneurysm repair, which I will show you later. Beyond the cardiovascular, we have the we talk about the neurovascular therapy beyond neurosurgery. Now, patients have the opportunity of having minimal invasive surgery. Now, the question is it being done in Nigeria? Yes. Airway, the brain, diabetes, we have the insulin pump, though not in Nigeria yet. Our 6 core cardiovascular operating units in Nigeria include the cardiac rhythm management, which is the pacemaker, the ICDs, the CRTs. We have the cardiac surgery, coronary vascular, peripheral vascular, endovenous, and aortic vascular repair. So, we have over 65,000 employees across the globe covering the cardiovascular therapy. We're just 3, we're about 5 in Nigeria. So now, why did Medtronic decide to bring this to Nigeria about 10 years ago? Because we realized that a lot of patients leave Nigeria, go abroad, come back to Nigeria, no follow-up. No follow-up because it's either the patient got a device that nobody can manage in Nigeria, or the patient got a therapy that nobody has an idea of what it is in Nigeria. Then we started by educating people, training people, and we decided that, okay, we have to do it here in Nigeria. So we are in over 70 countries. Now, beyond the cardiovascular space, we have the medical surgical operating unit. That's the surgical innovation, which is the SI, patient monitoring, respiratory, GI, and the renal solutions. Medtronic is here to deliver superior experiences to patients and to the customers. Now, for the surgical innovations, you have the patient monitoring, your staplers, the GI. Quite a number of people are conversant with this. And about 4 years ago, Medtronic bought a company called Covidien. A lot of people know Covidien. So Medtronic bought that company as well. So whatever you find in Covidien is now called Medtronic. So now, we are into what is called surgical robotics, not started in Nigeria, so I won't focus on this. The gastrointestinal. So now, for endoscopy, there is something called pill cam, whereby it's a camera in form of a capsule you swallow, and you look at what is going on. Still new, but we have about 1 or 2 people using it in Nigeria. Now, the idea is this available in Nigeria? Can it be done? Yes. Renal care solution? Yes. It's done in Nigeria. Now, let me start by looking at the peripheral vascular. Dr. Seku yesterday during his presentation showed us the cath lab and showed the diagram where they're accessing, when I was talking about the access within the Seldinga, going to look at the vessels. So now, beyond the heart vessels, we look at the peripheral vessels. So, we talked about some stents. So now what we have has to do with solutions from the top of the body, the upper limb, down to the lower limbs. So you have a patient that has maybe upper limb occlusion, maybe after an AV fistula. You want to open it, so you then either use a balloon, or you can put a stent. You have a diabetic patient, the lower limbs, most times patients go for amputation, but there is a solution before you go for amputation, looking at various criteria. So you can revascularize that leg or the vessel using a stent or a balloon, and there are different maneuvers. Now, is it being done in Nigeria? Yes. So many centers are coming up now, and as part of our program, we're trying to see how we can train HCPs, that's healthcare professionals, on how to do these therapies. Now, my question is, a lot of these centers set up these big facilities, like the cath lab, costing over $1 million. Companies like Medtronic come to Nigeria, set up this big, stuff you see abroad. Everybody look at it on Grey's Anatomy, but they're being done in Nigeria. Now, if they put up this much investment, what is required is, let's refer. When you refer, your patient get better. At the same time, whoever is interested in it can get trained on that area. It could be cardiac surgery, it could be peripheral artery diseases, what have you. Now, in the neuro space, our focus is on just these 3: hemorrhagic stroke, ischemic stroke, arteriovenous malformation. So what do we have here? You have, in Nigeria currently, a lot of neurosurgeons do what is called clipping. So what have we brought new? We brought the coils. So you have coils that you use for AVMs, and we have some devices that you can use for things like mechanical thrombectomy. You have some catheters you can actually use for this patient. So now we are starting with hemorrhagic stroke. Why? Because the approach we normally take is you pull the patient, we send an expert to train you in your facility. Back then in the days, a lot of people go abroad. But the idea is, when you go to a facility abroad, you have backups. If something happens now, somebody gets something done the next door. But in our environment, it's not as fast as that. So why don't we start with our own environment and see how we can tackle those challenges when they arise. So that's why we're changing the trend now from sending you out there to bringing the person in here. When you have gotten some level of skill, then you go to get upskilled. This is new for cardiac surgery. This was manufactured 3 years ago. So Medtronic partnered with a company called Spectrum. Spectrum is an IT company. So this is a heart-lung machine, but can also do what is called an ECMO. ECMO, or mechanical circulatory support. So during COVID, there was quite a number of interest in ECMO because a lot of COVID patients beyond ventilatory support, needed mechanical circulatory support. So we started this in Nigeria during COVID. I mean, the first machine came to Nigeria during COVID. So apart from doing cardiac surgery, whereby the cardiac and lung function is being taken over by this machine, you can also convert the machine into mechanical circulatory support. And who benefits from this? So now, the use of an ECMO, if you've checked it online before, for those that know, can either provide a cardiac support or respiratory support for this group of patients: ARDS, lung failure, pulmonary embolism. Now for cardiac support, patient in cardiogenic shock, cardiac arrest, advanced heart failure, sepsis, cardiopulmonary failure. Also during cardiac surgery, there's some patients that you cannot wean off the bypass. You need to transfer them into an ECMO, most especially children. Yeah. So I talked about endovascular, which is the we call it endovascular or endovenous. That has to do with varicose veins. Quite a number of doctors do what is called vein stripping. Strip off the vein, patient has to be admitted a day or two. Now, what happens to that? The risk of infection is there. But now we brought something called the radiofrequency ablation. So with the radiofrequency ablation, you don't need to go into the theater. You can do it in your side room. You can do it in your, maybe in the office even. So the patient just needs to be on a table, and you only need an ultrasound. So this is an ultrasound-guided procedure whereby you insert a catheter into the vein, and you literally burn the vein. You wrap the leg, and the patient goes home immediately. So this is something that we started in Nigeria, and quite a number of patients, you realize that a lot of patients, especially people that stand for long, people with venous insufficiencies, can benefit from the radiofrequency ablation, most especially women. I mean, a lot of women with the varicose veins tend to benefit a lot from this. And the painless therapy. So other therapies include, we have something called the structural art, which we are yet to start. I know Dr. Seko will hold me on this, which is the TAVI. So instead of a patient having an open heart surgery whereby you replace the valve, you can actually go through the groin, transcatheter implantation. These are all therapies that are available and can be done in Nigeria. Now, let me quickly go through to the training. So these are training centers. Now, we try to partner with different institutions, different facilities, to see how we can improve capacity, because the only way this patient can have access to this therapy is if the doctor has the skill. So our target is to see how we can increase capacities by partnering with centers like CardioCare and some other centers that have the facility, that have invested in those facilities. So we partner with them to upskill local doctors. So we sign in local doctors who have the skill to train other doctors, and we pay for it. So we have one of our centers, Medtronic Innovation Center. This is a big center we have in Istanbul. This is one of the easiest centers for people in sub-Saharan Africa, emerging market like Egypt, Kenya, Tanzania to visit, whereby we will invite them depending on the area of specialization they belong. The other one is in Tolokinas in Switzerland. So these are some of the facilities, what we offer, everything in one space. So it's a huge facility whereby you get to have an hands-on simulation. So we use what is called a simulator, like a real-life scenarios. You do the case, you kill the patient there, then you come and do the real one so that you don't kill the patient the next time. So we have the wet lab in Johannesburg, whereby you can go for pacemakers training. Also, there's another simulation lab. I look forward to Nigeria, whereby we'll be able to do something like this in Medtronic. So in terms of collaboration with Nigerian hospitals, this is what we do. So we do a continuous medical education in partnership with different centers. We had quite a number of them with LIMI and some other centers across Nigeria, Ghana, Tanzania. So for the for cardiac rhythm and heart failure, that's the pacemaker. So we partner with them. We do internal training, like I said, support. You have a patient, you invite technical guys. We come in, we support you during the procedure. We do follow up with you after the procedure. For coronary also, we do live case transmissions. We have partnership with different centers across the globe, whereby you can have a live transmission, like a telemedicine. Also, you have what is called pool and proctorship. So pool and proctorship means you pool the patient, we send somebody who's an expert called the proctor to train you. Then the APV, so that's aortic, peripheral, and endovenous. So now we started this newly in 2021, early 2021.
Thank you, Mechatronics, for your presentation. Before we go into the next presentation, we have a few announcements. The CME certificates will be prepared according to the names and emails that were submitted yesterday. So if you feel you probably have a mistake, probably in the way your names were written or anything, we'd like you to just get to the registration points outside the hall and then make the corrections. Then a few announcements. We'll very much love you to please remember to tag your pictures on social media, hashtag ACS 2022, and then hashtag cardiocare. A reminder that the restrooms and convenience, they are located outside the hall. When you get out to your right, behind the hall, you should be able to find that. Then let's not forget the algorithms in the book. They are very much essential for clinical practice and would come in handy. There's water at the back, and you can just signify and somebody will make that available for you. We have the next presentation. It's going to be a virtual presentation from, sorry, please, let me just confirm. Okay. Yeah, we'll have the next presentation from Africa Farm, and it's going to be a virtual presentation. Media, you can go ahead.
So good morning, Nigeria. It's good. So, hello, good morning, Nigeria. Thanks for all. So, good morning, Nigeria. Abuja from Barcelona in Spain. Africa Pharma is based in Barcelona. First of all, I want to thank to Dr. Iseko this great opportunity. Thank you so much, Dr. Iseko. I think will be for many years this nice collaboration with Africa Pharma and Limi Hospitals. My name is Miguel Comitre. I am CEO and co-founder of Africa Pharma. I've been working with many pharmaceutical companies like the German Bayer, the German Boehringer Ingelheim, the North American Volcano that was the owner of IVOS, intravascular ultrasound. This is very important topic. You will see in 3-4 minutes why this is important, because I know all the interventional cardiologists in Europe, and this will be a good point of Africa Pharma related to you. What is Africa Pharma? As you can see here, we sell the highest quality drugs from Europe, generic drugs for many pathologies. We have a big portfolio, and I know all the directors of manufacturers in Europe, so it's easy to get this. Africa Pharma is this. Also, it's important the supply, the excellence in supply, because all the high quality, all the best in class quality of medicines, if you send by ship, you are losing with the temperature, you are losing with the humidity. It's important to bring the medicines by airplane, okay? This is what Africa Pharma do. And what about our philosophy? Is this to sell these high quality drugs and also the excellent supply by air freight, by airplane always. Also, our philosophy is a big investment in education. As our colleague of Medtronic say with trainings, we also do trainings in Europe. I know all the interventional cardiologists, and it's very easy to perform 3 days, 3 mornings in a hospital in London, Paris, Berlin, Madrid, Barcelona. This will be very beautiful because this is the beauty of our business. Invest in education. And this is what Africa Pharma is doing, okay? So apart from tennis, always typical congresses, no? We invest in congresses. Already we did some investment with Lagos, with Hospital Pylon in Lagos, to Vienna. They went to very nice congress in Vienna. More points, clinical trials. We are investing in clinical trials. I was speaking with Dr. Iseko about Framingham style, but in Africa, because I think this cardiovascular risk study clinical trial will be a good point to change all the and clarify all the guidelines in cardiology. Let's speak about this. I don't know if you are doing in Nigeria. I don't know if you are doing in Africa, but it's an important topic, in my opinion, to collaborate with you in everything, okay? More things about clinical trials. Barcelona is a health tech hub. Barcelona there's a lot of health tech now, is on trend, all these companies of health tech. For example, they are performing a clinical trial with a smartwatch of Apple, and they can predict a heart attack. It's very state of the art now. So let's do it in Nigeria also. I don't know, again, I repeat, probably you're doing already, but let's do it because I know all these organizers of the principal investigator, okay? More than this, for example, clinical trials, symptom checker, based in artificial intelligence now is on trend. We are doing in some German hospitals and English hospitals that the patients arrive to emergencies and you give an iPad, you give a tablet, and start to say symptoms, and artificial intelligence is doing the next question. So when the patient arrives to the doctor, he did already this symptom checker, okay? More things, more collaborations, for example, speakers, no? Sure, more people of you, many people of you are good speakers, so we can collaborate with this to do symposiums. Talking about symposium, Africa Pharma is going to do symposium in Kawara State next March, okay? We are in collaboration with Dovizia Pharma. Ladi Ojo is a very smart and talented person. Ladi Ojo is the CEO of Dovizia Pharma, and we have a partnership with him, okay? Important, speakers, for example. If someone of you has this profile, let's do it. Let's do. And also webinars. Sometimes for me it's better presential as you are doing now. Today I cannot do it, okay? But next time we will be with you in Abuja, in Nigeria, for sure. Webinars are very comfortable for everybody, so we can do webinars. We can plan something for January, something for February, rent the speakers, and let's do it. It's another thing. So this is Africa Pharma. And now, for me, it's the most important moment of this conference, of this speech, is my phone number, okay? And our webpage. My phone number, please don't hesitate to call me, to text me WhatsApp, to send me email. Don't hesitate. If you can take note, probably everybody has pen and notebook here, is 0034, okay? 651, 0034, 651 962-333. Miguel Comitre. This is my personal phone. Don't hesitate to write me WhatsApp, to send me, to call me. I will be delighted to collaborate with you in education programs. We don't work only with doctors or physicians. We are working with nurses, that I know there is a lot of nurses here in this Congress. Okay, I was talking with Pamela, and also pharmacists. Our collaborations are always for healthcare professionals, not only doctors, not only cardiologists. Nurses are very important, okay, in the organigram. Nurses are very important, and pharmacists, okay. Indeed, as an example, the Congress of Vienna was with pharmacies, was the International Congress for Pharmacies, hospital pharmacies, and was amazing. So this is Africa Pharma. I will repeat just in case, my phone again, 0034 651 962 333. Our webpage is www.africa-pharma.com. So this is Africa Pharma, and this is what we want to do with you in Nigeria. Okay. Thank you so much for attending this conference, and thank you again all the Limi hospitals and Dr. Iseko. So this is all. Okay. Thank you so much. Probably Pamela, you are now introducing the next.
Thank you, Africa Farmer.
Thank you so much.
I hope you understand all what he was said. All right, don't worry. There's going to be a recording of all of that on the Cardiocare YouTube page, so you can always go back to refer to that. Then, of course, all the lectures that you have received will be sent to your emails that you've provided in time. Then, regarding the CME points, ushers are going around with sheets of paper so that you can fill the details the way you would like for it to appear on your CME form and also on your certificate of participation. Coming up next is a special presentation by Cardiocare, and this will be taken by Dr. Iseko, GMD of Limi Hospital Group. Please kindly make him welcome. We can do more than that.
Good morning, everyone. I hope you're not tired. We still have a lot of stuff for you today. Don't get complicated. There's ECG and there's ACLS. I've been sitting down in the back trying to make it simplified. With special thanks to Miguel Comita from Africa Pharma, who will send his slides across to you as well. Africa Pharma is a firm in Spain, and what they do is they try and supply drugs. I think so they are coming to Nigeria and they are trying to partner with hospitals. So this was a good opportunity for them to showcase, and he promised to be here in person next year. Some of you that took his number, but if you get his slides, his number will be there as well, and it may give you access to high quality medication, just like Vastovas is offering us here in Abuja. I'll be talking about Cardiocare Hospital. Cardiocare Hospital is where I work, and Cardiocare was founded in 2016 under the Limi Hospital Group. The Limi Hospital Group is actually 40 years this year. We celebrated our 40th anniversary this year, and Cardiocare was born out of that. Started in duplex, not far from here, and we've grown into what we are today, being the pioneer standalone cardiovascular institution in northern Nigeria, and also offering a wide range of advanced cardiovascular services. We've talked about a number of things, and these are some of our consultants here. We have about 4 to 5 cardiologists, interventionists, cardiac surgeons, endocrinologists, neurologists, and all the like for internal medicine. So cardiac catheterization procedures, essentially I want to focus on cardiac catheterization procedures which we offer, and I am primarily more now in interventional cardiology than in clinical cardiology. And what happens in the cath lab, we'll be talking about it, and we'll talk about some of it also when we are talking about ACLS. And what happens in the cath lab essentially is the gold standard to be able to intervene in a lot of, cardiac conditions while the patient is awake. So we get vascular access. We use the radial artery, so that is normally more convenient for patients, or we use the femoral artery, which invariably we also use much more. And since 2015, Cardiocare has been there. The cath lab was opened in 2020. Since then, we've done over 500 cases successfully by the grace of God. Of course, you know that much more have gone abroad from here in Abuja and from the environs. I noticed some patients that were passing through. One patient had a cardiac arrest at an embassy. They were passing through Abuja from, I think, Adamawa, and then they were now rushed to Cardiocare for us to sustain them so that they can enter their flights back to India, which we did. So what we are trying to do is to offer indigenous healthcare, just like Medtronic talks about. And what we are doing is, besides the regular care, is research, local training. That's what we are trying to do here. We've been doing this for 5 years. This is the 6th year consistently. We're trying to reverse medical tourism. And some of the training we are doing is postgraduate training of cardiology. So we've partnered with University of Port Harcourt Teaching Hospital. We're partnered with University of Abuja Teaching Hospital. We've partnered with University OAU Teaching Hospital Complex. So they send the SRs, they spend some time with us and familiarize themselves before they go for part 2 or become consultants. So Cardiocare, we know Cardiocare. Last year, we got this award from the Nigerian Cardiac Society, recognizing our work in cardiovascular care here in northern Nigeria. Yes, it's a good thing of joy. Nigerian Cardiac Society is where the orgas, the big people, our teachers. So that's where they are, and it's quite important. It was quite an honor to honor us. That's Dr. Olalekon, that's me, that's Dr. Edafe. Dr. Edafe is flying in this morning to join us as well. And this is 5th Abuja Cardiovascular Symposium. This was last year. I don't know if any of you can see your face there, but a lot of us are new this year. We've been doing this for a while, and we'll continue by the grace of God. We think that it's making a difference. We think that it makes a difference in practice, in patients' life. We think that patients are actually getting better. The quality of referrals, the timing of referrals, the survival stories when a doctor calls and says, look, I practiced that thing you taught us, and that patient is alive today. There's nothing like it. It cannot be compared. It cannot be paid for. And those are some of the things that we have focused on. We also this year decided to do the first National Interventional Cardiology Symposium, where we focused just on interventional cardiology over 3 days. These are all specialists typically from different parts. So mainly from the north and also from Lagos, and Enugu too had 3, and Benin. Yeah, Benin had 1 or 2. So brought in people, took them to the cath lab, they dressed up, a lot of procedures, and over time, about 10% of our procedures have been relatively discounted or pro bono or charity. So that has also been possible by a lot of assistance from the hospitals, from Limi Hospital as well, and Nigerian Cardiovascular Education. As at the Nigerian Cardiac Society conference, we presented this paper where we showed 454 cases that we had done, at least as at that time. Now it's gone past that, and how we're able to finance them. This is the case we talked about. Predominantly were coronary procedures. So that's what we showed yesterday, how you get it, and we leave a wire in there. Then we pass the sheet over it. We pass the catheter in through. The patient is awake. All we need to do is to put some local anesthesia around the groin. And then we take it up to the heart, and then we are able to look at if there's any blockage. Okay, of course you know that none of these things we are able to get from here, but thankfully to Medtronic, Mohammed and Oko, who have supported us. And you can see some of the blockages. We showed this yesterday, you remember? We showed these blockages yesterday and how we are able to stent it successfully. And so it's a simple procedure. Patients are able to go home the same day or next day after the procedure. If there is no blockage, they go home the next day. I mean the same day within 6 hours. If we use the wrist, they go home within 4 hours. And if there's a procedure done, we open a stent, we go home the next day. So that's better than open heart, and they don't have to travel all the way for a procedure that is done in 30 minutes or 1 hour in most cases. Sometimes the blockages may be too many or maybe too risky. In those cases, we do not intervene. So we stop and we refer for cardiac surgery. So if the blockage is too intervene, is too difficult, or is multiple, we typically refer for cardiac surgery in those cases. And by God's grace, we hope to start our cardiac surgery this year or in first month next year by the grace of God. And we will send you notifications so that you can celebrate with us. Northern Nigeria does not seem to have a regular place where you can send people for cardiac surgery. They do and come every day. And that's what we are hoping that we can accomplish in this place. Now, we've talked about pacing and pacemakers, CRTs. This is how the procedure is done. We put a local anesthetic just below the clavicle. We take a puncture to the axillary vein, subclavian or cephalic, and then through that puncture, we pass the leads into the heart. So we put one in the right ventricle and put one in the right atrium for normal pacemakers or for ICDs. And then for CRTs, we take another one into the coronary sinus around the left ventricle. And then we put it on the generator and put it under. This generator typically lasts between 11 to 13 years in terms of the battery life, and then we have to change it from time to time. So after that, we check the device, we program the device. Even people that have had the device elsewhere that need to be followed up or need to be interrogated, we're able to do that for them and then follow them up properly, because the device needs to be changing. Now, the device is also giving a constant record of what the heart ECG is like. So the ECG from the heart is called an EGM. So that's one that's gotten from inside the heart. It keeps a constant record of that together with the ECG, and we can go back and see what has been happening to the patient. Especially patients that are having syncope and all of that. When we find out that they need this, if you look in your jotter, you'll see when a patient needs a pacemaker. It's one of the, I think it's on page 36. Page 35 and 36 will tell you when a pacemaker, this is just one of the most common, there are other reasons, but these are the most common reasons why the patient will need a pacemaker. So we do that typically, it takes about 90 minutes, 60 minutes to 90 minutes, and we're able to close up and the patient goes home. The patient can go home the next day or in 2 days' time, typically. So this is what we have been doing in cardio care. So different indications, they are there in the book so that you can look at it. And then also for CRT. In heart failure, we talked about patients' ejection fraction is low and they remain symptomatic despite optimizing therapy. And there's QRS duration. We're going to talk about that later on. QRS duration is prolonged. We typically have to put in a CRT device, and you can see the device there, how we do that. And this dramatically changes patients' life. As in, from people that have not been able to walk from here to that table for months, as in literally from the next day, they start moving around, and in 2-3 months, you stop getting their phone calls. That is, they don't lead you until the next time they need interrogation. So that has been really fantastic. We've done a number of cases over the years. Now I'm going to talk about resuscitation, but I want to show you this particular case. This is a beautiful case that happened in cardio care. And luckily, our cardiac monitors keeps a record. Look at the ECG before. This is an ECG before. This is a PVC ECG before. And suddenly, you have that rhythm. Can you see the difference between this rhythm and this rhythm? Can we all see that? Very clearly. Well, that's what we're going to learn in ACLS. Once that happens, if you don't give a shock, and you can see the time. Can you see the time there? That was the time stamp. I had dozed off a bit. The other cardiologist was walking. Another person was walking. And luckily, members of the team picked it up immediately. Other people picked it up. We ran in. And then this kind of one, we don't need to wait for the machine to say, analyzing. Do not touch the patient. Right? You can read the ECG yourself. That's the whole idea. Because if you wait for that time, by the time you want to now finally shock, it will be too late. So we shocked the man. By this time, he had become unconscious. He had become unresponsive. And he was going. He was being managed for heart failure somewhere and saw our signboard and came in. And then we admitted him because he was very sick. And then he had this. And then we had to shock. And he came back to normal. Now, interesting thing about this man, about 52, when he now came back, he now said, why are all of us making noise? That's what he said. I was just looking at him like he don't know what has happened. As he was really complaining that, look, I don't like this kind of thing. You're disturbing me. Okay, so that's how dramatic when you do it well. So eventually we had to put an ICT for him because his reading was very bad. So we gave him drugs. In 3 days' time, we put an ICD for him, and he's fine. He's becoming for follow-up very well. Of course, that device now is treating actively. Sometimes it doesn't get to a shock. It does what we call anti-tachycardia pacing. It paces the heart faster than this, and then kills the rhythm, and then continues it so that it doesn't have to shock. And when that fails, it can now change to a shock. Okay, that's what the device in the heart looks like. Okay, and we've done quite a number of procedures, and Mohammed was talking about the peripheral. Now you can see where the blockage is for this patient. This is the tibia. That's where the blockage is, and then what we do is to put a stent there, do balloon angioplasty. You can see the balloon coming or blow. You just blow the thing. Then you put the stent across, and then once the stent is across, then blood supply can now flow very well to the leg. This is I think that's the anterior tibia. It looks like, and then blood supply can now flow, and it can help with gangrene. Can you see the before and after? So typically, this patient after a while will have had to do amputation, but afterward, 2 weeks after, you can see the dramatic recovery. It's not always like this. Some people come already, there's already blackness, there's almost maggot, there's nothing, we cannot raise the dead. Okay, so this is nothing. So what we advocate is that examine your patients regularly. Your patients with diabetes, especially smokers, examine them so that when it is still at this stage, it's darkened, it's ready, we can still open up and get good and recover the leg very well. Or sometimes we're able to recover it and the person can just do a ray amputation of just the toes, rather than having an above knee or below knee amputation, which is sometimes we're not able to even get that because after we restore it too late. But at least we can convert from above knee to below knee so that you can now attach a prosthesis. That knee is very important. So depending on how late they present, and the later they present, the more tricky, the more risky, and the more, the less, we don't get as dramatic results as possible. As well. This patient, if I remember, came from Gombe or somewhere like that. Okay, so approximately 50% of patients are, greater than 55 years of age, and the people have progressively worsened symptoms. The patients that need vascularization are critical limb ischemia. We did not talk about this this year. I think it's a little bit, maybe later we'll talk about that. But by the time you start seeing patients with claudication, that is when they walk some, they have some leg pain. They walk some distance, they have some leg pain. They run, they have leg. When they rest, the pain goes down. Please refer them. Sometimes the pain is coming from the buttocks going down, or the prime is in the calf, but most diseases are from the buttocks going down. Please refer them on time. Check their vessels, do a Doppler ultrasound of the foot, of the leg, and then refer them in time so that we can do any of these therapies. We've not yet started laser and cryoplasty. So some divisions that are very difficult, truly we're not able to, but we hope that in coming years we should be able to get that as well. But these other ones we do regularly. And similar process, we put the wire in there, it goes into through the vessel to the foot. Sometimes we have to do crossover, and then it goes in there till we get there, and then we put a balloon and a stent. Do the laser sometimes, and put your stent, and then you have blood supply. Blood supply is restored, and then the foot ulcer can now heal. So sometimes even for poorly healing wound ulcers, especially the vasculopathic ulcers, you can see before, put the balloon and the stent, and then afterwards, you can now see how it opens up nicely. So this is a man that has been having pain. He said he has been feeling something doing bing around his buttocks. But when we saw, you can see this aneurysm, you can see it is pumping, boom, boom. By the time he came, he already had gangrene, but at least we're able to identify that, open up the distal part, because there were a lot of clots inside here that were throwing clots down. So we opened up the clots distally and we're able to do that. And this is peripheral, this renal artery angiography, so that sometimes you have renal artery stenosis. And that is why you should always listen for renal bruit when patient comes with hypertension. I've picked one, I think, in a 38-year-old lady who came with hypertension. And if you pick it up, it's very important because potentially you can reverse that hypertension, and potentially you can prevent CKD from coming up too soon. This is the IVC filter Dr. Awufise was talking about. Who remembers? It looks like APC broom. You can see it there. That's what it looks like. So we put that into the IVC. Okay, we put that into the IVC. We've done about 4 or so. Put that into the IVC. One of them was a doctor, actually. Put that because he had clots. We could not give this thing. So we put that into the IVC. It traps all the clots there and stops it from going up. So that can be done. It doesn't take so much time. And we've had a case where we had to retrieve a catheter from the heart. So from one of the teaching hospitals in the south, there was a catheter put in for chemotherapy, a long catheter. And while they were trying to remove it after the chemotherapy, it cut and snapped and went in, and they couldn't get it out. So the option of cardiac surgery or all of that was just too much. So they sent down, patient flew in, and you can see the catheter there. Can you see it very clearly? That's our wire loop trying to get it from the femoral access. That's inside the atrium, the left atrium, right atrium, sorry. That's our wire loop trying to hook it up from the heart, and then we successfully brought it down. Can you see that? It's brought down. You can see it looped there. That is our wire having connected it, trying to come out. And then we've actually published this paper internationally and presented it at the West African College of Physicians, and then we're able to bring it out. That's the catheter from the patient's heart. As you can see, it was 27 centimeters long. Okay? Yes, thank God. So patient went home within 6 hours afterwards, and then checked into Hilton Presidential Suite for the next 5 days. So I think we charged too low. Apparently, a state government was sponsoring her. We did not know. We should have charged more than that. All right, fine. So just a little bit about cardio care. So this is who we are, and you can easily refer your patients. This team of consultants, residents, medical officers, nurses, a lot of beautiful people. Our nutritionist is there. Our cardiac physiologist is there. Our cath lab technician and manager is there. Beautiful people, different fields. There's a lot to learn. You can have opportunity to discuss and collaborate with us. Same day appointments for cold cases, 247 emergencies. So many cases we have done by the grace of God. And then that was the minister, the opening of it. And then you can always reach out to us. The first number here is the admin manager's number, so that can get you direct access. And then you can send WhatsApp or email. Please indicate, especially if you are sending a referral, it's good to send your details so that we can send you a referral feedback. So if we have your WhatsApp, for example, as soon as we see the patient, we'll do whatever procedure, we can send you a detailed feedback. This is what happened, this is what happened. And you can use that to improve, so that if you say, this patient has stroke, and then the patient comes and we say he had heart failure, or, and so many other things. So that way you look at it and then we'll send to you. Then when we are sending back the patient to you, we'll also tell you the things that you need to be checking, and follow up. And then you have a number to reach back in case you don't hear from us and you want to have access and say, this patient I sent, I want to get some information about that. Okay, so thank you for joining us to improve healthcare for Nigerians. And in northern Nigeria, we are here. That is Professor Adebayo from Ife. That is Dr. Officer and myself in the cath lab when we're signing the MOU for training of residents from Ife. So thank you very much. And I think we'll go to the next thing. Are there any questions? All right. I'm the next one. Dr. Aladeko, please join me. So we are going to ECG. Please have they eaten? Because the ECG will take some energy from their body. Okay, let's stretch our legs for 5 minutes. 5 minutes. I'll give you 5 minutes to stretch your legs so that you can your brain needs to be open. You cannot work without with another open brain. 5 minutes. Make a WhatsApp call. Post on Facebook, Instagram. Tag us at CardioCare. Tag us at CardioCare at ACS 2022. There's water at the back. are they giving the breakfast? Breakfast is being shared. Please, for those for CME, for your CME points, please make sure that you put the correct name while you're registering. And if you have not put down your name, please check and put it down properly so that we have your correct name. If you did not put down your email address, you will not be able to get the slides also. Okay, and the slides will be very helpful. For those of you in private practice, it will help you to be able to put some things in place so that you can arrange some things properly for your administration. Yes, the last slide too is there. Yeah. Yeah.
right, please, can we have our seats? Can those outside come in? We're about to start the session for the ECG. Please, let's sit down. All right, so we'll be inviting Doctors Iseko and Dr. Lalekon to kick off the ECG session. Please, let's make them welcome.
All right, let's come back in. Let's come back in. Sorry. Let's come back in. Let's settle down. Our guarantees, by the grace of God, you will learn ECG today by fire, by force. Physiotherapist, nurse, dietitian, even the sound person will learn how to read ECG. If you pay attention, and I'll use them as our, yes. We have, if you were here last year, we have further simplified it a little bit this year, so that no matter what, and then I'm sure next year we'll further simplify it.
By next year, we will be building on it. So maybe we can be going to...
Please listen, though. There are some doctors that are calling us from Japa. That please, oh, doctor, I beg, that's it. Can you please give us time? And please listen, oh. By then it's too late. When you come with that one, you will pay me in dollars. All right, are we all seated? Are we ready? Are we ready? So Dr. Alekon is here with me. My name is Dr. Iseko. Dr. Alekon. We work with Cardio Care and Limi Hospitals, Abuja, here. And we are glad to bring you ECG in 90 minutes. ECG in 90 minutes. Hopefully we don't need extra time. But ECG, by the way, when is World Cup? Is it today? It's today, Abi? Fine, great. So ECG in 90 minutes. All right. Let's call everybody in, because there are some things that once you miss, it's all, you will not understand again. Can I have my slides? Okay, so basic ECG interpretation. So I want to let you know that if you go to our YouTube channel, there are about 2 different teachings on ECG that me and him did together from the previous years. You can go and rewatch it again. And we did a recent webinar too, that is also there. And this one that we're recording will also be there for you to rewatch again and again. But for you to understand ECG, don't say that the slides are coming. If you don't write, you will not understand it. No, because, so, you must write. So that is why we gave you a book and a pen. We gave you a book and a functioning pen. You must write. If you don't write, then nobody can say that I violated advertising commission. What is it? That I gave false advertising. Because if you don't write, you will not learn. I don't care who you are. You must read. You read ECG today. Okay, so lights guy, you are going to be my. I want to use somebody that is not a medical person at all. The last time I used Pamela, I want to use somebody that is not medical at all, that can prove to me that we can read ECG. See our dietitian there, she can read ECG. Cynthia, come and take the lectures. All right, so number 1, believe that you can read an ECG. That's the first thing. Number 2, you need to get a pen and a paper and you must write. No shortcuts. If you are not writing, forget it. Number 3, you need to practice, and you will see that there's an ECG workbook in your jotter. There's an ECG workbook in your jotter. We're going to practice it. Maybe I should publish it as a full book. And in your jotter too, you see an ECG reading algorithm. Is it there? There should be an algorithm for reading ECG. It's in your folder. Check in your folder. There's a big paper that says ECG algorithm. Yeah, yes. Thank you. So that one, you can have it handy and look at it again and again and again and again. Then, number 4, some things must be memorized. You write it down, we'll use it, and you must just keep them in your head. So there's no shortcut to this one. So let me not tell you that everything is easy. You can just read. No. If you cannot memorize some basic things, you will not be able to read an ECG. Okay? And by this time next year, I'm going to try it with my son, my 12-year-old son. I'm going to teach him ECG, and then just to prove that anybody can read ECG, and he will be a part of the advert. Okay? And then keep the understanding of the heart while interpreting the ECG. Very, very important. Okay, everybody seated. You have our basic rules. Hello? You have our basic rules. If you don't keep to these rules, I'm not the one at fault. If you keep to these rules, you will read ECG today. Confidently. So ECG is good because it's recording electrical activity of the heart. It is cheap. It is widely available. Okay, like I said yesterday, you don't need so much money to do it. Almost all hospitals should have it. If your hospital does not have, how many hospitals don't have ECG? You don't have? Kai. Oh my God. What a pity, baby. You must get an ECG. You must get an ECG. Now, there are several reasons why you must get an ECG. Number 1, it saves patients' lives. Number 2, it is cheap. You cannot manage hypertension, diabetes without it. Now, people pay for it. You get money. It's a win for the patient. You get to practice. When you do ECG, you get to practice. You learn better. It's a win for you. The patient pay money. It's a win for the hospital. So it's a win all round. Do you understand? And unlike lab tests or whatever, ECG does not have much consumables. Just paper or gel. That is all. So you will do again and again. So revenue-wise, hospital, win. Patient-wise, good healthcare, win. Your own experience-wise, win. Why don't you have an ECG? So if you want to make a case to your medical director, tell them this one, that this is how much money we can make. Abi? They will answer you in your hand. Don't say, Oga. So, what else again? Also, it's useful for non-electrolyte derangements. So, waiting the lines means self. How many people have always thought that ECG is jaga? Everybody? There was one of my friends that said if they ask me ECG in final part 2, he would just tell them, don't worry, I'll come back. Now, he's not going to read it. He's not going to try to learn it. If they ask him, he will keep on coming back. That he's not learning, that's beyond him. But I can tell you that it's not beyond you. So this is what it means. This is now you have to pay attention. It has this P wave, Q wave, Q, R, S, and T. P, Q, R, S, and T. Once you understand this, you understand ECG. It's like I play the piano. Once you understand the 8 notes, you can play the piano. So this is P, Q, R, S, and T. That is the entire end of ECG. Once you understand this, you understand ECG. What you are now looking at again is what does that mean? First of all, okay, so that's P, Q, R, S, and T. Now I'm going to give a very important definition that you need to know. The P wave is the first positive deflection on the ECG. The Q wave is the first negative deflection after the P wave. You need to remember that. I will tell you why it's important later. So there are some things I told you that you must know. These basic definitions is what differentiates people reading ECGs. The Q wave is the first negative deflection. So if there is something small that goes up before the Q wave comes up, it's no longer a Q wave. It must be the first deflection that is negative after a P wave. That is the Q wave.
And maybe I should quickly add, this thick black line is what is called the isoelectric line. Anything above it is a positive deflection. Anything under it is a negative deflection. So that's why he's talking about first positive deflection, first negative deflection. So anything above that line is positive. Anything below it is a negative deflection.
Okay. Are we all clear? Any question? This is not simple. Anybody can tell up and down now. Now this strip we are looking at now like this, is it predominantly facing up or predominantly facing down? Up. So we say this is positive. Sometimes it's predominantly facing down. We'll say that is negative. You can read ECG now. Come, let me give you certificates, cardiologist. All right. So the next important thing now is knowing what stands for what. The first part of this ECG is when the atrium is depolarizing. So the electrical activity goes around the atrium, it depolarizes or gets charged. Let me use charged, and then it contracts. You need to remember this. When ECG gets jaga, this thing I'm telling you is what you're going to use to solve that problem. That's why I'm taking it step by step. The atrium gets charged, that's equals to the P wave. After the atrium gets charged, there is a delay called a PR segment. It's a delay at the AV node in between the atrium and the ventricle. Atrium, Abi, you want to know atrium? I will know ventricle, Abi. In between the atrium, so atrium gets blood, pumps it into the ventricle, ventricle gets blood and pumps it to the blood body. Not so? Good. Now, so that the ventricle does not get electrical activity scattered, the AV node will tell everybody to wait, like customs. Collect everything together, and then take it down to the ventricle through one pathway. Okay, now, no? If you don't have this delay, there will be problem. If the delay is too long, there will be problem. If the delay is too short, people will start looking for boycotts. Some people will not wait again. They will jump it, and there will be problem. Okay? So this delay is very important, this PR segment. The next one we are seeing is the QRS. The QRS is when the ventricle is getting charged also to pump. And the last one is when the ventricle is coming back to normalcy. And then the process starts again. Are we all together? No,
So-
we're not together.
So P wave is when the atrium is getting charged or contracting. That is what we see in number 1, number 2. Then after that, we have that short delay for all the parts of the atrium to get charged and for all the electrical activity to come to that point before it moves down to the ventricle. That is the PR segment. Then you now have your 4, 5, 6. That is the QRS. That is for the ventricle to get charged and contract. Then the T wave is when the ventricle is now relaxing. That is the old ECG tracing for you.
Any questions? Ask. Just raise your hand. If you don't understand it, I'll go right again. If you don't understand it from here, we're going to have problem going down. Don't worry. Nobody will laugh. Just raise your hand. Yes.
P is for the atrium. The PR segment is for that time waiting in the AV node before the impulses move down to the ventricle. The QRS is ventricle. QRST is the ventricle.
So P wave, it goes round. PR, waiting here. QRS goes round. T wave, it is getting itself back to prepare for another one again. Okay? I think it's clear now. So before we start getting complex, let's just understand this. Okay, so should I bother about this too much?
Let's go. We'll talk about this later.
Okay. So another way of looking at the lines is that each line also represents a part of the heart. And they come in groups. This is one of the things you must cram. So write it down. You must remember this grouping. Okay? Just like we have G5 governors. This is how the grouping is. Uh-huh. So this is how the grouping is. One person cannot be saying something. All of them must be saying the same thing at the same time. Do you understand? If we find ST segment elevation in only lead 2, we don't find it in 3 and F. Something is wrong. That person is lying. So at least 2 people from any of these groups must talk for you all to agree that something is going wrong. Do you understand? At the voice of 2 witnesses, a matter is confirmed. That is the ECG here. We need at least 2 people in any of these segments. Once 2 of them come together and agree on a matter, we say that is what it is. So you need to remember this one. Inferior is what? 2, lead 2, lead 3, and AVF. Lateral is 1, AVL, V5 and V6. 1, AVL, V5 and V6. Anteroseptal is V1 to V4. Okay? These are the basics. We are not yet started reading ECG. Once you understand this one, Shikena, the rest is just toying around with this. Go try, Sha. Do we all understand? Do you all understand? This is beautiful. Any question? Anybody not understand anything here? It's just straightforward. Just remember these groupings and then we'll use them later. Okay, so basic ECG template. Like I said, we have summarized it. Before we used to have a 10-step process here. We have reduced it further this time to 6. So identify the name and the calibration. Occasionally, patients are referred or seen with the wrong ECG. Heart attack, wrong patient's ECG. The heart attack person, you allow him to go home. The other person in front of you doesn't have anything. You are terrorizing their life. Always check the name. Cross-check the name. Cross-check the calibration, whether it is too fast or too slow. So cross-check that. So identify the ECG number 1. Number 1, let me just go through it. Number 2, rhythm and P waves. Number 3, QRS. Number 4, ST segment. Number 5, Q wave. Number 6, T wave. Just exactly what we have learned. P, QRS, ST, Q, and T. Where? What did we leave out? We did not talk about PR segments, but no, let's leave it for now.
And other segments.
Okay, and other segments. This is simplified. Now, some of you have learned something before, and you're arguing with me in your mind. Keep all those highfalutin stuff. Just learn what I'm saying. At the end of this one, when you understand my own, then now bring back your own. For now, just imagine you don't know. The people that learn ECG the best are the people that have no idea at all. Once you begin to overthink it, problem. Just follow what I'm teaching now. Don't think of anything high. I've removed the one that you don't. These are the ones you need for your practice. The other one, axis, all those kind of things, leave it alone. And let us be using it to eat bread. So, number 1, identify the ECG. Check the correct name on the ECG. Check the speed and calibration. This is always written at the bottom of every ECG. Check the speed and the calibration. Check the correct name. This is very simple. Check. Okay? Is there anybody like that? Where did I get that name from? Then number 2, check the rate. Okay? For the rate, that's the rate is simple. What do we do for the rate, Dr. Aliko?
Okay. For the rate, if you look at your ECG, you will see that the ECG, the tracing, you have small, tiny boxes, and you have 5 of that to make a big box. So when you want to calculate the rate, there are 2 formulas you can use, and that's why we said there are some formulas we must have at the back of our mind. And when you want to calculate the 2 formula, the number 1 is, if you are using the big box, that is the one that has 5 tiny ones inside, is 300 over the number of big boxes between 2 R waves. At least that is why we started from identifying the PQRS complex. So here, we are making use of our R waves. So what you want to do is look at the number of big boxes between two successive R waves. So it will be 300 over the number of big boxes between two successive R waves. That is number one. So if you want to use that, let's use that one alone so that we don't make things complex. So if you want to do that one, if we're starting from this first one, these two R waves, if you can see well from your side, it looks as if there is, how many? It's just one.
One box. One.
So if you say 300 over 1, so for this one, it is 300 beats per minute.
So if you have a good patient monitor, it will calculate it for you. But occasionally it may be wrong. Or it may be calculating the pulse rate, which may not match what is happening in the heart. So the heart can be going 150, 300, and people are just using pulse oximeter and writing something. So you should be able to look at it. Once you see one box, some people even cram it. One box is 300. Two boxes, 150. Three boxes, 100. 4, 75. 5, 60.
Using that formula. 300 over the number of big boxes between two successive R waves. With that, you have gotten your heart rates.
Is that easy? Any problems? If you have a problem, just raise up your hand. I'll go over it again. Okay, some people have problems. Okay, I need microphone around so that I can understand the problem. But what you do is look at the R wave. Can you see this one R wave? Remember PQR? Can you see the R wave? From the peak of this R wave to the peak of this R wave, how many boxes are there? 1, 2, 3. 300 divided by 3 is equals to 100. That is what it is. Is that clear? You have another question?
Somebody want to ask a question?
Please ask. Now, what do we come here for?
Okay, I actually lost it when you were talking about the initial number of boxes. I don't know if you can come over that again.
What is the initial number of boxes?
From the first one, you said two successive R waves.
Okay, so what he said is, look at just follow what I'm saying now. This is the R wave. This is the R wave. So that means two successive R waves. Count the number of boxes between them.
Between the two of them.
And then 300 divided by the number of boxes between them. That's all. Once you see two boxes in between them, you are talking about 150. You are likely in trouble. That's when we go to ACLS. So when we go to ACLS, we are going to use all of these things because you are going to read it and know what to do. Okay? You will not be doing MP at that time. Yes, please.
What if the boxes don't fit perfectly? What if we have like outliers? Do we also count them that have like smaller squares? Maybe 2 or
what I always advise is, if you look at your ECG very well, you will always see one that falls within those boxes. So it makes it easier for you to just use that. And like we said, if I get 85, you got 83, 84, 87. It doesn't mean anything.
Okay, sometimes you can have 2.5. It can be 300 divided by 2.5. Okay, so you likely get about the same thing. Okay, let's give an example.
Somebody is also
okay. Yes, please. Whenever
Thank
enter the
you.
middle.
How about using the rhythm strip? Since it's a 10-second strip, so you count the number of QRS complexes.
Just stay here for now.
We are trying to make it very
Leave
simple.
all those ones. Now, waiting the people know they remember ECG with that. This methodology is what we have used to cut down all the things that you don't need. This is the one that you will use and eat bread. Some of you will go and start signing ECG now to 2,000 naira a pop. This is the one, straightforward. Okay, fine. So let's look at this one. Can somebody tell us the rates? Can somebody tell us the rates? Yes. Yes. Yes, please. Somebody is there.
According to the ECG, the
The only one that according, just say the rates.
150.
150. Are you a politician? 150, Abi? Yes, so we can see two boxes there. 1, 2. You can find one. You always find one that lands on the one. So that is like here now. Can we see that? Between two of them, 150, about 150. You see this one, your nurse should know this is a red flag. This is not the one you just continue, you say you're handing over and you go. No, 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 no. This is a red flag. The next thing you will hear is that patient has gone. Okay, people don't just die. Okay? Yes, are there any questions? Easy, Abby? Very easy. Don't worry, I'm coming. I'm coming. We will soon start getting less easy. What about this one? Yes. I'll start picking people. Though. This man with a very nice face cap. Please bring cap. He wants to say something. Abi, you want to say something? Yes, thank you. Just try.
So 60.
60? How did you arrive at 60?
Let's say from where?
1, 2, 3, 4, 5, 6.
And small.
6 and small. 300 divided by 6?
6.
50. So
if you say 50,
48.
if some people use 40 something.
48, 50, now be more correct. I mean, are we all together?
Yeah.
Is it not simple?
Yes.
What are we talking about before now? What about, is it the same one? Has it moved?
It's the same thing.
Okay, so next, rhythm and the P wave. Rhythm and the P wave. Very simple, rhythm and the P wave. Now, for this one, we ask ourselves 5 questions. You have to write this formula. You ask yourself 5 questions. Okay? Anybody that is writing? Is there any of the non-medical people that are writing? Vastovas, are you writing, or Codex? I have a gift for you. Are you writing? I'll test whether you understand, just to be sure. All right. So you ask yourself these 5 questions. Number 1, are the RR intervals regular? That is the distance between each of them. Are they the same? Number 2, is the P wave upright in lead 2 and inverted in AVR? Number 3 question, are all the QRS preceded by a P wave? And then does every P wave have a QRS after it? It looks like the same thing, Abi. Like P before QRS or QRS after P. Is it not the same thing? It's not the same thing. Don't worry. When we get to difficulties, you will know the meaning of these questions. And number 5, are all the P waves alike? Do they look alike? Okay? Simple. Hello? Hello? What do we mean by upright P wave? Is this P wave upright or facing downwards? Upright. So shaking, huh? Dr. Oladekun, I didn't do it. We have many cardiologists in the room. Okay. Bagam. Yes?
I think people are still writing.
Oh, okay, I still writing.
So it's when you have all this fulfilled that you can say
Sinus.
the rhythm is a normal sinus rhythm. So
this is where you are checking your P wave now. Leave other highfalutin things, just focus on this one for now. RR regular, P wave upright in 2 and inverted in AVR, QRS before P wave. QRS, there's a P wave before QRS, and every P wave has a QRS after it, and then do they all look alike? Okay, we have to move. Ain't got all day. So is this sinus? Is this sinus rhythm? Yes. Somebody.
using the criteria.
See her now, see her with the very nice Ankara pink. Yes, with glasses. She's about to talk. Yes. You have not followed my hand, man. That's okay. Well, she also has pink. You can give her, she will talk.
So all the P waves are regular. Okay, there's a P
Number
before
1,
every
is
R.
there, what's number 1?
Upright P wave.
RR, are they all similar?
Yes.
So this RR here, between here and here and here and here, is it about equal distance?
Yes.
Yes, good. So number 2 question?
The P waves are upright in lead 2.
Upright in lead 2 and inverted AVR. Are they? Is
Yes.
it? Number 3?
Number 3, all QRS are preceded by a P wave.
So you look at this rhythm strip on the ground. Every QRS that you see, is there a P wave before it?
Yes.
Good. Number 4?
Then all P waves have a QRS.
For every
complex
P wave,
after
is there a
it.
QRS after it?
Yes.
Can we all see? And then number 5?
All P waves similar and normal.
Do they all look similar and normal?
Yes.
What is that?
A normal sinus.
Sign your name. 2K there. All right. Are we all together? What's the question? Give her mic. Raise your hand so he can find you.
Sorry, sir. I want to know what is this AVR?
Okay. We have gone too far. This is lead 1, lead 2, lead 3. Okay? The leads we put on the right leg, left leg. Then these are augmented leads. This is lead 1, lead 2, lead 3. This is lead AVR, AVL, and AVF. And this is V1, V2, V3, V4, V5, V6.
That's just, we talk about 12 lead ECG. You have 6 precordial leads from V1 to V6. Then you have your augmented limb lead and the limb lead that is gotten from spatial arrangement between those things you put on the patient's hands and leg. So you have 6 limb leads and you have 6 chest leads. That's what gives you the 12 leads ECG. So the AVR we're talking about is one of the augmented limb leads.
So on the ECG, you have 12 leads. All of them are looking in different directions. That's why we said you needed 3 looking in one direction to be able to tell you about something about the heart. So now we're looking at AVR. This P wave now, is it facing downward or upwards? Downwards, correct. That is what we expect. For lead 2, is it facing upward or downward? Upward, that is what we expect. So that's what we mean by, that's the AVR lead. Okay? Any other question? Yes, please.
Always negative.
Yes, typically. Okay. If it's positive, there are 2 things that could happen. Well, the main thing is that you put the leads wrongly. Maybe you put right hand on left hand or right leg on left leg. So anytime you see AVR completely facing up, number 1 is that you put it the wrong way, or number 2, it could be a posterior problem.
Or sometimes maybe dextrocardia.
Or dextrocardia. The heart is placed in a different direction. But more often than not, once you see it looking normally like this, very likely that the person put the hands like this, or the heart is moved to one direction or the other. Okay? Are we all together? Is it not simple? The place is getting quiet too. Don't fall my hand though. Now we are going to the next one. Sinus rhythm or not? Yes. I need a taker. I need somebody. Quick. I'm wasting time. Quick. Yes, okay. Fine. Her friend. She pointed to her friend. Call a friend.
The RR intervals are not the same.
Really? These RR intervals, are they not the same? Okay, yeah, you're right. So. I'm too close to the screen here. Okay. What else?
But the P wave is upward in lead 2 and downward inverted in AVR.
Where is the P wave? Where did
you can see the P wave.
Is there any P wave here at all?
There is no P wave on lead 2.
Aha.
Neither can I see on AVR 2.
So you cannot see any P wave here. There's no P wave here.
Yes.
Okay. Say again.
Occasionally.
Look at lead 2 again. Look through any P wave. What we are seeing here, there's a P wave actually here. A small P wave that is merged with it was not a normal P wave. This is T. This is QRST, 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 QRST. No P wave.
So one of the criteria is gone now.
So automatically this is not sinus rhythm. 2. That means QRS are there and there are no P waves. Okay? And then we cannot see any P waves. And it's irregular. And even when the one that we saw that looks like query a P wave is deformed. So This is not a sinus rhythm. What rhythm is this? It's on your sheet. What rhythm is this? It's called an atrial fibrillation. Whenever you have an irregular RR interval, you need to write this one. You need to keep it down. Keep it. Because you don't pick this one, the patient is coming to a stroke. You don't pick this one, that patient will never come out of heart failure. Like someone will ask about someone not having heart failure. This may be there. So you don't pick this one, you don't treat it, the patient is not coming out of heart failure. So that is what we are seeing there.
There's no P wave, and the RR interval is not regular. So
Good.
that's atrial fibrillation.
We have to move fast now. Yes, sinus rhythm or not? Sinus rhythm or not? The man with glasses there, just by your side. Yes, yes, yes. He looks very serious. Yes, in front of you. No, in front of you. Yes, he looks very serious. Go ahead.
It's not sinus rhythm.
Really? Why?
Although the RR intervals are normal, the P waves, there's the QT interval isn't.
Simple. Number one. What question one?
The RR intervals.
Are they
frequent.
equal?
Yes.
Good. Number two.
P waves.
P waves. Are they upright in lead 2?
Yes.
Are they upside down in lead AVR?
They're also upright in AVR.
No, they're upside down. See it now.
Okay, sorry, they're upside down in AVR.
Correct. So number 2, number 3.
P before.
Are they before the QRS complex?
Is there every QRS has a P before it? Is that correct?
Yes.
Yes.
After every P wave, is there a QRS?
Yes.
Yes.
Do all the P waves look alike?
Yes.
Eh?
Yes.
Which one?
They look alike.
They all look alike. They are all the same. Sinus rhythm.
Don't look at whether the shape of the QRS is abnormal. What we're talking about now is
I know you are looking at this one. I'm
sinus,
looking at this one.
a sinus rhythm. And the rhythm is coming from the SA node. That is all we are looking out for now. So it's a sinus rhythm. The fact that it's a sinus rhythm does not mean that the ECG will be normal at the end of the day. Don't let's get it.
Are we okay with this? Anybody have a problem with this? I should go over again. I should go over it again. Go through your questions. Question number 1. RR interval, are they equal? They are equal. Forget anything you know, and just follow this basic rule. Number 2 question, Dr. Lodibia, Dr. Olaleko, maybe, and Dr. Aofiswe, maybe you should stand there in case there are some questions that you are too afraid to ask. You can just answer them quietly. Okay, so number 2 question is
P wave upright in lead 2.
Upright.
Inverted in AVR.
Is it inverted here? Can you see the P wave? Is it inverted? Good. Number 3.
QRS preceded by P wave.
Every QRS, is there a P wave before it? Every P wave, is there a QRS after it? Do all the P waves look alike?
The morphology, the shape.
Okay, now. Normal sinus rhythm. Is that clear now? Is that clear now? Just follow it like this, jelly. Don't forget anything you've learned before. This one is what you will use now. Okay? Anybody not understand again? Let's get it hot in here. Yes.
Okay, my question is, I noticed that when you were checking the QRS complexes, whether they are preceded by a P wave, you were checking the lower.
Yes, so this is what we call it.
So is that what we are supposed to check and not consider the other?
So this is what we call a rhythm strip. You can see it's long and together. While these other ones, they are cut short. You just have a short segment, a short segment. So you use your rhythm strip to see the entire period so that you can be sure about the rhythm or not.
Easier for you to follow a longer reading than just
number
a short.
2 thing, use lead 2 you use to check P waves. Please write that down. I think I forgot to say that. Lead 2 and lead V1 and V2. Those are the ones you use to check your P wave. You want to check whether your P wave is good or not. Whatever it is, look at lead 2 and lead. The other ones, P wave might be hidden somewhere. Look at this V2. Can you see P wave there? V2, can you see P wave there? Not really. So you cannot pick, but if you look at lead 2, you can see it. So that is where you focus on when you want to check the reading. And you see your reading typically is lead 2 automatically from your machine.
It's usually under like this, and you can use that to.
Now some of us have those small ECG machines that print small strip. Even after it prints, there will be one that will be long. that you will use to check the reading? Thank you very much for that question. We'll update it in our updates and make it better. All right, let's get it hot. How did they say? How that song? Let's get it started in here. All right, who's going to answer this for me? Where is my... Pick the person in front of you. Pick the person in front of you. Pick anybody you like or you don't like. Yes, sir. Sinus reading or not?
It's not.
Why?
Why?
The RR is not, the interval is not.
It's not equal, correct?
It's not equal.
What are the P wave in lead 2? This place is...
There is P wave in lead 2.
There's P wave in lead 2?
Yes.
Is it upright in lead 2?
It's upright.
In AVR, is it upside down?
Yes.
Okay. Now, are all the P waves, is there a QRS after them? After all the P waves?
Not all.
Huh?
Not all.
Which P waves have QRS? All P waves have QRS. See one P wave here? It has QRS. All the P wave QRS, P wave QRS, P wave QRS, P wave QRS. Can we see that?
Yes.
Okay. Now the next question, which is the question that I will now give the answer. Do all the P waves look alike?
No, they don't.
This one is different. This is the original. This one is a way match. Okay? Can we see that?
Yes.
This one is different. This one is correct from the proper place. Can you see that? So, what we have is an ectopic atrial reading. Another SA node, some people call it one SA node, another place in the heart is also generating its own impulse. So after the normal one does, another place does. That is why it's not a sinus reading. Do you understand that? Hello?
So just know that this is not
sinus.
A normal sinus reading.
Once you answer your questions, it's not sinus, it's not sinus. Is that simple? Thank you. Anybody that is still burning them, that's the thing getting hard though. Okay, fine. I want us to know this. If it's not regular, it could be either fast or slow, and there are no P waves. We call that atrial fibrillation. You need to write this one down. Remember I told you, you've written atrial fibrillation before, Abi? You need to write it down. Anytime you have irregular RR interval, please, Dr. Ilodibia is there, Dr. Aofiso is there. In case you have a question that you're too shy, just call them, they will explain it to you quietly in your seat. Where are my other doctors now? Where is Dr. Abdulkadir, Dr. Anya, Dr. Ajibola? Where are they? All right. Okay, so now, if you have multiple P waves, that is, you have P wave, no QRS, P wave, no QRS, P wave, no QRS before you have QRS. We call that atrial flutter.
So what we're saying is, if you look at your P wave, and you can't find a P wave, and the interval between the RR waves are not regular, that patient has atrial fibrillation like the ECG we saw earlier. Then you can have ECG where, like we said, that P wave must be before QRS, but you can have occasion where what you have is multiple P waves before you see a QRS, and the RR intervals are regular. That is what we call atrial flutter. I think we will limit that for now. Before we'll come back and talk about the others as we proceed. So let's look at this.
What reading is this? Is this
so what
normal?
do we have here?
Is this normal? Come to this side, come to this side. You have used those people too much before they hate you. Come. Yes, give her. Thank you. Go ahead.
It's still using the same basic.
It's your turn to shine, 2022.
Still basic.
The camera is focusing on you. You are international now. It's on YouTube. It's on Zoom. All right, give her a friend next to her. Let her call a friend. Good. Thank you very much.
So still using the same criteria.
Okay, the RR intervals are regular.
Okay, thank you.
The P wave is negative in
Lead 2.
Okay. In AVR,
Positive.
Is that correct? Is that normal?
that is not normal.
What do we expect normally? Positive in lead 2 and negative
in
in
AVR.
AVR. That already tells you not sinus. Abi?
So number 3,
Are all complexes preceded by a P wave?
All the QRS, is there a P wave before
it.
Yes.
Good. Then the next question,
Is there a P wave?
is there a QRS after every
Is there a
Every P
QRS
wave.
after every
Is that true?
Huh?
If you are not sure, look at V1. In V1, you will see your P wave very well. So all those are P waves. So what you have is you have multiple P waves before QRS complex. And like I said on the table we showed earlier, I said if you have multiple P waves with regular RR interval, that is what is called atrial flutter. And if you look at it, the V1, it looks like the mouth of a saw. And that is why they call it a sawtooth appearance.
So you can look here, you can see one P wave here, one P wave here, one P wave here,
And
one P wave here, before it now had a QRS. Can we see that? Sometimes people miss that, even us cardiologists, sometimes you can miss it. Treating somebody with heart failure, it can be so subtle. If you miss it, that person will not. So when somebody is not getting better, you need to go back again, like a medical student, and just be going through these simple questions. You'll be going through them one by one and find what you missed. And that will just change the day for you. Okay, so this is atrial flutter. All right. Sign it there. Good afternoon, sir. I'm so sorry. I made a diagnosis. Sorry. All right, I'm joking. Yes, who can help with this one?
So the basic principle first.
Okay, he likes you. Please. Go ahead, go ahead. It's your turn to shine. Don't worry, I know it's hard. We will not hold you for it. Do you know the funny thing? These things are happening in your practices. I want you to try it out because it's happening there. You may not have put ECG monitor on your patients, or you are doing surgery. You started doing surgery, it is there on the monitor. You don't take notes. Next thing you say, sorry, something happened. You don't even know what happened. The remote control. There's no remote control. This is the remote control. Can we see that here? Can somebody try, please? Can somebody try? Give somebody to try. Just try. Quickly. We don't have time. Everybody is dodging the microphone. Thank you. You need to contest. Go ahead.
Okay.
P wave in lead 2. R interval, they equal?
There are interval. They look.
What is the rate here? A little bit, yes. A little bit more than
very
150.
high, yeah, very high.
Yes.
There is no obvious P wave.
There is no obvious P wave.
On lead 2.
There are P waves there, but
see this small P wave. Can you see this small P wave?
Yes, okay.
Can we see that? Yes, there's a small P wave before QRS.
P wave, QRS, T, P, QRS, T.
Can
It's
you see
because
that?
of the rate.
It's because the rate is very fast. Look at it now. So ECG they be. So I don't leave here tomorrow and say they taught me that they brought the real one. I could not read it again. We are going to read ECG here tired. So don't get. This is the only way you learn it. And if you finish from here, you go to your center, gather ECGs, and read again. Take another 50. Anyone you have problem, post it on the WhatsApp group. Give your interpretation and we'll help you correct. For the next 1 week, just be posting ECGs that you have tried. We will help you correct it. After that, that's all. Okay, the last thing. Catch any group of people that you have control over, even your children, and start teaching them. Once you teach a set of people, you will never forget it. That's how I learned ECG. Okay? So, go ahead now.
Okay.
P wave is there, is regular. P wave is there before every QRS. What again?
In AVR, the P wave is inverted. So there is in AVR, lead AVR.
Okay. Difficult to see. Continue.
Yeah. Then there is P wave before every complex.
Okay.
So this is a sinus rhythm. A
From your
sinus-
first principle,
Yeah.
as in, before you say something is a sinus rhythm, you should also, don't forget, maybe we didn't have that one, you should also look at the rates too. Because your rate already is above
150.
the normal average. So, because of the heart rate, it's a sinus rhythm, but it's not a normal sinus rhythm. Overlooking other things, you can say sinus tachycardia, but that is not what this patient has. But we don't want to. This patient has a ventricular tachycardia, but don't let's make it complex. Yes, but if we look at our basic principle plus the rate, you can say this patient has a sinus tachycardia, but this is an ECG of a patient with ventricular tachycardia.
Let me make it a little bit simpler. Anytime you have an ECG at 150 and above, anytime you have an ECG 150 and above, check the QRS duration. If the QRS is wide like this, that is more this QRS. Can you see the QRS duration? It starts from one box and it crosses one big box. QRS is supposed to be less than half a box, half a big box. Write that down. QRS must be less than half a big box. So once you have a very fast heart rate, you should ask yourself, is this narrow complex or wide complex? In this case, this is a wide complex regular tachycardia. Are we okay? It fulfills the criteria for sinus rhythm, yes, but it is a wide complex regular tachycardia. And there are different things you do. This is an emergency.
Let's go back to our table. So back to our table. You know we stopped here. Now, we're jumping to the number 4 there, which we call the ventricular tachycardia. The one we looked at last, the RR interval was regular. The rate was fast because it was greater than 100. P waves, because of the fast nature, that was why it was difficult for you to see the P wave, but the P waves were there. So depending on how fast the rhythm is, most of the time you will not see the P wave because it will be buried inside something. Then the QRS appearance, you said it is wide and it looked bizarre. So what do you have is a ventricular tachycardia, and we said it is a medical emergency. And that is why everybody must be able to identify this morphology.
This thing must be in your mind. I think, is it there on your ECG sheet? Is there something like it on your ECG sheet? Ventricular tachycardia, is it there?
I think it's maybe inside the book.
Yes, ventricular tachycardia is there. You need to keep it. You need to keep it. It's going to show up on your monitor. It's going to show up while you are doing surgery, while you are delivering babies. It's going to show up. And if you don't attend to it, that person, you're going to lose that patient. It will show up. It has been there. Sometimes you can enter a hospital ward and it's there and people are just sitting down. Then when the patient now stops, everybody starts running. No, you must notice this. So that thing, you must keep it. Paste it around your hospital if necessary. You must keep it. It's not something that you need to look at it again and again and again. Okay? All right. Let's get it harder. Let me jump this one. I think we didn't do this one time too. Step 4, QRS. QRS duration. So we'll come to the QRS. And for the QRS, we remember that QRS is for what? What does QRS represent? Ventricular depolarization, when it charges the ventricle and the ventricle contracts. So the QRS should be less than 3 small boxes. That is less than half a big box. That is narrow. And every time it is broad, greater than 3 small boxes, greater than half a box, like I wrote down, that means is broad. If it is fast, we say that is a wide complex tachycardia. You need to know this one, though. It's going to be very important in your ACLS. I know we are getting more complex and everything, but, you know, this is how the ECG is. No shortcuts. Just be writing. When we start applying it, you will see how it is. Okay? Typically, anytime you have two shots, we say they have small complexes. And when you have it very big, that's when you have ventricular hypertrophy. So if you have more than 5 big boxes in any of the limb leads, or any of the chest leads, where the right limb lead? Any of the chest lead.
If it is in the limb leads, that is 1, 2, 3, AVR, AVF, AV. If the height of the QRS, if it is less than 5 millimeter, that is, if the height is less than 1 big box, then the amplitude is small. That means the height is low. So you can call that low amplitude. And when you look at the V1 to V6, if it is less than 2 boxes, the big one, then you can say the patient has a low amplitude. That is what we mean by height. Height and amplitudes are the same. So if you look at 1 AVF, 1 to AVF, if the height is less than 1 box, the amplitude is low. If you go to V1 to V6, if it is less than 2 boxes, then the amplitude is low. So for this one now, from V1 to V6, the height of the R wave is fine.
Can we see that? See the height of the amplitude here. 1 box, 2 box, 3, that's fine. If it were less than 2 boxes, we'll say the amplitude is low. Maybe there's pericardial effusion, maybe there's a problem.
Or the patient is obese.
Or the patient is very fat. So that is what you look at.
Then
in the limb leads, if it is less than 1 box, we'll say the amplitude is low. Low voltage complexes are important because it shows that the heart muscle may not have enough electrical activity, like NEPA. Okay? Very low. Okay? Now, what else do we say about QRS? We said the duration. What about this QRS? Is this normal?
Hello? In terms of duration. Is this normal? Let's look at the QRS
What
complex.
do we say the normal duration is? Less than half of a big box, Abi. So this one, is it less than half of a big box? It starts from here. Let's look at this one. Started from here, and it ended here. Is that what? That's a big box now.
Yes.
Is that less than half? That is much more than half. That's 1 full big box. Look at this one here too. It started from here, and it ended here. That is 1 full big box, Abi. In fact, it ended somewhere here.
So this is a broad, complex QRS. So if you
Any
have
questions?
tachycardia with this,
ask. If it's not clear, you just raise your hand. I'll go over it again. It's not clear? Okay, fine. So look at the QRS duration. The QRS is when the thing goes up and down. From the point it starts going up and down. Let me look for one that is on a line. This one. From the point it starts going up and down to the point it comes back to the line. Is from here to here.
That's the old QRS.
That is 1 big box. A normal QRS complex should have stopped halfway.
Halfway. Normal should not be more than half of that big box. So once it is more than that.
Look at a normal one here. Is this normal?
Let's go back a bit. This one.
Okay. Then the one that starts from a line. Okay, here. Can you see this one here? It starts here and it stops here. Can you see that?
So this is a
Can
normal
you see that?
QRS complex.
You can't see it. Sorry, you can't see it. There's a TV screen near somewhere there, halfway in the line. You can look at, maybe that's clearer. Let me show you again.
Dr. Ludwig,
Dr. Ludwig, if you're nearby, maybe you can just open the book. The people at the back there. You can just open the book and show them. See, it starts from this line and see where it ends. Just halfway. And from the big box, from here to here. And this QRS stopped less than half. That's the normal QRS. Are we all together? Beautiful. It's simple. Don't worry, we are coming. We are coming. So let's look at this ECG again. What's the rate of this ECG? Rate. We talked about it already now. 75. Okay. What's the reading? Huh? Sinus reading. Uh-huh. Then, what else did we say again?
So the
QRS.
normal QRS complex.
The QRS complex normal. Is there any QRS complex that is more than 5 boxes? No. Okay. Now we're going to go a little bit deeper in this QRS business. The next one we're going to do in the QRS is to find out if there is hypertrophy. If there is hypertrophy, right ventricular or left ventricular hypertrophy, you need to write this. We're going to use it. Let's go back to that same ECG. Just stay there. No, before this one. Yes. So on this one, to find out whether it is normal, once this V1 is facing upwards, what direction is it facing now? Down. If V1 is facing upwards, we say that is right ventricular hypertrophy. Please write that down. V1 facing upwards, right ventricular hypertrophy. Is that not simple? You can tell what is up and what is down now. It's just for you to remember. Who doesn't understand? You don't understand? I don't understand. Save me. Okay, fine. V1 facing down, normal. V1 facing up, right ventricular hypertrophy. Now, hypertension most times has left ventricular hypertrophy. If you check, let's have one that has V2 facing the other way. Good. If you check this number, how many boxes is this? How many big boxes is that? Is this S wave? How many big boxes is that? Maybe 2? Almost 2. You come to V5 and V6 and look at the R wave. How many boxes is that? 1, 2, Abi?
3.
Okay, I'm too close to this thing. 3. 3 plus 2 is what? 5. When it is 7 or more, we say there is left ventricular hypertrophy. When you add this S wave in V1 or V2, the number of big boxes to the S wave, to the R wave
in V5 or 6.
In V5 or V6, if it is more than 7 big boxes, we say there is left ventricular hypertrophy. I don't understand. You don't understand. What don't you understand? Which part? In V1 or V2, the part that is facing down, measure what number of big boxes is facing down. Get the longest one. That's the S wave. In V5 or V6, the R wave, that's the part that is facing up. Get the one that is the tallest and measure the number of big boxes. When you add number of big boxes here, plus number of big boxes here facing down, if it is more than 7 or more, we say there is left ventricular hypertrophy. I think that's simple. Yes? I still don't understand. Focus on me. Write later. Just understand this now. I don't understand. You don't understand. Which part don't you understand?
Oh, the left ventricular hypertrophy.
Okay, so left ventricular hypertrophy. Right ventricular hypertrophy is simple. If V1 is facing up, it's right, Abi. In left ventricular hypertrophy, check this V1 or V2, look for the longest S wave. When you find the longest S wave, count how many big boxes there are. Come to V5 or V6, look for the tallest R wave. R wave is the one facing up. Count how many big boxes there are. Add the number of big boxes from here to here. Okay? How many votes you have in the north and the south? If the votes are more than 35, you win. Left ventricular hypertrophy. If they're not to 35, you lose. Normal usage. 7.
He's saying 35 because inside one box there are 5 votes inside. So 5 times 7 is 35. But let's just do 7 boxes, big boxes.
Is that clear now? Good, beautiful. We can move. One more person. Again. Huh? V1.
V1.
For right ventricular hypertrophy, just look at V1. Just look at V1. If the V1 is facing up, right ventricular hypertrophy. Ready? Once the V1 is facing up, so you bring somebody that is breathless, rush to your hospital, and you did an ECG, and you saw the V1 facing up, right ventricular hypertrophy. Maybe there is pulmonary hypertension, pulmonary embolism, something like that. You can make, before you start doing D-dimer, all the rest, that already should tell you what's happening there. Now, the blood pressure is high, you're not sure, you want to check whether you want to give AC inhibitors. Now, go to it and count. How many big boxes? Look at the ones facing down in V1 or V2. Get the longest one. 1, 2.5. Come here. 1, 2, 3. The one facing up in V5. Look at the longest one. 1, 2, 3. Add them up. 5.5 is not up to 7. Means it's normal. It's likely to be normal. If it is 7 and above, the heart muscle is ticking. Left ventricular hypertrophy. Okay, we are moving forward. The rest of you, in the dream, it will be revealed to you. Okay, but don't worry. As we continue asking more questions, you're going to understand it. Yes, please.
Sorry, sir, please. I'm taking us back to the QRS complex. Just clarification. Did you say the QRS complexes in the precordial limbs are taller?
Yes. Yes.
Okay.
Precordial limbs are close to the heart, so they'll be taller.
Okay, so 2 big boxes.
Yes.
Then for the limb leads,
one
big box. Thank you, sir.
Those ones are further away from the heart. So the next thing we want you to go back, please. The next thing we look at this QRS again is a bundle branch block. Why is a bundle branch block important? A bundle branch block is important because a left bundle branch block may be the only thing you find in somebody that has an MI. We talked yesterday about ST elevation, Abi. Who remembers? Talk about ST elevation. Some people don't have ST elevation. All they will come with is a left bundle branch block. If you are doing USMLE, you'll be familiar with this acronym. And I don't think you can even practice as a nurse outside this country without understanding ECG. In this country, I think it should be a law too. You should not be able to practice without learning ECG. Anybody. Okay? So, once we have this deep RS wave, what we call W, in V1, and an M-like wave in V6, we say that is a left bundle branch block. That's why we have this acronym, William. W in V1 and M in V6. When we have it the other way, an M in V1 and W or a big V in V6, we call that a right bundle branch block. Again, the QRS complex will look jaga-jaga like this. It will not look like the normal QRS complex. That jaga-jaga in V1 and V6, we use that to define whether that is left or right bundle branch block. In the right bundle branch block, in V1, it will be M shape. Can you see M shape? In right bundle branch block. That's it there. That's in V1. While in V6, it will be W shape. Sometimes not full W, it's just one U. It's not a double U. Okay? We call that left bundle branch, a right bundle branch, a left bundle branch block. If somebody comes with chest pain, and this is the ECG you see, that person is having a myocardial infarction until proven otherwise. You need to get a troponin immediately. Don't send the patient home. Don't give them a referral and say, see cardiologist in 2 weeks' time. No. You need to keep that patient and do all necessary things. You will lose that patient. Okay? So can you go to the next slide, sir? Real life. Don't worry, you'll get it now with real life. Real life, look at this ECG. Is the QRS duration normal? Yes? Who said no? Yes.
No.
Why do you say no?
Yeah, is the QRS complex is up to 1 big box.
It's up to 1 big box, so it's prolonged.
Yeah.
Meaning there's a problem in the conduction. Now in V1, is that QRS looking normal? V1, V2, is it looking normal? In V1.
In V1.
This is V1.
Yeah, it's normal. It's half.
V1, this is V1 now.
Okay, V1. Sorry. No, it's up to one big box.
It's up to one big box. Does it look normal? Forget the duration now.
No, it's not normal.
What does it look like?
Yes, there is an M there.
Correct.
Okay.
RSR, we call it. It's perfect.
Yeah.
You know the technical term. But we just call it M. M like this. Abi?
Yes.
Correct. M in V1. Where do we go again? We look to V6. Do we have anything that looks like a U or a W here?
Yes.
So what kind of bundle branch block is this? Right bundle branch block. Check your paper. Check your paper. What did you write?
Marrow.
Right, marrow. M in V1, W in V6. If you switch, it would have been left bundle branch block. Apo, for those that speak Idoma. Inanapa, Igbo, Kunaji. Yetibo. Sorry, I don't remember Fulani and Igbira. Okay, fine. Any questions so far? Questions? Let's go on. As we go, we will continue to move on. I think I've done that one. And then step 5, ST segments. ST segment, we are finished. Now we are going to just do practical. We are finished. And you will see how easy it is. Okay.
So ST segment, we're looking at that line between the T wave and the end of the QRS complex. And what we're looking for is whether that line or whether that line is still on that horizontal line or is either above or below. So if it is above what you are looking at, that is when we say there is ST segment elevation. If it is low, below that isoelectric line, we talk about ST segment depression. And this is important because, like we talked about chest pain yesterday, chest pain in the presence of abnormality of that ST segment is very, very important. That is what is going to help you to know whether your patient is having pericarditis or whether your patient is having heart attack. So like I said, that line is what we're interested in. Let's go ahead, the next slide. And so we've seen the line, and you may want to trace that line to join your P wave so that you will know, because that ST line will not be there. You will still need another reference. So you can extend that ST line to the next P wave to be able to identify what the isoelectric line is. Then you now move to B. In B, the line is supposed to be here, but it is here now. So that is ST segment depression. We can see that. The J point we are pointing to, that is the end of the KRS complex and the beginning of that line. So you can see that that point is down. And the whole of the ST line is down, and also dragging part of the T wave along with it. Then C, you can see now that it is now above that isoelectric line. So C is ST segment elevation, while B is ST segment depression. That is all you need to know about that.
Hello? Are we together? Not yet. I've started losing some people. Just take a deep breath. In and out. This is the meat. We are getting to the meat of it. ST segment elevation and ST segment depression. If you have chest pain and you have ST segment elevation or depression, what you are dealing with is an ischemic heart disease. Hello?
You have blanked us out.
All right. All right. Let's leave down when we are doing the. Is there any question about the elevation and depression?
Okay, we can. This one.
Any question about elevation and depression? While you are fixing that, can we look at page 45? Page 45. Okay, go ahead, sir.
Thank you very much. So I just wanted you to clarify where you would have like something that sometimes cardiologists talk about having normal variants in V1, V2, or benign early repolarization. How you wouldn't consider that as actually a significant ST change?
We're just trying to wait for the screen to come out so that we'll be able to see the pattern.
I think you can manage to see the benign here.
Okay, the benign is there. So when we talked about, first of all, we want us to be able to identify the depression and the elevation. Then when you now talk about the elevation, we're talking about looking at the J points and also looking at the shape of that elevation. In the benign early repolarization changes, the J point is still on that isoelectric line, while the remaining part of the ST segment might be elevated. So that is like a normal variant you can see in young adults, and it is not pathological. But in others, you look out for the J point. The J point moves either up or down. So that one, you know, this one, there's issue here, there's a pathology that you need to identify. So you can have benign early repolarization changes where you have in young adults, especially maybe tall, thin individual, you can see those ST segment changes. And another thing I will give it away is if it is related to heart attack, like we look at the ECG looking at different area, you see those changes in a specific area. But for the benign repolarization changes, it's going to be generalized. It's not going to be restricted to a certain part. So what do you have here? So like you said, the J point is still around the isoelectric line, and you have the whole other area elevated. But for the other one, look at the J point for this. Look at that, and that's what you have in.
I think I'll just leave it behind. Let's not confuse everybody.
So we just don't want to go to all those details so that we don't get things complicated.
Do we understand depression and elevation? ST segment is depressed in B, is elevated in C. Do we understand that? Beautiful. Now, this is now where we bring back this thing. That depression or elevation, it must happen in at least 2 contiguous leads. You remember how we wrote this one before? Check your notes where you wrote this one. It must happen in at least 2. If you find only 1, you are not talking. You are not yet talking. If you find only 1 bit, that is all the bits were there, just 1 bit went up a bit, leave that one alone. It must be in almost all the bits, and it must be in at least 2 leads. It cannot be in lead 1 and lead 2. Why? They are not related. They are not part of the G5. Okay? Only lead 1, only the people among the G5 can talk together. 2, 3 AVF are together. V1, V2 are together. V3, V4 are together. 1 AVL, V5, V6 are together. Do you understand? They must be together. 2 of them must agree concerning this elevation or depression. Are we together? Let's look at this ECG. Number 1, what's the rate? Rate? Yes, ma. What's the rate? 75. Okay. What's the next thing again?
Is this sinus rhythm?
Is this sinus rhythm? Give her.
Yes, it is.
Yes, it's a sinus rhythm.
Okay, fine.
Yeah,
QRS.
There's a P wave before.
QRS.
It's
The QRS, is it normal?
It's normal.
Is it wide?
No, it's normal.
Okay. So
QRS is normal. ST segment.
ST segment, any abnormality in the ST segment?
Yes.
Where?
It's elevated.
Where?
Where?
looking at V3.
Eh?
AVF.
AVF. If you see in AVF, where else
Should
will
you
you
check?
check? Check your book. Check your book. You wrote it down.
That is why you
2
have-
and 3.
So you look at those areas.
Lead 2 now. Is it elevated?
Yes.
Lead 3
Lead
come?
3?
Yes, it's elevated.
At the voice of 3 witnesses.
A
So
testimony is
in
established.
which area is this now?
The 2-3 AVF.
What do we call it?
Inferior.
Yes.
Inferior. So this is an inferior ST elevation.
MI.
Or you sign your name, cardiologist. You made the diagnosis.
So this patient has inferior ST elevated myocardial
I remember
infarction.
this man. He was very fit, slim guy. 2016. Slim guy. Nothing, no hypertension, no diabetes. This was all that was there. Some chest pain, and he rushed him to the hospital. Okay? Inferior ST segment elevation MI. Can we all see this one? Very easy to make a diagnosis. Okay. The next part of it now, the other segment. We'll look at the PR segment, which is depressing pericarditis, but you hardly ever use the PR segment. So this PR segment, can you see the PR segment? Sometimes it goes down. You have the S elevation, and then you have PR segment going down. That could happen next. The one I want you to see now is the Q wave. Should we bother about Q wave? I think we should. It's called Q wave MI. Who remembers the definition we said about Q wave? First
deflection.
negative deflection after a P wave. First negative deflection after a P wave. Remember this. Okay? So, the depth of the Q wave must be at least 25% of the R wave, English. P, Q, R. That Q wave that came down must be at least 1/4 of the height of the other one. A. Hello? People are getting quiet. The hall is getting quiet. Did they bring lunch? This Q wave is like ST elevation. It must also happen in contiguous leads. Hello? If you have somebody coming with chest pain and has Q wave, that is a significant Q wave that is deep or wide in contiguous leads. That person is also likely having an end-stage MI, a non-ST segment elevation MI, or has had an MI before, or they are still having a MI currently ongoing. Let's look at this. I remember this person. It's an Indian lady. An Indian lady. Yes, that was 2016. Yes, 2017. Anybody? Any takers? You pick somebody. They are not coming. Good. How can you wear suit like that? Answer. You are wearing suits. Remember, I give you mic, make you teach. Just go ahead. Answer.
So what is the heart rate?
Just try. What is the heart rate? Anytime you see ECG, don't be afraid. Just follow what I have taught you.
What is the heart rate?
100.
100, good.
Beautiful.
What is the rhythm? All of you should be trying. Say it out near your table.
Sinus rhythm.
Sinus rhythm, good. QRS.
Wide. Normal.
Wide.
Okay,
yes.
no, it's
Slightly
normal.
wide, normal. It's about
It's
half.
normal.
It's about
It's
half.
It's
normal.
about half. Okay.
Yeah, it's normal.
Fine. ST segment.
ST segment.
Elevated.
Where? That's the
3.
next question.
Huh?
Where?
Elevated in limb 3.
3.
Okay,
Very
no.
small.
Very small. We have
Okay.
other obvious ones in other places. Look at the whole ECG.
Look at the whole ECG. This is why you must have a 12 lead
Whole
ECG.
ECG.
You cannot use all that one on the monitor and we say there's no
V2.
segment elevation. You must do a 12 lead ECG to
It's
see
look at
elevated in
everything.
V2.
Lead what?
V2.
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 If it's elevated in V2, which other one is the brother of V2? Open
Two.
your book. Open your book. Everybody open your book.
V1.
V1.
Okay, so check V1.
It's just elevated there.
Yes.
Correct. Where else is it
Where
elevated?
else?
V3.
Where
Where's
is-
the brother of V3?
V4.
Is it in V4 too?
Yes.
Okay.
Slightly.
Beautiful. So what kind of MI do you have here?
Anterior
Anteroceptor.
Elevated MI. Okay. So, Q wave. Is there any Q wave here?
Are there any Q waves here? What do we define as Q wave again? This is why you remember that definition.
So, do we have Q wave here?
This one you have a P wave. There's a small R wave here, Abi.
So the next
no
one
Q
is
wave.
S.
What about here?
In V1, V2.
In V1, this is a P wave. Is there a first negative depression there? Hello, is there anything going up after this Q?
After this P wave?
No, so what is this? Q. This is the first negative deflection after the P wave. You can see why I said you write that one before. When it starts getting hot, those things you wrote down are going to save you. In V2, remember I was saying in V2, Q wave again. Sometimes, if this patient does not come to hospital in time, let's say they come after 2 weeks, they've drank everything, everything. And they finally say, okay, let them try your hospital. And they hear that you are very good. That you delivered triplets the other day. Then you now did ECG. By then, this S elevation may have come down. But these Q waves will still be there. That will give you the telltale sign. This is why you must remember, you will still need to do the troponin for that patient. And you will still need to intervene for that patient. Otherwise, that patient will die. No be joke. If they don't die then, they will die within 1 year or 2 years. Hello? Hello? Well, don't answer me now.
So the pattern you have there is what we call a QS waves. There's no R wave there. So all you have is just negative deflection. So you have the first one and you have the second negative. So the one that should go up is not there. So it's a QS wave. So that's what you have down up to V5 for this patient.
I remember this patient, a 52-year-old, 58-year-old Indian citizen, I think, married to a Nigerian man, and then they came, we had this ECG, we managed conservatively. They refused to do anything in Nigeria. They went to India, and just like we said, all the vessels were blocked. They refused surgery as well. They wanted something divine. Unfortunately, it was not to be. So I remember the name I remember the name. One of my first patients. All right, so you don't joke with it. She died within 2 months or so. You don't joke with it. All right, so T wave. Finally, T wave. The main thing you're looking for in T wave is whether it is negative or positive. Whether it is negative or positive. Whether it is negative or positive. All right, in this ECG, can somebody read this ECG for me? Give somebody. Thank you. Yes, go ahead, go ahead. What's the rate? All of you be trying it. You keep on trying, that's how you know.
It's 100.
100, correct? What's the reading?
It's sinus reading.
Sinus reading. Can you not see you are flowing? Yes? What do you notice next?
The QRS.
Yes? Is it QRS?
It's normal.
Is it really normal? Is it really normal? What about the height of the QRS?
Okay. It's long, it's true.
How long? Is there a left or right ventricular hypertrophy? What do we say for left ventricular hypertrophy? Do you remember?
The left.
Yes.
The V1 needs to be
V1 or V2. So let's calculate this one. 1,
okay, no,
2, 3, 4. Come here again.
B6.
Let's calculate it. 5, 6, 7, and small. So it's 7 and above. So that is what?
Left
ventricular hypertrophy. Now, ST segment.
Are they all on the vertical line?
ST segment. Remember the ST segment? This is the T wave. Yeah. This is the ST segment. Are they all on the same line? Look through all the entire ECG. Talk.
If you say no, where are you looking at?
If you say there's ST elevation, tell us. If you say there's depression, tell us. Yes?
Where? V6.
Huh?
Okay.
I didn't hear her. What did you say? Talk now,
There
don't
is
be afraid.
ST depression in V6.
In V6.
V6.
Yeah.
Where is the brother of V6?
V5.
V5. There's not much there, but there's
Yes.
ST depression in V6.
Yes.
So, because it's not too clear, what else? Q wave, any Q wave?
Any Q wave? If you say yes, where is the next question? So you have to look at everywhere and make sure there is no positive deflection after your P wave.
This is the real meat. After this one, now you are a star.
V4 and V5, are you sure?
Can you see
After the P wave, there's something going up now.
So it's not the first deflection, Abi? Is it the first
The
deflection?
first deflection is a positive deflection.
So cancel.
There's no Q
That
wave
failed
there.
this thing.
So there's no Q wave on this ECG. Even if you look here, you can still see something small before the negative deflection.
Yeah.
So there's no Q wave here. So T wave.
T wave. They have finished now. Where she are? Don't run. You never finish. You have not assigned your name. Give her to finish now. You have not assigned her name. You came for ACS 2022.
T wave. Any T wave abnormality?
Eh?
Someone said lead 1. So what happened to the T wave in lead 1?
Remember T wave, we're looking, is it facing up or is it facing down? Normally it should face up except in AVR.
Yes.
So in lead 1, is it facing up or facing down? Facing down. Where is the brother of lead 1? AVL.
AVL.
Is he facing up or facing down? Down. Where is the brother of 1 and AVL?
V5 and V6.
Is he facing up or facing down?
Down.
V6, is he facing up or facing down?
Down.
Oh, no.
So you put there the T wave inversion
In what leads are 1 AVL V5? V6? Check what you wrote down. Lateral.
So there's T wave inversion in lateral leads.
That tells you there's something wrong with that muscle. Most times it's ischemia. Hello? It's not looking simple. We are finished. We are finished. Again, let's remind ourselves. Identify the name, ECG, and rate. I forgot that. The rate, the name, calibration, and the rate. Next, rhythm and P waves. Next, QRS. Next, SC segment and other segments. Next, Q waves. Next, T waves. Shikena for now.
Just making it simple. There may be other things.
There are plenty other things.
This is just simplified step to start. And you can now build on this subsequently.
All right. Now, let's start answering more ECGs. Yes, can anybody try? I think we've done this ECG already. Okay. Can somebody try this? Pick, quickly. Just pick anybody. Thank you, sir. Please go ahead. Go ahead. Give her. Okay, just answer. What's the rate?
75.
75, correct. What's the reading?
The sinus reading.
Sinus reading, correct. You see, you are doing it. What's next?
QRS.
QRS, is it prolonged? The duration, is it prolonged? Is it more than is it up to one big box? Is it more than one half of a big box?
It's not normal.
It's normal. Okay, what about the height? Yes?
It's normal.
It's normal. What about in V1? Is it facing up or facing down?
It's facing down.
Facing down, is that normal or not?
Normal.
Normal. Can I ST segment? ST segment, look at all of them. Here, is it normal? ST segment.
It's normal.
Normal. Anyone that is facing up or down, none. All right. Q wave. Any Q wave? None. Correct. T wave. Anyone facing down, except this AVR facing down is normal. Anyone facing down in all the T waves?
Normal. Normal.
Check. There is one facing down.
Looking down in V1, but it's
most
usually normal.
Most times it's normally facing down in V1. And in children, it's also facing down in V1. So, what is your final diagnosis?
Normal ECG.
Normal ECG. You sign your name. Member, sign, came for ACS 2022. Can you not see? Oh, you can do it. See, you were afraid before. Let's go to another one. Yes. Good. Thank you, ma. Go ahead. What's the rate, ma? Go ahead. Go. What's the rate?
Oh. Let me see. Excuse me, I can't see you.
We will read ECGs today. Tire. When you are dreaming, you just be seeing ECG like this.
60 beats per minute. 60. It's normal.
Based on what?
How did you arrive at 60?
The first 1, 2, 3, 4, 5. The first lead one.
Which first one? Is it this one? 1, 2, 3, 4, or this one? 1, 2, 3, 4, 5, or this one?
No, the lead one.
Okay.
1, 2, 3,
Look
4,
at your
5.
strip here now.
For your rate, it is always better to use the long reading strip for your rate, for your rhythm.
Okay. 1, 2, 3. That's 100.
Is it fairly regular or very regular or
Not
irregular?
It's irregular. It's irregular.
Is it irregular?
Yes.
So what you do when it's irregular, just find the average of the boxes that you are seeing. So this first one is about 6 boxes, Abi.
Yes.
This one is 5. This one is 4. This one is 4, maybe 4, 4, 4, 5, 6. So average about 5, Abi.
Yes, that's 60.
300 divided by 6 by 5 is what? 60. Uh-huh. Is this sinus rhythm?
Let me see.
Why is it not sinus rhythm?
Oh, I didn't say. I'm not answering this.
Okay, is this sinus rhythm? Whatever you say, I will ask you why.
Okay. Let me see. Sinus rhythm.
Question number 1. Is the P wave in lead 2 facing upwards? Have you done the first one?
Yes. Is the RR interval
equal?
Are they equal?
No, they're not equal.
They are not equal, so it's not sinus.
That's number 1.
Number 2, P wave. Is it facing up?
P wave in lead 2, is it up?
Yes, there's a P wave there.
Where?
In AVR, can you identify the P wave in lead 2?
There's a P wave there. Like first.
This is Ali and Angel. Where?
Is it this one?
No, that one, yes.
Yeah.
Or this one?
No, the one right before.
This QRS.
Oh, okay.
QRS. Can you see any P wave? Anybody? No P wave.
But if you check V1, you will see P wave
In
there.
V1, are you seeing P waves?
Yes. Okay.
So you have multiple
P waves. When you have multiple P waves, atrial flutter. But in this case, it's not regular. Okay, so normally atrial flutter may be regular, but in this case, it's not regular. So what's the rhythm here? Say it. I want you to say it.
It's
atrial flutter.
Atrial flutter.
Say it boldly.
Atrial flutter.
So that if you want to collect your money, we'll collect it. Hey, you're not finished. Is that all? You're not finished ECG now. What next?
That's QRS complex.
QRS complex.
Okay.
Look at it. Don't worry. Don't be afraid. Is it wide?
Yes, it's wide.
It starts from here. Yes, it starts here. It's a little bit wide. Yes, it's a little bit wide. So slightly wide, but not too much. Just slightly.
The height?
What of the height?
1, 2, 3. It's abnormal.
What is it? V1, is it facing up?
No.
So there's no right ventricular hypertrophy, Abi?
Yes.
What of left ventricular hypertrophy? Any?
1, 2.
Are you sure?
4.
1, 2,
No,
3.
there's none. I don't think.
1,
it's 5.
4, 5, 6. Okay. 4, 5, 6, 7. Yeah. If you do V2 plus V5, you will get 7.
Okay. Which is
okay. So what do you call that?
Okay. Left ventricular hypertrophy.
Left ventricular hypertrophy. Yes. What next? ST segment. ST segment. Oh yeah. The patient came with chest pain. They came to you. They heard it just came from ACS, and they don't want to come and pay Dr. Iseko. So they have to come to you.
There's one in V6.
Where?
V6. Elevation.
V6. This is the ST segment here.
It looks almost.
And this is the normal one. It's on the same line.
Almost on the same line.
Okay. Yes.
I think that's the only V6.
What?
V6.
V2, V3.
V2, V3. Okay.
V2.
There is slight, but if you look at it really, this is the J point. Now, that question he asked about benign early depolarization. Most times, benign early depolarization will happen in V2, V3. And it is convex upwards. So it is going up like this. It is in only V2 and V3. You will not see it V1, V2. These ones, are they brothers? V2 and V3, are they brothers? No.
It's V1,
V1 and
V2.
V2, V3, V4. So that's another way you can know that this is benign. Who was asking that question? Yeah, that's another way you can know that this is benign early repolarization. But it's not really benign, but it's there. Okay, so let's leave it. Q wave, any Q wave? Oh yeah, now.
Q wave.
No Q wave.
False negative deflection in QRS complex.
Any Q wave? No Q wave. Just say it. Don't worry.
Okay.
Don't be afraid of it being wrong. T wave. Anyone facing downwards? Any T wave facing upside down?
No.
Talk. Have you checked everywhere? What about this one?
In lead 3.
Is that a T wave? Okay.
This is your QRS. This is your T wave.
Okay.
This is your QRS. This is your T wave.
Okay.
So where else will you check?
Where else will you check if lead 3 has T wave?
We check
Lead 2 and
AVF.
AVF. Lead 2 is flat, more or less.
Okay,
And in AVF
is
down. Also down. So you have T wave abnormality in what set of leads?
Inferior leads.
Inferior. You wrote it down before now. Did you write it down?
Yes, I have.
So you wrote it inferior leads. Okay. So now let's summarize. What are the main abnormalities you found here now? Number 1.
Atrial flutter.
Atrial flutter is
Number 2.
LVH.
Left ventricular hypertrophy also.
Oh, yes.
Number 3.
And then
T wave inversion.
T wave abnormalities in
inferior leads.
Inferior leads.
3 and AVF. All right. So thank you.
Thank you very much. All right. Are we okay to continue? Let's go to our book. That one is close to you so that you will not say, this is now real. All these ECGs are from cardio care. We have our library has maybe over 20,000 ECGs now. So there's no ECG. I'm not sure there's any ECG in the world we have not seen. So where do we start from? Page 40. ECG for all workbook. Page 40. Dr. Ofisoya and Dr. Olaleko is there. Dr. Miriam too. Dr. Inuwa is there. So we have 3 consultants around. If you need to draw them to your book that you need something you don't understand, please do that. So let's answer this one. Use your biro and answer by the side of your book. Everybody try. We are doing our exam now.
Just fill the rate, redeem, and P wave, QRS, ST segment, QT, then your final conclusion.
Yes, camera woman, what do you think? Is this normal? Okay. Correct.
Okay,
see,
the
camera woman
average.
said it's 100 beats per minute. Thank you very much. Yes. You can see CG is simple, Abi. What about the rhythm? Anybody? Say again. Normal sinus, Abi, you can see it in front of you there. What about the QRS?
The QRS.
The duration and then the height. Normal. ST segments. It's not easy to teach plenty of people like this. It's easier to teach just 10 people. If your organization wants us to come, then hey, we can come and do it in a smaller room and take maybe a full day on just ECGs. Okay. ST segments. Anybody? Normal, yes. T wave. Q. Any Q? There's a small Q in lead 3. But that Q is not up to 25% of the R wave. Can you see that? Look at Dr. Olaleko. It's not up to 25, so it's not a full Q. Remember, we talk about pathology Q. We put a definition, that's why it's not, we don't count it as anything. All right. T wave, any problems? None. What's the ECG? Normal. Sign your name. You are not sure? Call cardio care. All right. Let's go to the next page. Page 41. Yeah, 41. Oh yeah, let's answer. Let's answer. Quick. 100 per minute. Yes. Read him. Jude, find me somebody now. Good. Thank you, sir.
Normal.
The reading.
Sinus.
Sinus. Good. What about the QRS? The duration, is it okay?
It's okay, sir.
The height, is it okay?
Yes.
Yes. Are you sure? If you add V1, 1, 2, 3, plus V5, 1, 2, 3, 4 and a half. Add your V1 and your V5. How many big boxes? Okay. It's up to 7.5.
Yes, sir.
So that is what? Left ventricular hypertrophy. Sir, can you see it?
Yes.
Good. So you add the V1, the one facing down, and the V5 facing up. Add those two. So you are doing the highest between V1, V2, and V5, V6. You add it up.
It's more than 7.
It's more than 7. Good.
It is left ventricular hypertrophy.
Left ventricular hypertrophy. So write it down there. You know you are signing this ECG to go out from your hospital.
Yes, sir. Yes, sir.
ST segment. You never run. The patient came with chest pain now. ST segment. Any elevation or depression?
Let me see. This elevation.
Where?
V3.
Not really.
Not really. Okay. The elevation in the precordial list typically should be more than 2 small boxes. Okay. 2 very small boxes, but this is not up to even 1 small box. And then if it's in V3, you should also check V4. It's not there on V4.
It's not.
So it's only Wiki. He's on his own.
Yes, sir.
I bet Wiki and Agyoku. Yes.
Thank you, sir.
So what is the submission?
Q wave.
Q wave.
Don't run. Q wave. You have to finish it.
Q is normal.
Wicked's man is here. Dr. Dafe. Dr. Dafe is here from Port Harcourt.
It looks normal, the Q.
Q, no Q wave, okay. T wave, any T wave abnormality? Any T wave abnormality, look, and write it down.
Any T wave abnormality.
Look at all the leads. TCG is so simple, isn't it?
It's elevated in V3.
We're looking at the T wave now.
T wave. Is it facing up or facing down? T wave, all the T waves look fine, oh.
They look fine.
A little bit upside down in V1, Abi, and V2, slightly. So maybe septal is anterior lead. Fine, great.
So LVH in this patient, that would be a major submission, left ventricular hypertrophy.
All right. Let's move to the next one. Number 42. This is how you know ECG. You just keep on trying. Give us Nena. See her in front here in purple. Yes, with glasses. We're in extra time now.
1, 2, 3. Rate is 100.
Rate is what?
100.
100, fine. Reading?
There is P wave.
Reading, what's the reading? We're not past that level. We have entered this stage 2. Is the reading normal or not?
It's normal.
Normal sinus reading. Thank you.
QRS.
QRS.
Okay. QRS is normal.
It's normal. It's not too wide. It's not too high on any of them. Is the QRS really normal? Are you sure it's normal? Look at the limb leads. Look at the limb leads of the QRS. Are they up to one big box? Are they up to one big box?
No.
So you have, what do we call that one? Low voltages. So there are low voltages where? In the limb leads. This is a sign of an abnormality. It means the heart muscle is not getting enough current. NEPA. Right? Remember, I wrote it down before.
Yes.
If it's less than a big box, the QRS, all of them, they are less than a big box, then we say they are low limb voltages. So that QRS has a problem. So write that down there. ST segment.
ST segment.
ST segment, any major changes?
No.
Okay. We've done the Q wave.
Q wave. We've not done Q wave.
Q wave.
Yes.
Q waves. Okay, somebody is saying something.
This is a senatorial candidate that collapsed at a rally.
Q wave.
So Q waves.
The press are outside asking you what's happening.
Look at all the leads, the whole 12.
I'm coming.
Look at the chest leads.
This number.
Any Q wave, okay. Q wave is first negative deflection. Any negative deflection after a P wave?
Yes.
Where?
V1
and
V2, where again?
V3.
AVR, yes. Though it's normally upside
It's
down.
normally upside down in
there.
AVR.
So V1, V2,
V2,
V3.
V3.
T wave. T wave. Look at the same areas where you have problem already that are telling you that there's problem. Are there T wave inverted there?
Yes.
Yes. So what are you talking about here now? What's happening? Up to V4 self. V1 to V4. So what's the problem here?
So V1, V2, where is it looking at?
V1, V2, what you wrote down? What did you write down? V1, V2 looking at where? Septal. V3, V4 is looking at where? Anterior. So we can see Q waves here. If this person is coming with chest pain, this person likely has an MI or has had an MI before in this area. Okay, so he either has had an MI or still shouting, vote for me, or he's had an MI. You should do your troponins and you should send them to the cath lab ASAP. Okay, so you made the diagnosis now. What else is there? Is it the ECG simple, sir? Yes? It's not simple. Show me the one that is not simple. Just show me. Just prove me wrong. Choose any of these things that you think is not simple. Page 45. Let's do page 45. Page 45. Dr. Howard, nobody's asking any question, Abby. They are all getting it. They are either all getting it or they are all not getting it. Page 45.
So what's the rate? The rate is 100.
Rate is 100?
Yes.
Read him. Just sharp, move.
It's sinus.
Sinus.
Yes, sinus. Then
So the QRS.
QRS.
The voltages, are they normal?
The QRS duration, is it normal?
No.
Really?
The duration, look at it very well.
QRS.
The duration.
This box from here to here, Abby?
It's normal.
It's normal,
Yes.
also?
Yes.
Good.
The height.
The height far.
In the limb leads, are they normal?
No.
So it's a little bit more than
There's only one that is up to 5.
It's short.
This one is up to
Others
5.
are short.
Others are short, but it's up to 5. At least one is up to 5, so it might say lowish. Any other in ST segment?
Elevated.
Where?
Oh my God.
Where is the ST segment elevation?
V1 to V6.
Awesome. Awesome. This is what we call tombstone appearance. Tombstone. This is because to likely take the patient in the grave. But also you need to intervene ASAP. These are real life patients though. These are not cases from somewhere.
Is a 40-year-old hypertensive diabetic.
Oh.
Referred from FMC Jabi.
Okay.
Is 2 years, 6 months post PCI.
Oh.
Doing well.
Doing very well.
Usually.
Straight we put the stent in and the patient is fine. Thing came back down. Everything.
Usually comes in with malt and plantain chips to for everybody.
The guy is checking our own cholesterol, whether we too can get it. All right. So you saw that, Abi?
Yes.
Good. What else? Q wave.
Q waves.
Q wave. Is there any Q wave there? So when you're looking for a Q wave, look at the P wave. Then look before the next deflection. Is there the first deflection a negative one?
Yes.
Okay, so that's a Q wave, Abi?
Yes.
Where else are you seeing that kind of thing?
V2.
V2 is there, V3 is
V3
there,
is there.
V4 is there,
V5
V5 is there. These are the
6.
very extensive MI.
So anterior septal lateral. So extensive MI. T wave.
T wave. Eh? Inverted where? Talk now, talk. Don't worry.
V4, V5.
V4, V5. This is
V6.
one of these places, Uncle.
It's inverted from V1.
Okay. V1.
It's inverted too, Abi.
Oh, V1 to
all
V6.
the same areas too.
Also look at lead 1.
Lead 1 too is inverted. AVL 2 is inverted.
Inverted.
Very extensive MI. So put your sinus name. What's the diagnosis?
MI.
Extensive MI where?
Everywhere.
You can't say everywhere. You came for ACS. Anterior, septal, lateral. Call Dr. Eseko immediately. Call cardiologist immediately. Let's put a stent. Quickly to save this man's life. Okay? It's not easy. Let's do. This man works in telecoms. Page 44. Talk about old ECGs. Page 44. But also, you know this guy. He's on anticoagulation now. Yes? Yes, give that man. Good. No, the one with cap. Yes, sir. Awesome. You look like the governor of Borno State.
The rate is 60.
60, good.
Then
page 44. Is it 60? 1, 2, 3,
It's 4. This is 4.
Page 44. It's not 44. Yeah, it's 44 now. Page 44.
We have 4 boxes there.
It's clearer in your notebook.
1, 2, 3, 4. That's
75. Good.
75, yeah.
Read him.
Normal sinus.
Normal sinus. Awesome. QRS.
Normal.
If you don't understand anything in your book, just raise your hand. Because doctors are around, they will just come to you and help you. Dr. Okosoye,
The
please.
QRS is normal.
QRS is normal.
Yes.
Are you sure?
Yes, sir.
Are you sure? Are you really sure? Look again.
Yes.
V1. What do we say about V1? V1 should be facing up or down.
We said the R wave in V1. In V1, once the R wave is looking up,
What
that's
is wrong?
not normal.
Right ventricular hypertrophy. This is a young man. They sent him to my office and say hypertension or something. Once I just saw the CG, I said, There's something wrong there. The guy, he was hiding his history. When I told him, I felt like a prophet. Yes, what's there? Say it, sir. V1 facing up. What do we say? It is, check your book. You wrote it down.
Right ventricular hypertrophy.
Beautiful. Right ventricular hypertrophy is there. Okay? Any other thing? ST segment.
ST segment.
Is there anywhere where the S segment is up or down?
Where?
Where?
V2.
V2, yes. When you make it, you see one, look for the brothers immediately.
V3.
V3. What of this one, this brother? V1. What of this brother?
V4, yes.
Is lower now. V4. What of this one here? It's a little bit down. This one is normal. What of the T wave?
The T wave.
You will see that those things normally follow together because they are all signs of ischemia.
T wave.
T wave, is it up or facing up or down? Any T wave that is facing upside down?
Yes.
Yes? V1, Abi, is facing upside down, not facing up. What of the other ones? Here?
V2.
V2, where? Here? Where? Here? Good. So summarize what you have found so far in this ECG. The main abnormalities.
Left ventricular hypertrophy.
Left, not left.
Right.
Right.
Right ventricular hypertrophy.
ST segment, depression or elevation.
ST segment what?
Depression.
Depression where? V1 to V6. Abi?
Yes.
That is anterior, septal, and
lateral.
T wave inversion in the same areas, not so?
Yes.
You sign your name. Call the cardiologist. I made the diagnosis. Who taught you this? You came to ACS 2022. All right. I think we can stop here. Let's clap for ourselves. Please take a few minutes and go through some of the other ECGs so that we can help you through it. Take a few minutes and go through the ECGs by yourself. Go through it with the people on your table. Go through it with the people on your table. We will break for lunch and for those going to the mosque. And then we'll reconvene by 2:10 sharp. ACLS, if you miss the first slide, you have missed. I think 2:10 should be, mosque will be over by 2:10 now. 2:10 sharp, we start here. Lunch. Bring that food. That yesterday's food was very sweet. Those online, we will send your own. Just click food on the Zoom platform. If you have any questions, just raise your hand. Keep on trying. Raise your hand and somebody will come to you.
One that we did.
Eh?
The last ECG that we did.
This one? Which page?
44.
Okay, that's this one now.
Yes, right ventricular hypertrophy, depressed ST segment, depression V1 to V6. So with the right ventricular hypertrophy and the ischemia in the anteroceptal leads, so what are we thinking?
So in this case, when we see ST changes with the right ventricular hypertrophy in V1 and accompanying ST segment changes, what typically happens is that those changes are due to the strain on the right ventricle. The right ventricle has become hypertrophied, and it's now become so hypertrophied and strained that it's not getting enough blood supply. So it's not able to relax well before it contracts again. So most times when you see this kind of one, patient has a pulmonary embolism. You see a patient like this, think of a pulmonary embolism.
Okay.
Think of COPD, something that caused the right ventricle to be under so much pressure. Think of congenital heart disease.
All right, thank you.
Thank you very much. That's the clinical implication of that. Please, question here.
Please, sir, in the bundle branch blocks, can you go through the Marrow and the William again?
Okay. We look at the V1, and we are looking for a first positive deflection, and then it comes down before it goes up again. What we call an RSR pattern. RSR pattern. Pamela, I expect movement to be happening. RSR. That looks like an M. When you see an M in V1 and the QRS is prolonged, so the first thing is that you see a QRS that is prolonged, telling us that there's a block. It's taking a long time for the impulse to go around the ventricle. Once you see that, that's the first sign that there's likely a block. The next sign, now you look at V1, and you can see that there is RSR, marrow. That is right bundle branch block, MRW, marrow. And then in the left bundle branch block, you have the M is in V6. WLM, William. That's how we look at it. So now let's look at a real ECG. And we say the left bundle branch block is the one you should keep your eye out for. Because if somebody has a chest pain or you see a left bundle branch block in them, chances are they are having an MI. So an MI can come with ST elevation or it can come with a left bundle branch block. So look at this case. Is the QRS prolonged? See where the QRS started from here, and it's here. It's prolonged, sir, isn't it? So now let's look at V1. This V1, what does it look like? Does it have any pattern? M, R, S, R. And then in V6, you can see these ones. It's like a W. So what kind of block is this? Right, marrow, exactly. If it is left bundle branch block, this thing you are seeing in V6 will be here. And this one you are seeing in V1 will be here. That's just the difference. And that's a left bundle branch block. Hope that helps, sir.
A question, yes, sir.
Thank you very much for an exciting lecture. Please, what are the SE changes in pericarditis?
Okay. In pericarditis, what we are looking at is the shape of that ST segment elevation. Like Dr. Iseko showed during his presentation of chest pain yesterday. And the one we showed, like the ECG in page 45, you will see that it is convex up. But in pericarditis, it is a saddle-shaped ST segment elevation, like something you can sit on. And in pericarditis, it's going to be almost diffuse, as in affecting all the leads. Because in pericarditis, it's affecting the pericardium. So it's not limited to a specific blood supply area, like you have in patients with heart attack, where you have either maybe inferior, anterior. The changes will be generalized, almost going from V1 to V6. Then you can have that PR change, like he talked about. The PR segment, where we're looking at that AV node at the beginning, can be a little bit depressed. So that's how, so the shape is either like a spoon or saddle, while in MI is thank you.
Chief, one more question.
Thank you. Please, when you have pathologic Q waves, what should you be thinking? And then can you also explain the QS wave?
Okay, thank you. The pathologic Q wave, like we said, it is deep, more than a quarter of the R wave associated with it, and it's also wide. So Q wave, it means there is either an acute, as in an ongoing MI, or a previous myocardial infarction. So just know that once someone has a Q wave that is pathologic, there is a myocardial infarction. It could either be something that is still going on, or because once the patient developed a Q wave, even after intervention or whatever, the Q wave remains there. So it can show that someone has had an heart attack in the past or something that is new. Then you talk about the QS wave. Once there is no R wave in your QRS complex, what you have is just something like a V. So it's supposed to be a negative, a positive, and another negative. But unfortunately, the positive that's supposed to be in the middle is lost. So what you have is something like a V. That is a QS wave. So.
All right, thank you, Chief. We'll reconvene at 2:10 to continue the session. Let's take a break. Good afternoon, everybody. I want to believe most of us have had our meals. You can start rounding up your meals. You can start taking water. Please, can those outside come in? We're about to start the next session. Please check your seatmates. If they are not here, can you put a call across? Tell them we're about to start. Start drinking water so you don't choke when we start the next session. Okay, just an announcement. If you're interested in working in any of the groups in Limi Hospital, there's an email. So you send your CV and application letter to careers@limihospital.org, and Mr. Victor will be very happy. Mr. Victor and his team will be very happy to contact you. So we'll be going into the next section. That's the Advanced Cardiac Life Support. And to take this session, we're going to have Doctors Iseko, Awofsoye, and Olalekon. All right, so let's welcome Doctors Iseko, Awofsoye, and Olalekon to take the next session. Let's give them a round of applause as they come up.
Good afternoon, everybody. Are we all back? Hope we're not in the postprandial phase. Okay, so this afternoon we'll be talking about ACLS. I'm sure all of us must have some sort of experience in resuscitating patients within the hospital, and of course, as healthcare professionals, especially in the hospital, we have to do beyond the BLS, and that's where this comes in. What happens once you start your chest compressions, you put in your ambo bag, what next? Usually the BLS is the most critical part, okay, but we need to continue and we need to get things to an advanced level, and that's what we are going to talk about a bit this afternoon.
Okay. Good afternoon, everyone. Good afternoon, everyone. Did I daze you too much? At least lie now. All right, so we're talking about ACLS, Advanced Cardiac Life Support. I think it's showing already. No, it's showing already. Change the slideshow, please. Advanced Cardiac Life Support, and essentially it's what you do after the basic. We did the basic yesterday. If you don't do the basic, if you're not here yesterday, you're almost wasting your time somehow, but I'll do a small recap of the basic. We went through how to do all the things properly. If you don't do that one, you cannot jump here. You cannot jump here. Okay, so if you don't do that one, you cannot jump here. If you look in your jotter on pages 33, no, from 31, from 29. Abi? Where did it start from? Yeah, from pages 29, you will see different algorithms for life support. Okay, if you contact me later, maybe we can do a big one for you. We have big ones around our hospital that we paste. If you copy it and you paste it in the hospital, please give us some small credit. Just put small credit there. So that you know say we try small. Okay, so from 23, you will see algorithms. These algorithms you must go through them with your staff over and over and over again. Because when it starts, you need to, now I'm going to also give you a website where you're going to use to practice. It's not our website, but I'm going to give you where you're going to use to practice the ACLS readings. So once it gets to ACLS, it's more about knowledge. It's not about what you are doing and what you are not doing. Okay, so we'll go straight into it. Have we seen it in our books? The different algorithms. We're going to use some of them. It's not complete, but there are quite a number here. Okay, are we all together? Hello? I think we have found it. I've given you free textbook. Okay, my name is still, page, I think from, yeah, okay, 30. This one cut off, the name cut off of this one. Check responsiveness, defibrillation. Okay, this normal BLS. Cardiac arrest. 31, 33, 33. Okay. So we'll go straight into it. What is ACLS? Advanced Cardiac Life Support. You can sit down, sir. Advanced Cardiac Life Support refers to a standardized algorithmic. Algorithmic means that step by step, every step is a new question, every step is a new question. Step-by-step set of treatments that are used to treat life-threatening cardiovascular conditions. Every doctor, every nurse must know this. And for those of you that have tried to Japan, you know that they will tell you, if you don't have this, don't come here. Every doctor, every nurse must do this. Now, typically an ACLS class is about 8 people. It's more in-depth. I don't think there's anybody that charges less than 120,000 for an ACLS class. Okay? So there's only so much we can do with this whole audience, but we will try our best. You will at least have enough knowledge to do what you need to do part-time for now, just like we did for BLS. Okay? So that is ACLS, a set of clinical guidelines. It is for urgent and emergent treatment. So some of them are urgent, some of them are emergent. That is, some of them you must do something immediately. There is no time to call me. There's no time to refer. There's no time to be shouting. You are the person, you are the last hope of that individual, and they are in your hands. And if you don't handle that person well, in my mind, you are going to answer to God. That is how I see it. Okay? So it's a set of guidelines, urgent and emergent, for life-threatening cardiovascular conditions that will cause cardiac arrest. So some of them have not yet caused a cardiac arrest. But as you see them, it's just a matter of, remember when we were doing ECG, I said this one will turn to cardiac arrest. If you don't do anything and say, no, nothing is happening, the person is still breathing, you are just, sometimes they are even talking with you. There's one man that came to the hospital. He was talking, politician, and he refused. Remember that guy? He was supposed to get to appointment. He didn't get it finally. He refused our admission. We had to start doing things. Even he had to sign a DAMA form. Because they will either cause or they have already caused. So either person having a cardiac arrest or what he's having now is going to lead to a cardiac arrest if you don't do anything. So what you do, the procedures, the medications, and the techniques, that is what constitutes ACLS. Is that simple? ACLS, the sets of procedures, the decision tree, the set of clinical guidelines that we use. All these guidelines have been tested over time. We're not here. We tested over time. There, people keep on reporting. You know, for example, if we have reported all the things we have done in cardio care, the one we survived, the one that we survived, then other people will report their own. After a while, we can find what is working for Nigeria and what is not working for Nigeria. So they have national registries and national institutes. Their institutes of health, their Ministry of Health are collecting those data and working on it. Here, it's something else. Okay, so that's how we go. So what we are using is what they have a lot of time in most of the cases. In some of the cases, I will tell you what will work in Nigeria. So some of the things are there, we don't have those things. I will tell you what we use in Nigeria and what you can do in the meantime. So ACLS steps in my mind. Number one is the BLS and CPR. Then the remaining parts of the ACLS are these other three parts. Crisis resource management, identification of the rhythm and the treatment, and you do that with electrotherapy. That is either you are cardioverting, you are defibrillating. Both cardioversion and defibrillation involves shocking. The difference between cardioversion and defibrillation is what? Is the voltage. How many people have something like this in your facility where you can adjust the voltage? How many people have something like this? Show of hands. 1, 2, 3. Don't worry, by faith, let's learn it. You must have this. You must have this. You should not be going near the theaters, operating on very sick patients, hypertensive, diabetics. You don't have this. You have anybody with heart attacks, hypertension, on admission, diabetics, and you don't have this, you are looking for trouble. And you know how it is. It is just one person, maybe 1,000, that will embarrass your entire hospital. This is a little bit expensive. And unfortunately, this is one of the things in a hospital for those in private sector that you cannot really get your money back for. A defibrillator standard costs something around 5 million or thereabout, 4 to 5 million. A full one. And this one I'm holding here, maybe costs close to 7 million, also has an AED. So you could turn it to AED. If you don't know what you are doing, just turn it to AED and put it to still work. And when you want to do ACLS, you can also now adjust it. In addition, you can use it to pace the person. So if the heart rate is too low and you have given what you cannot do, you take these pads, put one in front, put one in back, and turn it to a pacer and put on, and it will start pacing the heart. So that you can transport that patient safely to get to cardio care. We can now implant a pacemaker or put a temporary pacemaker into the heart. Without that, there's no way you can keep that rhythm up till you get to a place that can do that. Do you understand? So you should have this or something like this. It typically has batteries. You should be charging it every day. It should be somebody's job to go around, check all of these things, and charge it. On the slides also, I will give you a list of things that should be in your emergency trolley. Okay? And so you should also have them in your clinic. So you go back and prepare. Many years ago when I was in the government hospital, I complained. I wrote, we fought. I said it's not. The next time I heard it, one of our professors had an issue. This is how we went to park to go and be waiting for drug to come from Lagos. So you don't ever know, God forbid, who will need it. So always prepare your center, that they should not tell you that somebody that you know is in your center and you say, leave that place. Prepare your center so that, God forbid, if something happens to you in your clinic, you can be resuscitated properly. Train everybody. Go back. The one you have learned, use it and train. And these videos are on YouTube. It's broadcasting live. You go to Cardio Care on YouTube, you see yesterday's own and you see today's own. Okay, and you see our previous videos on different things, in depth. So, crisis resource management, identify the rhythm, and then treat the rhythm, manage the airway, and then specialized life support things, different higher-end gadgets that you can use. This essentially constitutes advanced cardiac life support. Okay? You will not find this like this if you read it online. It's always somehow. This is, I've been working throughout last night to find a way to break it down. Still, I don't think it's simple enough. But I think this is okay. Okay, so recap. Remember I said BLS is the start? Recap. If you don't do a good BLS, you will not get to ACLS. Patient will have died. So in the BLS, the first thing you do after you have confirmed that the patient is unresponsive, doesn't have a pulse or a heart rate, and is not breathing right, unresponsive, cardiac and respiratory arrest, is you call for help. Help is bringing extra hands, defibrillators. If you have a good system, you should be able to press a code for everybody to come in. You should have a code blue team, which typically consists of the most experienced people in the facility that you should be able to call, that should start coming. And the people that know how to at least get airway, you should have that team on standby. And the bigger the hospital you are, the more likely you should be able to have such people. Okay? So you should call a team, you should get a crash cart. How many people have a crash cart in their facility? 1. So you are going to go and do it. It's not a bad thing. They should carry catapult like this. Put wheel under it and put cupboard. Shikena, you have crash carts. Hello? Or you can meet maybe Codex, I don't know if Codex has, or any of the instrument suppliers. It's about 400,000 or so. That one is the proper one. It has the backboard that you can put under a patient when you are doing CPR. It has all the cabinets where you can put your drugs nicely. It has the place where you can put your drugs, your AED, and where you can hang your pole. So you should take some time and invest in it. Okay, I don't know if any of our partners has. I'm not sure. Vaslovas, no, Vaslovas is mainly drugs. Okay, so you should have a crash cart. So some of us, this is something we are just putting together. You must have it. So when they say something is wrong with a patient, you drag that cart to the side of the patient. It's not that time you say adrenaline, then they go to the pharmacy. Adrenaline. Okay, then they come back. Atropine, then they start going. You know? A running doctor is not a very good doctor. Okay, fine. So the next thing is compression, as you have a firm surface. I'm just recapping. We did this in detail yesterday, remember? This is just the main points. 100 to 120 cycles per minute, 5 centimeters depth, minimize interruptions. Lock your palms and lock your elbows. Push from your shoulder. Push from your shoulder. Then airway and ventilation, 30 to 2. 30 compressions to 2 ventilations. If you happen to be somewhere that you don't have the ventilation or to do the bag, continue. Continue compression. Compression only is sometimes as effective as compressions with ventilation. So if you cannot do ventilation, just continue that compression. Don't let people be shouting all kind of things. Just be doing your compression. It has the potential to save. Firm mask, ambu bag. Remember the CE technique. We practiced it yesterday and we showed all of you. Then avoid pressing too much of our ventilation. Connect oxygen. Then bring your defibrillator. Connect your defibrillator. Put the pads. One under where? Where's the first pad? Under the right clavicle, and the other under the left breast, just under the nipple on the left side. Okay, you put that there. If you want to pace, it becomes front and back. If it's a child, it's front and back. Okay, you make sure that it does not touch each other. If you are using for a child, a lot of times you may have a voltage reducer for the defibrillator. So you have a voltage reducer. This is not one for the children's hospital. The children's hospital have their own. It has a voltage reducer. So it connects to a voltage reducer that reduces the voltage that goes to the child. Okay? But if you don't have that, still use the normal adult one. Okay? Last you go shock and well, but let the child come back. I'm joking. But seriously, use the normal adult one. Okay? So put off open oxygen, no wet surfaces, just follow the prompts. It will analyze the ECG for you. So that is a BLS recap summarily. Okay, next is the crisis resource management. This is critical. A lot of times we don't normally pay attention to this. We're just looking for stuff. This is part of ACLS. This is where everybody must work together. So the key principles in crisis resource management are leadership, communication, and preparation. There's a fourth one actually, debriefing. But leadership, communication, and preparation. Leadership, communication, and preparation. What does this mean? There must be someone that is the team leader. So typically when I get to the side, they say, call a code, everybody. Brrr. Once I get there, I take the head of the bed. I am not the one pressing. I am not the one doing. What I'm doing, I am coordinating the team. There must be somebody in charge. Whenever there's a crisis, it's not democracy time. It's military time. Okay? So that team leader is the person that does the global management, ensures that all tasks are carried out properly. So at that point in time, I will see somebody doing CPR like this. Krombe. Move. Go and be drawing drug. Okay? That time you see the wrong person, go and be recording. You need to assign people that will be recording your CPR also. So you make sure everything is being done properly. You will coordinate communication. Anybody that wants to give an instruction, we give it to you. And you will give them so that you can harmonize it. Not that somebody is saying give atropine and somebody is saying give adrenaline here. You are the final person. You still will not be proud. You must collect everybody's expertise. Somebody says, sir, we have not done this. You take it, analyze it, and see whether it's something. So the most senior person in your hospital now, you are the most senior person, Abi. So far you came to ACS now. Now you senior pass. Why all of you looking like me like that? You are the most senior now. Now you know who goes supposed to do what. Okay, fine. So he coordinates communication among the team members, implement the management strategies, reassess performance, collates the experience and wisdom of the entire team. Yes, you will see at the organ, but you will still get input. In cardio care, everybody, cleaners, everybody will be taking turns. They are pressing the bag, sir. It's like what this oxygen is not doing. Somebody is doing that, sir. This something, that guy is not doing this proper thing. Well, they will move. They are invaluable. Everybody in your team. Let everybody learn it. It will not cost you anything. If they go and that person can't teach them again. Okay? So let everybody in your team learn it because they are all important. At a time when CPR is getting to 30 minutes, sometimes we cannot press it again. It's not that time you will not start teaching. I know the housekeeper and security men, they normally have muscles, not them. They will be pressed well. Okay? So they are a critical part. I'm not sure I can do CPR without them. Okay? See one that is coming in, came from the cath lab. No, we don't do cases without him. Yes, that's how important the person is. The person knows what drug to bring next, knows what ambu bag to bring next. It's critical. You cannot be running at that time. It's too late. Okay, so the next one is communication. Communication. All pertinent information goes to the team leader. Tasks are assigned by the team leader. The team member must repeat back the instruction. This is called a closed loop instruction. If I say give atropine 0.6 milligrams, you will repeat back to me atropine 0.6 milligrams before you will give. Do you understand? It's to make sure there are no errors. If I say give adrenaline 1 ampoule, you will say adrenaline 1 ampoule, then we will give. All of us will hear it. We will have assigned somebody that will be recording for private practice, also for billing and for inventory purposes. But otherwise, you want to make sure that you document it properly. If you end up in court, you should be able to bring out everything. Okay? You should be able to bring out that you follow the proper steps. And you tell yourself, because tomorrow you should look at it and know where you can improve. So this is all part of ACLS. Okay? Then, extraneous personnel should be asked to leave. Some staff will just be there looking. Get them out. What are you doing here now? Okay? So team leader, get them out. Relatives not helping. Hey. They were just pressing the chest. Get them out. One person, they did tracheostomy, and the patient still died after everything. The woman said, if I cut your neck, will you survive? So get them out. Okay? Fine. Then debrief the team for learning points. After you have done, patient came back, patient did not survive. All of you should talk about, you sit down and talk about what you did right and what you did wrong. It helps you to improve for the next one. It helps you to improve for the next one. You say, we look for adrenaline today. Then you go back, you adjust it. So that eventually, it will become like an orchestra. Somebody is having a cold, people will just be moving around. Pam, 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 everything is just coming out. The patient comes back to life. It's just fantastic. But if you don't do the debriefing, you will not learn from your mistakes like Nigeria. All right, and then finally, crisis resource management is preparation. Get vascular access immediately and early, IV or IO. I don't think many people do IO. You need an intraosseous set, a drill to the bone so that you can set a line when you cannot get any line. So IV or IO, oxygen should be ready. So you should not run a hospital if you don't have oxygen. Okay? Yes, I read in the papers they say there's no oxygen in one place. Somebody came with COVID, they're looking for oxygen around Abuja. You should not run a hospital without oxygen. Then you should have a way to monitor oxygen saturation. ETCO2 is very good. If your monitor can get ETCO2, fantastic. It has some extra cost, but it's very important. ETCO2 is the most reliable means to tell you, A, whether your CPR, you are doing a good job. And B, when to stop CPR. Okay, so end-terminal, is it end-terminal? End-tidal, sorry. End-tidal CO2. There are two types, mainstream and side stream. We only connect it when we have intubated the patient. We connect it either mainstream into the one or side stream, and it measures the CO2. Okay, so let's assume you win contract now. Please, at least supply the correct thing. Okay? Then ECG, and then your crash cards. Are we all together? All right. This is stuff. You need to learn it. You need to practice it. Without this, your ACLS will not be successful. You can never walk alone. You cannot know it all. You cannot do it all. So ACLS is useless if you are the only one that knows it. Okay? So common team roles. So the leader, 2 to 3 CPR performers, an airway person should be called, IV access somebody with medications, typically one nurse mans that, 1 or 2 nurses joins housekeepers and doctors to do the CPR. Somebody is checking the defibrillator, connecting it, making sure, and somebody is recording. Atropine, 2 milligrams given. So after a while, you're not sure if you have been resuscitating for a long time. How many atropine are we giving? Somebody can tell we are giving 4. You stop. Somebody can say we are giving 8 adrenaline. We are giving 3 shocks. Somebody must be recording. Hello? Fine. Hope the food is not too much. Okay, so those are the team roles. So the next thing is rhythm identification and treatment. This is the main part of ACLS. When you get to the point where you have to identify the rhythm, we did rhythm today, Abi, well, and where you can now treat either cardiovet, defibrillate, pace, and medications. Okay, so I hope that is it. So successful ACLS treatment starts with the correct diagnosis of the ECG rhythm. That is what is the main bane of doing ACLS successfully. You must diagnose the rhythm successfully. If you do not correctly diagnose the rhythm, you are going to do something that will even make it worse. So if you diagnose the wrong rhythm and you shock the wrong person, or you defibrillate instead of cardioverting, you are going to stop the heart rather than start the heart. Do you understand? So getting the ECG diagnosis is critical. Besides the shockable rhythms, the rest of them, you have to read them. So in your defibrillator, there will be an ECG cable. Okay, there's another one. Have you guys brought the second one? Where's the comment? Okay, so there's another one. You can see this one has a full 12-lead ECG. So you connect the entire ECG cables to the patient. If you are doing a surgery, the person say he's coming for, what's that thing they are doing now? Brazilian something. Brazilian lifts or something, or liposuction, hypertensive something. Put all of this ready. Set your pads ready. Because you can see this patient is relatively high risk. So that ECG is there, you are seeing it. The reason why you need this, if you need to cardiovet, for cardioversion you must do what we call synchronized cardioversion. Meaning, you must shock exactly on the QRS, on the peak of the QRS. Remember that QRS? Your shock must be delivered at the exact time that QRS is landing. Otherwise, you will cause problem. So when you have set it, the ECG is there, you will tell the thing to synchronize. It will now synchronize it, and when you press shock, it will deliver the shock at the right time. But if there is no ECG there, the machine cannot synchronize. And you cannot know when the next one will come, so you press. It's not possible. So you have this ECG there. Then you will press synchronize on the machine. It will synchronize it. It will pick up the ECG rhythm, synchronize it. The way you shock, and you choose your voltage, you shock, it will now synchronize and bring the person back. Hello? You have not seen he's here. You can come after, walk around, look at it. Okay? And then go back and give somebody trouble. Thank God I'm not your MD. Okay. So typically, there are 2 sets of rhythms. Think of it simply. There are cardiac arrest rhythms and there are non-cardiac arrest rhythms. That is when somebody needs ACLS, he may be in cardiac arrest, or sometimes they're not in cardiac arrest. They are just on the ward without cardiac arrest. They are in your A&E. They are in your theater. You are doing the operation for them. They are in your labor room. These patients are everywhere. So, say somebody, he went for surgery, there was nothing, he just, somebody did not recognize something. It happens everywhere. Sometimes you recognize and you could not do the right thing at the right time. Okay? So, remember that there's cardiac arrest rhythms and non-cardiac arrest rhythms. For the cardiac arrest rhythms, there's the shockable and the non-shockable. If you put your AED during cardiac arrest, it will decide if it is shockable, it will say shock advised. Then it will tell you to press and then to shock. For the non-shockable, it will say no shock advised. Continue CPR. Okay? For these ones, the patient has come to you and you have found the rhythm. And you know this one may likely lead. So it might either be a very slow heart rate or a fast heart rate. If it is fast, we'll check whether it is narrow complex. Who remembers narrow complex? How big is narrow complex? Less than half a big box, Abi. And then wide complex is more than half a big box. So that is wide complex and narrow complex, or slow, tachycardia, and then a slow heart rate. Okay? Is that straightforward? It's simple now. Hello? Any questions? About to take it a little bit harder. They are not shockable. If you put your AED and it analyzes that rhythm, it will say non-shockable. And if you are not using an AED and you have become guru like us, we look at it. This is PEA. Asystole is like flat line. Flat line. Don't mind the movies. It doesn't mean you should stop. Flat line. It's not like that. So in the movies, it will just become flat line and they will just say it's over. No, it's not over. You will continue what? CPR. Continue CPR. Okay? So, we don't have pulse. What is the ECG pattern in this cardiac arrest? Anybody? This person came with cardiac arrest and no pulse. Of course, no pulse. It's cardiac arrest. What's the ECG pattern? There is no pulse. Yes, anybody? Anybody? No pulse. But on the monitor, this is what you are seeing. Hello? Try now, try. Dr. Atakulu. Choose one. This is what you are seeing. And the person is in cardiac arrest. No pulse. But you put on the ECG and you are still seeing this. You check there's no pulse. You put there's no heart rate. But you are seeing this one. C, pulseless electrical activity. So there's electrical activity. Maybe this, it may be something worse. But in this case, it is electrical activity that is pulseless. Okay? This one you cannot shock. Hello? This one you cannot shock. What about this one? B. D, asystole. So sometimes you see some small flickers, but it's generally a flat line. Okay? Before you say it's asystole, check that your ECG cable is connected well. I'm telling you, it has happened before. It can be on the floor. You are there. There's nothing here. The ECG cable is down, just like it came down from there now. Please. Okay, so these are cardiac arrest rhythms. So in these two, these ones are non-shockable. What you do next is to exclude reversible causes. Hope I have them. Yes, exclude reversible causes. 5Hs and 5Ts, we'll talk about that. And then you continue your CPR. Give adrenaline, repeat adrenaline every 3 to 5 minutes, and after checking the rhythm. Every 3 to 5 minutes after checking the rhythm, repeat adrenaline, continue CPR, and recheck the rhythm every 2 to 3 minutes. Hello? So your monitor is there. You've checked it. It is this one or is this one. Give adrenaline. Continue your CPR. Continue your CPR. 3 to 5 minutes, you check the rhythm. It's still there. Your CPR, bag, max, 32, 32. Every 2 minutes, change so that somebody can rest. Change. Bag, mask, change. Give your adrenaline again. Every 3 to 5 minutes, recheck the rhythm. Continue. That's what you do. Sometimes, a lot of times, when you continue, next thing you see to change, the rhythm will change. to a shockable rhythm. Then before the person comes back. So that is why you should not see that one and say it's okay. So what are the causes that you should check while you are doing that? This is why you need a team. Somebody else should begin to check the 5 H's and 5 T's. What are the 5 H's and 5 T's? These are the 5 H's and 5 T's. You should check, is there hypoxia? Is there hypo or hyperkalemia? Sometimes you need to get someone to take the blood immediately, and if you have the iStat machine, you can take it and get it immediately by your bedside. You should check, is the person too cold? A lot of times people that have drowned, okay, they are calm, they are now cold, you need to cover them. Okay, in our center, if the person is cold, there is still a chance, in fact, a better chance that you resuscitate that person. So until the person's body has become warm, you cannot truly say that person has died. So if you say the person has died, that's why the ones that they say they woke up from dead. From the somebody did not finish CPR, he just say, then later they say the man woke up. Okay? Fine, what again? Acidosis, then thrombus, that means pulmonary embolism or MI. That your ECG, get your ECG. Check for it. Tension pneumothorax, you may need to just put a needle there. So somebody is checking why CPR is continuing. Tamponade, toxins, sometimes they're taking Igbo or something else, Abi, or trauma. So you need to address all of that. So what rhythm is this? Still cardiac arrest, no pulse. B. A. Open your ECG. I think it's there. Open the ECG sheet in your this thing. Check for it. Look there. Look there. Well, I'll give you everything you need to succeed. All that you need for life and godliness. What is it there? Is there the rhythms there? I think they are there. I hope I did not forget to put it there. Is it there? It's not on that one. It's not in this book. On that sheet with ECG. There's tachycardia. Oh. The revised one will have it. Okay, so what is this one? Jaga jaga. Jaga jaga is A. Ventricular fibrillation. No, it is irregular. There is no detectable rhythm, but there is something there. That is A. This is a shockable rhythm. You must shock immediately. If you see this one and you have a manual defibrillator, shock. Turn it to 200 biphasic and shock. Don't wait for things to start reading. This is a ventricular fibrillation. In a short time, it's going to go to PEA and asystole, and you will have a very hard time. Hello? So just think about it. Irregular, scattered, almost jaga-jaga, ventricular fibrillation. Sometimes some people refer and say ventricular fibrillation in a referral letter. I say, you saw it and you refer the patient. If you don't do anything, the patient is going to be their creator. Okay? So you need to have this done. Look at the 12 lead of it. What you can see it. This is what the 12 lead would look like. Sometimes the people, if you have an ECG technician, your ECG technician will just be doing ECG and see this one. Patients are doing like this. Hey, they should know what to do. They should start CPR immediately. The same thing you do for cardiac arrest. Start CPR, call for help. After somebody sees this one, you shock immediately. You get the person back. We all know this, Abi. Anybody that cannot recognize this again? Anybody? Straightforward. Once you see chicken writing, Dr. Aho says, once you see chicken writing. Again, check that this cable is not on the ground. Check. Because it could just be disconnected and hanging. You not connect it back. Sometimes somebody writes it because the patient will be gisting. Then you see this, he goes, Check. Likely is that your ECG is not connected well. Okay, fine. Again, I remind you, you will get all the slides by the grace of God, hopefully between next week. You get all the slides to the email. So if you don't write your email well, sorry, you get it from your friend. What ECG is this? No pulse, cardiac arrest. So you have a regular here, in this case regular, wide complex. Hello? Wide complex regular tachycardia. In this case it's irregular. So this is called a pulseless ventricular tachycardia. Sometimes you can have ventricular tachycardia with a pulse. The patient is just feeling somehow they are there. You will not defibrillate. You will do something else. Talk about it. So again, for shockable rhythms, I hope I corrected this one. For shockable rhythms, shock. Sorry, mistake. For shockable rhythms, pulseless VT, VF, shock. Sorry about this. Shock. Give adrenaline. Shock. Continue CPR. I'll correct it in your slides. So cardiac arrest happens. Can we see that? Check the rhythm. Start your BLSO. While your BLS is there, you have set up your rhythm. This ACLS now, not ACLS. BLS has been continuing. Now your rhythm. Head matron has come in. She just finished from ACL, from Abuja Cardiovascular Symposium. Abi, you land. Today, as you're leading Kefi or where, they just say, you have come. I will not be there. I will not be there, I promise you. So, you found out that it was pulseless VT or VFib. You remember? It looked like this or like this, and there was no pulse. Patient is in cardiac arrest. What do you do next? You were doing CPR before now, then you continue your CPR. What do you do next? Shock. Don't be afraid. Shock. Shock. So what kind of shock is this? It's a defibrillation. Because it is jaga-jaga, you cannot synchronize. And you have to give a very high Q. So you start with 200 typically on a biphasic. Or does it change to 360? Sorry, I'm very tired. And then continue CPR. You continue that. If it is asystole or pulse electrical activity, you remember those ones? Flat line or just some electrical activity but there's no pulse. What do? Continue CPR. Give adrenaline, remember? 1 mg, typically 1 ampoule. And repeat every 3 to 5 minutes, we said. Continue your CPR. Are we clear? One time, some people told me that their AED is not working, that every time it's always saying no shock advised. What does that mean? It was picking these kind of rhythms. So it was not as it was not working, you're picking these kind of rhythms, so they said that is not working, Gary. So they stopped using it. Okay? So you have to know that so that you know what to do. So adrenaline every 3 to 5 minutes. Check and treat in all of them. Be checking. Somebody else should be checking and treating the irreversible causes. If you see hyperkalemia, start giving your drugs. And then if it is for not this one, if it's for pulseless VT or VFib, you are giving the first shock, it continues. Second shock. By the second or third shock, you should start adding IV amiodarone. IV amiodarone, for this case, is 300 milligrams. Write it down. IV amiodarone, 300 milligrams starts. IV amiodarone, 300 milligrams starts. And then you continue with 150 milligrams, if you have to repeat the dose, or you put in infusion. 300 milligrams starts. How many people have seen IV amiodarone? I didn't see it till I became a cardiologist. So don't be, listen, it was when I became a cardiologist I saw it first. So it's not everywhere. But now you have come for ACS. You are going to your center and you are saying, sir, we need IV amiodarone. All right, I showed you this ECG this morning. This ECG this morning in the cath lab, we had this. What rhythm is this? Hey, people are quiet too. What is the rate? What is the rate? Can we see the lines? It's about 300, Abi. Good. What is the, what rhythm is this? Huh? This is real life, oh. It's
Someone
real
that
life.
is sure should answer.
Talk now, talk. Say it boldly.
Ventricular tachycardia.
Thank you. It is regular. It's not jaga like chicken scratching. It is regular. It is coming regularly. Abi, wide, complex, regular tachycardia with no pulse. The person has gone. I told you the man went. He started even convulsing. The man went, and then when we now woke him up, he now said, "Why are we disturbing him?" So is what? Pulseless ventricular tachycardia. After that, there's one man. He had MI. He had all of this. We resuscitated him. He came back. We said, "Okay, let's rush and give you connected place or take to the cath lab." He said, "No." That how much? No. Nobody should tell you. On top of what? That is malaria. The person that had woken up from this, he refused though. We couldn't force him until he had another cardiac arrest, and we were unsuccessful. That's about 5 years ago. We were unsuccessful reviving him. The wife called me to say we should not mind the man, that we should not mind the man, we should not. But there's no way you can override a patient's wishes. We cannot carry him to cath lab by force. We cannot give him anything by force. The man said, "You say how much?" You are not serious. I'm telling you a real life story, not be a joke. It was nice. I think Dr. Oleleko was the one on call that day. Okay. I think that's basically it for that. So, shockable rhythm, yes or no? You have this in your book. This is page 31. Shockable rhythm, yes or no? If it's not a shockable rhythm, that's asystole or pulse. Give your epinephrine. Continue your CPR. Repeat your epinephrine every 3 to 5 minutes. Consider advanced airway. Check again shockable rhythm. If there is none, continue your CPR. If there is a shockable rhythm, administer your shock. Continue your CPR. Get access. Check shockable rhythm again. Give your CPR. Continue to give your epinephrine every 3 to 5 minutes. Shockable rhythm again. Give shock. By the time you are getting there, start getting that amiodarone. So if you don't have amiodarone, you have lignocaine. Everybody has lignocaine. The same one you use for local anesthesia. Hello? The same one you use for local anesthesia. That one that if you mistakenly put inside you, the person's heart will stop. If you give that one inside somebody's vein, mistakenly, the heart will stop. Okay? And if that happens, start CPR. Start CPR. People have made the mistake before. They wanted to give ceftriaxone. You know, they put it with lignocaine. They've withdrawn it before. One of my SRs that time, there was strike. He was giving drug. He was tired. All our officers also followed the strike. It was 2 a.m. He had given like 20 children. He said as he just gave, it just occurred to him, what did he give? The child just stopped breathing. He ran like this. He said the clarity in his mind there, he continued CPR for 30 minutes because the child was fine, about to be discharged. The child came back. Then he told us the story. We're all cold. We're all cold. Okay? So fine. So I'm telling you this story so I can stay awake. And then you can remember the stuff that we are teaching. So give lignocaine if you don't have amiodarone. Okay? I've forgotten those of lignocaine. Can somebody help me check it up? Okay, number 2 now. In this case, this is not, remember we said there are cardiac arrest rhythms and there are non-cardiac arrest rhythms. Remember? In these non-cardiac arrest rhythms can be either fast or slow. Not so? The fast ones can either be wide complex or narrow complex. Beautiful. Hello, there are, a lot of people are quiet. Oh. Don't be quiet. Oh. Don't be quiet. So, when your heart rate is fast, ask yourself, is this person unstable or is he stable? If they are unstable, what's the meaning of unstable? Blood pressure is too low. Patient is in shock. They have chest pain. They are altered sensorium. So you are doing your vital signs and you saw this patient, and sometimes if you don't find during ward round, the person just did like this. You check the heart rate 150, 160, he's unstable. Or they are complaining of chest pain. They are complaining of chest pain. They rushed into your clinic. What do you do? Unstable. What do you do next? Cardiovet. Cardiovet. This one you don't shock. You cardiovet. Why? It's not a cardiac arrest. Hello? Hello? Unstable tachycardia. Unstable tachycardia. Cardiovet. Not in cardiac arrest. The person has a pulse. He's just unstable. Blood pressure is low. Blood pressure is 70-50. The person is having some chest pain. They say they are feeling lightheaded. They are feeling like fainting. Okay? You say, don't worry, pour water on the head, drink Coke. No. So, if they call you and somebody says he's feeling like fainting, he's feeling sick, check the pulse, check the heart rate. If you notice the heart rate is already fast, connect your monitor. Start ACLS immediately. What you are dealing with is ACLS. Check, that patient is not stable. What you do to is get your monitor together and cardiovet. Okay? You cardiovet and then you continue with medications. If the person is stable, what do? You start checking. Is it wide or narrow? Hello? Don't get tired of me. Oh. Me too, I'm tired. If you are feeling sleepy, just stand up. In fact, let's stand up for 1 second. This is the meat. 1 second, we are standing up. Stand on your toes, up, down, stretch, up, down, stretch, good. Take a deep breath in, out. Again, we're going to take it this time very well. In, hold it, and out. Good. Now let's have our seats. Great. Let's clap for ourselves. Clap for yourself now, not for me. Some of you don't like yourselves. All right. Please take this very serious. Maybe we should have done this first in the morning. But then we have not learned ECG. So you will not have known anything about it. Okay? But this will be critical. This is life-saving. So the patient is stable. Check, is it wide or narrow QRS? We all can do that now. We are all ECG experts. If it is narrow, start with vagal maneuvers. What are vagal maneuvers? Who can give an example of vagal maneuvers? Valsalva. How can I explain Valsalva maneuver? You should do as if you want to use the toilet. Or you want to give birth. Bear down. Blow out breath against a closed glottis. So, or hold your nose and mouth and blow out. Can we try that? All of us try it. Hold your nose and mouth and blow out. Try and breathe out without letting any air come out. Have we done that? That's what you are going to teach your patients. Okay? Another one you can do is carotid sinus massage. Okay? And I've done it before. I think the last patient I did stand for. As soon as I opened the RCA for him, blood supply to the area, the guy started having SVTs. Narrow complex tachycardia. One day you remember. And I was the only one inside the cath lab. So immediately started massaging. Get the carotid, feel it, and then massage. And the reading went back to normal. Okay? No, we did not need anything extra. Okay, so you know that one. So you have carotid sinus massage. You have what again? Valsalva. Yes? Please don't do both of them at the same time or you will kill the patient. Don't pray both of them. You will stop blood flow to the brain. The patient will go unconscious. One side, feel the pulse and do it. If you have time, you may need to do a Doppler to make sure that there is no plaque there so that you don't rub it and the next thing the patient has a stroke. So those are the things you should take. So start with Valsalva first. But if you don't do anything with this narrow complex tachycardia, that patient is going to have a cardiac arrest. It's just a matter of time. So you need to do what you need to do. There's no time to call anybody to refer anywhere. You are the one standing between that person and their maker. All right. If it's narrow QRS, you can do vagal maneuvers, and then if vagal maneuvers fail, you can continue into drugs. And we'll talk about the drugs shortly. Remember, IV access should be there, oxygen access should be there, monitors should be there, ECG should be there, get specialist input. Not referral, input. When you are stabilized to an extent, then you can now start. If you must refer this patient, you must go with the patient. This is not the one you give driver to go, enter Uber. Or start describing, this is how you get to cardio care, left, right. No, no, no. You must go with the patient because that patient may likely enter a cardiac arrest. They are talking to you now. The next minute is all over. Okay? So check and treat reversible causes. This rhythm can be changing, so you need to be evaluating the rhythm regularly. So synchronized cardioversion, I've explained it already, but you need to know this. You need to know this. You are going to paste this in your emergency rooms. Nurses, doctors, you are going to paste your emergency room. You are going to keep it on your phone. You are going to keep it on your phone for narrow regular when you have to cardiovet. This type, you cardiovet typically for, who are the people you cardiovet for? Yes? Go back, you wrote it now. Who do you cardiovet for? Unstable. Unstable people with tachycardia that have a pulse. Tachycardia with a pulse. They are not in cardiac arrest. They have a pulse. Pulse is 150, 180. Sometimes 200. We have seen them in the clinic, 200. And they are feeling somehow, they are looking at you. There's one man they brought from Benue. He was looking at me like that. Professor, it was going like that. Okay? So you can do that. And if it is narrow and irregular, you use biphasic 120, use a higher joule. Wide regular 100 joules, and if it is wide irregular, you are likely dealing with a polymorphic VT. You should defibrillate because pulse is unlikely. Maybe you are feeling your own pulse. You should check this. Wide and irregular one, you should defibrillate. That is, you turn to 200 and you shock. You don't have to synchronize. Questions? Anything I should take over again? Just lift up your hand. Don't worry. We are here to. That's why we are here to learn. Just lift up your hands. We are here to learn. Any questions? Okay.
Thank you very much. My question is, in a patient that's unstable with tachycardia, with pulse, and you made a diagnosis that the patient is hypotensive. Will IV fluid go a long way in bringing back the patient to normal? Or we have to cardiovert anyway? Thank you.
Thank you very much. That's a very fantastic question. The instability in that patient, the hypotension, what is causing it? So when people have tachycardia with a pulse, and it is due to hypovolemia, it rarely crosses 140. That is the hypovolemia causing tachycardia. It rarely, if at all, 130, 140, tachycardia 130. When it starts crossing 150, 180, then what is causing the hypotension is not just the hypovolemia, it's the tachycardia. So remember, you are checking reversible causes. What are one of the H's? H. What's the H? Remember? Hypovolemia, B. So while you are doing the hypovolemia, what is it? While you can start your fluid, but you must still cardiovert. Otherwise, that fluid will not reach to solve any problem. Are you okay? That's what's happening. So you can be correcting it, but you must cardiovert because it is crossing 160, 180, 200. It is not a normal. It is not a sinus tachycardia. It's not a normal response of the body. Okay. Is there any other question? There's somebody at the back there. Ooh, I'm tired. You sure you'll not come and take over from me?
Thank you very much for your presentation. Please, I wanted to ask you for other examples of electrolyte imbalances which are reversible, can trigger the what do I say?
You ask regarding the cardiac arrest
Yes,
or
cardiac
the
arrest.
or the
Thank you.
unstable rhythm.
Yes, the unstable rhythm. Thank you.
You're asking for other abnormalities.
Other electrolyte abnormalities.
Hyperkalemia, hypokalemia, those ones you mentioned. Calcemia too, sometimes, hypercalcemia, all of them, they are there. So calcium should be one of the things. If you have hyperkalemia, you will still use calcium gluconate to help you protect the heart while you are giving glucose and insulin. Okay? So all of them are there. But typically, in this place, more times we see calcium and then you see severe acidosis. Okay? So that's one of the H's. All those H's that you saw, that is where it is. Okay? Those are the main ones. So again, if it is a wide, complex, regular, antiarrhythmic drugs, these are the drugs you can give. The patient is fine. He has a pulse. He is not hypotensive. He's stable. What do? You can give your amiodarone infusion. If you look on that page, what number is that? Is it there? Page 34. Page 34. You will see the doses of the cardioversion you are giving and the dose of the drug. Please open it now. Page 34, so that if you have any questions, you can ask. Page 34. You will see there, synchronized cardioversion, narrow regular 50 to 100, irregular 120 to 200, and so on and so forth. And then for amiodarone, the dose is there. Okay? So those are the doses. For narrow complex, give IV adenosine. Adenosine is quite difficult to find. And you must give it very fast. And when you give it, you must flush it because it disappears from the body in seconds. You must make sure that the rhythm is regular. Never give adenosine in an irregular rhythm. So it's not regular, do not give adenosine. But don't worry, adenosine is hard to find. So it's probably not, you probably have less chance of making a mistake. Hello? So you can call us later. We'll come and audit your hospital to see whether you're ready for emergencies. And then beta blockers and calcium channel blockers. So if it's adult bradycardia with a pulse, this all the one we're talking about is tachycardia, Abi. If, however, that pulse is now very slow, less than 50, less than 40, we have seen 26. We have seen 26 before. How many people have seen 26? Nobody. Anybody has seen less than 30? Nobody. Less than, okay, 2 people. Anybody sees less than 40? Nobody. Okay, so less than 30. What did you do for them? You prayed with them? Okay. So, again, stable or unstable. Again, understand? Stable or unstable. If they are unstable, that is hypotension, shock, chest pain, heart failure, altered sensorium, and you are getting that, atropine is the what you should give. Atropine will only work in certain situations. It will not work in many situations. You can also give dopamine or epinephrine infusion. That's adrenaline infusion. You can give that. Or, like I said, you can do transcutaneous pacing. But transcutaneous pacing is painful because it's sending shock. It's shocking from the front to the back. So you put this pad in front and at the back, turn it to pacer. Where's this thing now?
I'm sure of that one, sir.
Or maybe it's a soft. Okay, see pacer here. So you put it on pacer, and that one is there in front there. Maybe the camera can point to it and show it on the screen. Please, can you zoom in on it? So you can see that one. You can see AED, pacer, then monitor. So you can turn it to a monitor setting where it is just monitoring your ECG for you, or you turn it to pacer mode. In this case, select and then you start the pacing. So you put the pad one in front, one at the back, and then it starts pacing, especially if your atropine has failed. Then you can carry them. Most of them have batteries, and you can now move them with that until you get where we can put in something to help them. If you are too far away, you continue atropine, start dopamine, and then you trust God till you get here. Okay, so what do we do in cardio care? We can put in a temporary transvenous pacemaker. We go to the jugular and pass a pacemaker probe into the heart, or preferably we go to the femoral vein, just cannulate and pass it. Anybody can do it. It's not hard. I assure you, it's not hard. You pass it straight, you get into the right ventricle, and then you put on. You have a device. The device is a temporary pacemaker. You hang it on your drip stand. I didn't bring the device here. You hang it on the drip stand, you connect it, and you press on. You put normal batteries, Duracell. Make sure it's original. Put in the battery, and then you press on, and then it will start pacing. So that one is inside the heart. Then you anticoagulate. You have that one will give you a longer time and do not be shocking the whole patient. You know, this one is shocking the whole patient. Every time he wants to beat the heart, it will shock. Shock. So once you pass that one, it's now more stable. You can now prepare, get your normal pacemaker like I showed you earlier today. Take an incision, subclavian vein, axillary vein, any of the veins, go to the heart and connect it, and boom. If you think it's a permanent problem. If it's a temporary problem, go and solve the temporary problem. It could be an MI, do your angio stent. It could be a drug they have taken. It could be digoxin. You just continue that till it wears out from the system. It could be that the person took digoxin, took beta blocker, took amiodarone all together. He went here, he said his brother was taking this drug. He said this, I get heart problem. I wait till I go also they take. Bam, they took all of them. Bam, patients do it. They will not tell you. So it now went down. So you just have to pace them till that thing passes out. You make sure the kidney function is going. You are giving fluid. Once it passes out, the heart rate starts coming up. You reduce your pacing rate and the threshold until you see the normal reading picking up, and then you remove it and you are fine. Hello? Does it sound far away? Hello? Does it sound too far away? So what you need to do is just to make sure you get one of these. Make sure you get one of these in your hospital. Go there, and if you already have it, you probably have not noticed it before. Check for it. You came for ACS. So your medical director, I will tell them, they should call you, they should look for you. That you are the one that came here, you know what to do. Beautiful. Fine. And I think we can more or less end. After the patient has returned, the patient is fine, the heart rate has come back. Please, typically we like to intubate. A lot of times, you might enter the airway, intubate, get the SpO2 up to arterial blood gases, maintain the blood pressure, get a full 12-lead ECG, and then start the real treatment. Because you are returning the person, you have not yet solved a lot of the problem. A lot of times we rush the patient straight into the cath lab. Hopefully there is no financial constraint or the person has a good insurance. Okay? One day insurance will be covered in this country to the point that anything happens to anybody we can call and we are sure that everything is covered. Amen. Yes, one day is coming. One day is coming. But till that day we have to learn and be ready. So that there will be many people that can do everything until they get the patient to where they can get help. So if you have done that, you put all of this, follows command, you do other critical care management. If the person is unconscious, you will now have to manage as a coma patient. Sometimes you have to trigger coma yourself and do targeted temperature management. Okay. Ventilate, treat reversible causes, maintain hemodynamics, and get a specialist input. Advanced airway is all about putting endotracheal tube or laryngeal mask airway. Okay? Typically, your anesthetic nurse can help you, your anesthetist can help you, or preferably learn. I think in our children's hospital, we have a mannequin for training how to put for children. I don't yet have one for adults. If not, we'll have. But that one is very, these are very expensive and we cannot do for 400 people. It will just destroy. Okay? So, you should try, there should be somebody on staff somewhere. If they're not on staff and your hospital is small, at least know somebody. Know where your help is coming from. So as you started your CPR, started doing this one, call for the person. Let the person come, open the airway, put it in. Okay, we have not always had all of that. We call some, they will be driving fast. They will call me too, 10 minutes. It takes me 10 minutes from my house at 140 kilometers per hour. I get there, we shock. Immediately I get there, I get to the foot of the bed, and just like we talked about. Okay, so that's advanced airway. And then the final one is specialized life support systems. This includes taking the person to the lab. You need to open that vessel as soon as possible. It includes an IABP. So we have this device. I wanted to play a video, I forgot. We have this device called an IABP. I'll put it on the WhatsApp group so you can see what it looks like. The same way we did the coronary angio, instead we put a very big balloon in the aorta. The balloon will give counter pulsation. Whenever the heart pumps, the balloon also, after the blood comes, the balloon will also pump a bit and push the blood. So it will help the heart. So the heart will not do much work. To pump it again, some blood will go back and perfuse the heart properly. The rest will help to perfuse the rest of the body. Okay? And we had one case, a policeman came with an MI. Yeah. Came with an MI, cardiogenic shock. He was on 3 drugs, nothing. That is an ACS waiting to happen. We put the IABP, we thrombolized him first, called a facilitated PCI. Because he was too sick, we had him sign a high-risk consent that this one, oh, if you don't do anything, you die. If you do something, you may die. So, sign. So we first thrombolized, and they didn't have money. Thrombolized, then we went in, opened the stents, and then put an intra-aortic balloon pump while we were doing the stents. So all of that helped the heart, was pumping, helping the heart to pump. And afterward, urine started coming out. In a day or two, we brought him out of the ICU. He went home. He's still coming for follow-up for now. Unfortunately, his wife left him after he was discharged. I don't know why. But she tried for him. Oh, she called everybody. I mean, I was so impressed. So I was like, "Where is that your wife? That your wife really tried?" She said, "She left me." I said, I don't understand. We'll have a CME on understanding that kind of thing later. All right. Great. This should be your crash cart. Your crash cart in your hospital, this should be there. If you don't have a crash cart, at least have a cupboard. Call your carpenter to subdivide it for you. It must be there. You came for this program. Don't go back and leave yourself anyhow. I've written what I can remember now. We have a standard checklist that we use. Maybe if I remember, I'll put on the group as well. But this one is there for now. Amiodarone, adenosine. I put a standard adenosine. You may not be able to find it. And when you find it, you may not use it till it expires. Okay? So you should also know that. Some of these drugs, you may not use them. They may expire on your hand. Luckily, by high volume center with very high risk cases, so we use them. Okay? But if you don't have them, the day you need it, you will pray to your lucky stars that you had it. Okay? So if you're in private practice, charge for the ones that will expire. Make sure that it's there, Sha. Atropine, bicarbonate, calcium gluconate. Somebody asked about this thing. Dopamine, dobutamine, diazepam, 50% glucose. Why is 50% glucose there?
Hypoglycemia.
Hypoglycemia, one of the H's. Labetalol, lignocaine. Why is lignocaine there? If there's no amiodarone, you can also, some people even use it first instead of amiodarone. So it can be either both. When do you use it? Amiodarone or lignocaine, when do you use it? Huh? Shockable rhythm. Yes.
Reading.
Go back, check. When do you use it?
Cardiac arrest.
Cardiac arrest. After 2 to 3 shocks. That is what a refractory ventricular. So you shock the person, the thing remained. You continue CPR. 2 minutes you check. You shock, it remained.
Give your adrenaline first.
Give your adrenaline and continue adrenaline every 3 to 5 minutes.
Shock.
While you are continuing, shock. By the time you are getting to the 3rd time, technically 2nd to 3rd time.
Give your amiodarone, 300 the first dose, then subsequently 150.
And we've had fantastic results. It's so sweet. When it works out, it's so sweet. When it doesn't work out, it's so terrible. Why? Your whole body will be paining you because of all that. Bring, shouting, all of that. Then to make matters worse, the patient relative may still come and still insult you on top. Do you understand? So
why do you want to collect money when the patient is dead?
Exactly. And you use as in you emptied your crash cart, you intubated, you shocked, you finished, these pads. You have to order, there's not in this country now, we don't make, so definitely we don't make this. So you shocked, you transcutaneous paste, you did everything, you called 3 cardiologists were there, after a few patients still did not make it. See fight. Okay? So, but what I will advise you, if you start, it's not in normal ACLS, but for Nigeria, if you start ACLS or BL resuscitation, inform the family why you start. Okay? Sometimes let them even come and peep in and see what you are doing. So it will not be that they left the patient now and they came back and met him. What did you do, Seth? In fact, you're the one that killed him. Do you understand what I mean? So once you start, in our experience, it's good to send somebody out to inform the family, let them know. And also, you need prayer. Abi? And last, you need prayer. So have oropharyngeal airway, endotracheal tube, laryngoscope so that you can intubate. Please make sure you don't have the laryngoscope without batteries. Batteries should be there. It should not be inside, it should be by the side, and it should be checked every day. Somebody's work should be to check all of these drugs every day. Okay? Ambu bag, oxygen tubing, suction tube, Yanka short suction. Are there any other things?
Oxygen itself.
Oxygen. Oh, well, if you have oxygen in hospital. Okay, fine. Some people have oxygen attached to their crash carts. So when they just move the crash cart, there's oxygen, you just connect it. The face mask, you connect it. The ambu bag is there, you bring it out. You will bring in your drugs. It even has an IV pole connected. So you hang your IV fluid, you start. If you need amiodarone and you put your IV. So that crash cart is containing everything for life. Where I was training, when the patient starts doing somehow, the nurses will just move it close to the bed. The relatives will just start crying. Hey! All right, fine. We are going to try a small test. And I will give you a website. Somebody can help me find the website. NHCPS. Somebody will help me find it. There's a mega code there. You go there, you're going to try it. It times you because you have 2 minutes or so, 3 minutes or so. So it's going to time you while you are going through what you are going through. And every time you fail, it will tell you have failed. This is not what you're supposed to do. You do it again. You keep on practicing. Even we do it, we fail. Do you understand? I do it sometimes, I fail. The one I did yesterday, I failed. Yes. Why? Every stuff has half-life. It's gradually going down every day. You have to be refueling. Some people say they're not coming this year because they came last year. I say, how many heart attacks did you see between last year and this year? The stuff will be going down. Okay? So, ACS medical code. Let me just try one case. You have
I have the website, nhcps.com/ACLS mega code. nhcps.com. I think I'll get someone there to type it. nhcps.com/ACLS mega code. I can type it. Let's type it.
We'll put it on the WhatsApp group for you as well. Please endeavor to try at least. That's the website. Endeavor to try at least once a week. Keep your half-life up of your stop. Okay, just write the website, and when we want to just try one, we'll try one now. Are we all together? Just write it down quickly and then look up. We are going to do a small test. Maybe we can browse with this one too when we finish and try and do 1 or 2 days. Are we all together? All right, let's look up. A 52-year-old man collapsed at a political rally. I will not say which rally. Okay. Bystanders perform CPR at the scene. They say your hospital is the closest one. They rushed him. You're the only one on duty. But you came for ACS 2022. You have a certificate to show for it. It's on your wall. Pulse, tready, blood pressure, 60-30, SpO2, 95%. CPR has been done. Question 1. What are the initial steps in management? Yes. I need a microphone. Somebody. Cardiovet. Somebody say cardiovet. Yes, is that the does cardiovet have it? Say again. Give somebody. Be bold now. ABC. How can you cardiovet what you don't know? Is it VFib? Is it VTAC? What is it? Is it asystole? Is it bradycardia? Hello? So first, ABCs. Check the airway, check the breathing, check the circulation, check all of those things first. Okay? So, ECG came out like this. Time is going. VTAC, you think? Initial management. Now we do more.
Don't forget that anytime we're talking about VTAC in ACLS, you have to specify whether it is pulseless or the one with a pulse. So you have to put it on
whether it's
stable.
stable or unstable.
So
is this stable or unstable? Somebody say it's stable. Unstable. The unstable say aye. The stable say nay. The ayes have it. Why this is unstable? Hypotension. Good. Hypotension. So it's an unstable, wide, complex, regular tachycardia. Right? Unstable, wide, complex, regular tachycardia. He's not in cardiac arrest anymore. He has a pulse somewhat. Blood pressure is there. He's looking at you. So what do? Cardiovet. Cardiovet. Synchronized cardioversion. Okay. So, what dose of cardioversion do you use? Open your book. Open your book. Open your book. Open your book. Don't kill the patient, oh. Go to page 34. Page 34. What did you see? 100. Somebody said 200 before. You don't burn the man. You have burned the heart off. You can see that this thing, it doesn't stay. Even after 2 weeks, if I go back, I may not remember that it's 100 because you have to keep on doing and doing till it becomes muscle memory. Till you don't have to think and it comes up. Hello? Great. So we say 50 to 100. Yes, 100 joules from our book. Now, which of the following should be used for pulseless VT? I wish we had poles here. Anyway, it would have been scattered. Yes? Which of the following? Open your book, what you wrote. Check this thing. Give microphone. Let me see a bold person. Give him. He said what? Somebody said 3. 1 milligram adrenaline, 300 milligrams amiodarone. Why? Give him now. He was the one talking. The man with suit in front of you. You want to deny yourself? Yes, somebody now. Somebody try. Go ahead. Go try. Why?
Okay, 3.
Why? Why? What rhythm is this? What rhythm is this? Pulseless VT. Right? Hello? What rhythm is that? Pulseless VT. Is it shockable or not shockable? Shockable. Shockable rhythms you give. Do you give adrenaline? Check. Do you give adrenaline? Yes, you give adrenaline. And you repeat it how often? 3 to 5 minutes. After you have shocked 2 or 3 times, what do you now bring in? Amiodarone at what dose? 300. Correct. And then subsequent CPR. You are right, but you're not sure. You are right, but you're not sure. Okay. Isn't that not simple, isn't it? Continue your normal CPR and you are changing the people. Okay, I think that's about it. If this patient, you give this one, and the patient still continues with VFib, what do you do next? Maybe try and open the website and let's see. What do you do next? Continue CPR, and then what next? You repeat the amiodarone now at 150 milligrams. And followed by adrenaline every 3 to 5 minutes. And you shock again. And you continue CPR. Okay? Shikina, that's ACLS for you. Eh? When do you stop? So
you can do your amiodarone up to, I think, 6 cycles. Yes. So the first one is 300 milligrams. So you'll be alternating amiodarone, adrenaline, amiodarone, adrenaline. So once you give up to 6 cycles of amiodarone, you can stop and just continue your CPR with adrenaline. So, but adrenaline comes first, then you'll be checking every 2 minutes. But the thing about the mega code is, and the real life is, the patient will not permanently stay in VFib. He can change from ventricular tachycardia. The next thing might be bradycardia. So everything comes in together, though it's discussed separately, but you can have the whole spectrum in a single patient. You can move from ventricular tachycardia to ventricular fibrillation, from there to bradycardia, from there to normal sinus rhythm.
Somebody asked the question on
how often? Till you stop. It is either the patient return to spontaneous return of spontaneous circulation, or PA for 30 minutes, and you just have to call it at that point.
As far as they have a shockable rhythm, you cannot stop. As you are doing that and it's not getting better, you should go back and check your 5Hs and 5Ts. You are missing something. In fact, in some cases, you are doing that CPR and moving the patient into the cath lab. People continue the CPR while we are doing the angio. We have done it before. You are doing the CPR, we are doing angio, we are looking, it's very difficult, but you are trying to get there. Or sometimes you thrombolize while they are doing that CPR. Okay? So, pulmonary embolism, so far you have that. So, the other alternative is, if you have had PEA and asystole for 20-30 minutes, and you have continued, and there is nothing 20-30 minutes, that's another way to think about it. Then a third way is, if you have the end-tidal CO2, if it remains less than 10 millimeters of mercury, yeah, 10 millimeters of mercury consistently for 15 minutes or so too, is also a sign that you may need to stop. The likelihood of coming back is very slim. Now, if you get it less than 10, that's on your monitor. If you have that monitor, and we will get it, don't worry. If you have that monitor and you are getting less than 10, it's a sign that your CPR is not effective. You are not pumping enough, your ventilation is not correct, and you don't have a proper advanced airway. Okay, so those are things to do. Now, sometimes it may also be a sign that your endotracheal tube entered the stomach. It happens. You think you are put endotracheal tube enter the stomach, you are pressing, there is no air. It has even blocked the trachea properly. So there is no air at all going to anywhere. Okay. So this is what the website looks like. And I think we should try one of them. But I also pick at random.
Okay,
so a 54-year-old presented to the emergency room with chest pain. So, and this is the rhythm you have. So, what will you do? The question is, what is the next best step? Can we move it up so that people can see? What is the next best step? Defibrillate, start CPR, intubate the patient, check a pulse.
Say it again. What answer the issues?
The time is going?
The time is going up. So we wasted so much time. Check a pulse, right? So my people said check the pulse, right? So you check the pulse, and it's important for you to know, like we said, if you see VT, you want to know whether it's pulseless or it has a pulse. So go to the next slide now. The patient does not have a pulse and a high quality CPR is initiated while you prepare the defibrillator. What's the appropriate joules for monophasic and biphasic defibrillators?
So which one are we choosing?
A, B, C, or D? Yeah, sure. D. Yes. Okay. Okay, so you think it's 120 for mono, 360 for biphasic?
So which one are we choosing? They said D. Let's.
It's B.
B.
So you tend to need less voltages for biphasic.
For biphasic
because it's
and
coming
more
from both
for
directions.
monophasic.
Okay, so it's B.
So next.
Okay, so next. So put that in your mind now already. So you have defibrillated the patient, but the patient remains pulseless. What is the next best? What's the next step? Say it again.
C. Continue CPR, administer epinephrine.
So that's perfect.
So next.
So next, and what medication apart from epinephrine can be given next?
Administered now. Amiodarone.
Okay. So that's a good answer. Next. So if you administered your next round of medications and performing another round of CPR, then you
have
see this reading on the screen.
So what's the next thing? What's your next step? What is your next step? What is your next step? Check your pulse, cardiovascular, defibrillate, administer amiodarone.
What's the reading, first of all?
What do we have now?
Okay, so when you have beta, you want to know whether there's a pulse or not. Okay. So next. So your patients
Now develop this. What do you do next? What is the reading first? What's the reading? What's the reading? VFib. So what do you do next?
Is there epinephrine, cardiovascular, CPR,
CPR,
or
defibrillation.
Say it again. So defibrillate by the mercies of God. So if it's defibrillating, you need to defibrillate. Okay, so you do this. So when we're going through it individually, you should read it. So I think we can afford to read that now. So.
So the idea is, like I said, it's going to take you through, because real life is not just going to follow this, a single path. It keeps moving depending on what is happening to the patient. So you can move from the tachycardia to bradycardia. So that after your amiodarone, the next thing may be atropine or whatever. So it depends. So you're going to follow it. So it's not going to happen the way we have discussed it, that, okay, the one with pulse, the one without pulse. And that is why it's a team effort. As you're doing, somebody is looking at the monitor, somebody is giving the drug, some people are doing the chest compression, and we're going to continue like that. So, any question?
Any questions? Oh my God. Okay, I think that. Thank you very much. Thank you very much.
All right, thank you, everybody. Thank you, Dr. Iseko, Dr. Opse, and Dr. Lalekon for the wonderful session. We will now take the role of interventional cardiology, and we have Dr.
Just 10 minutes, and it will finish now.
Okay, for just 10 minutes, and Dr. Dafe would be anchoring that. Please, let's welcome Dr. Dafe, please. Thank you.
Okay, thank you very much. A great privilege to be with you again and again. Dr. Iseko and his team has been a very phenomenal to all of us, and we keep learning from them. As we're about to start, remember what Dr. Seko mentioned, that if you have lidocaine, you can use it. So, Dr. Seko, you talked about the dose of lidocaine. Okay. So, lidocaine comes in either 2%, am I right, or 1%. So, it depends. How you calculate the dose is, if you hold the one of 2%, one mil is 20 milligram in that 2%. So that is how you calculate it. If you pick lidocaine 2%, if you withdraw 1 mil from that 2% of lidocaine, I'm not talking about, because lidocaine can come with plain lidocaine or with adrenaline. I'm talking about the plain lidocaine. The plain lidocaine, withdraw 1 mil, that 1 mil is equal to 20 milligram. 2 mil is equal to 40 milligram, and so on. If you are using the one of 1%, those of us that are in adult medicine, we use 2% almost every time. If you are in pediatric medicine, I use 1%. 1 mil is equal to what? 10 milligram. It's as simple as that. So how do you give it? You can give 4 to 4.5 milligram per kg, but don't exceed about 300 milligram a day. So you know how to do your calculations now. Thank you. Yeah. Yes. So as a team in the Cardiocare Multi-Specialty Hospital, we have a very beautiful cath labs, which many cases has been done there, and we have very, very exceedingly or excellent success rates. And even after we leave this meeting, we are still going to do another case. Dr. Seko is part of us. He's a great interventional cardiologist. I think because he has taken many topics, he's a little bit tired, so let him rest while we do this 10 minutes course. So we just want to show you some cases. You may have 1 or 2 questions. When you ask them, then we can throw light on it. You can see this is a 70-year-old male with end-stage renal disease, and is on hemodialysis. So next, yeah, press again. Yeah. So you notice that somewhere around here, the LAD is almost 98%. Okay, it's not working. 98% occluded. Is it working? Okay, will it work? The LAD is almost, oh good. Almost somewhere around here. Let it play again so that we'll be able to pick it up. Okay. Yeah. So you can see, yeah, that is where he pointing that. It's almost 99% occluded. And the next was for us to stent it, and it was stented. And post-stenting, revascularization was very good, and the patient went home rejoicing. Yeah, next one. So this is another case, 54-year-old man with previous history of, 2 previous history of STEMI. This man came from Bayelsa. So 2 previous history of STEMI. He received fibrinolytic agent in the 2nd episode. That was where we be able to give him, it was even streptokinase that we gave to him. So you should have a streptokinase in your lab. We gave him streptokinase. Then after that, we move him to Cardiocare and see what happened next to him. The LAD was totally occluded. Next slide. Yeah. So you just show it. You can see, yeah, you see a stump of the LAD, totally occluded. Next one. Yeah, you can see this another view. So Evis, you can point it downwards. Yeah, that is another view. You can see there is a stump there, as if you cut the tree halfway. The above the roots, is of the branches are all off, just only the stem remaining. Yeah, next one. So we proceed for a PCI of the LED. Yeah, LED. That is the ROCA. There's no problem with the ROCA. 54 is a young man. Next one. Yeah, you can see that you can see the stenting process ongoing. Stenting process ongoing. Next one. You can see that it has opened up. That point where there was a stump. This is after we balloon. After the balloon, we have not put a stent. After we balloon, you can see the distal part. So the whole of this has been cut off. Whole of this has been cut off. You can see from here to here, this is where the problem is. Yep, next one. Yeah, you can see, next one. She has not finished. Next. Is it hanging? Yeah, so you can see the stent ongoing now. Just only one stent we put for it. We put at the lesion and everything was fine. So this is the post stent. You can see the artery beautifully open back. And he went home the following day. And he's very grateful. He's in Port Harcourt there with me. Next one. We shouldn't go into all this detail. So this is a triple vessel disease. We do also triple vessel disease. It depends. Dr. Seko just did one triple vessel disease about, yes, last week. So we have a lot of triple vessel disease that we take here and there. Next one. Okay. You can see, play it again so that they can see where the lesion is. No back. Yeah, you can see the 99% occlusion of that proximal LED at that point. Okay, it's not responding. No problem. Next one. So these are the various views of the cases that we do in the coronary, both complex, moderate, and simple lesion. We stent all of them, but some of them we also send them to. Some of them to bypass surgery. If we give them, because anybody that had the triple vessel disease, you give them the two options. Either you want surgery, if it is stent amenable, you take them for stenting. Next one. Yeah, so next. So not just only the coronary, we also do peripheral procedures. Peripheral procedure ranges from carotid to renal to lower limb, upper limb peripheral. We take all of them. Let's just show you one of such case. No. Yes. Yeah, this is one of such case. This guy is a custom officer who came with critical limb ischemia. I had it at Yola. Came with critical limb ischemia, and we put a stent where that arrow is. We put a stent across it. I think you can play it. I think so. No. It came with critical limb ischemia. Yeah. I think we have it. Yeah. This was the stenting process when the stenting was going on, and after the stenting, beautiful, and it's fine. And until you call him, he will not remember you anymore. So apart from peripheral, we also do all the cardiac devices. We do from pacemaker to ICD to biventricular pacing. We do all of them. So the work at CardioCare is really loaded with all cases in the cath lab. So recognize these cases and send them, and I'm sure your patient will add you to the testimony of the good things he has received because of your good way to them. Thank you. If there is any questions, we can take it.
So question. So while we're waiting for question, there is a question about ACLS. What's the difference between cardioversion and defibrillation? And I think Dr. Iseko talked a bit about it. It's just about the timing of administration of the shock. For cardioversion, you want to administer the shock on top of the R wave. So you have to time it. The machine will time it for you. And you can only do that when the rhythm is regular. So when you have a regular rhythm like ventricular fibrillation, there's no way for you to know where the QRS is coming. So in that case, what you do is defibrillation. One is timed or synchronized. The other one is untimed or unsynchronized. That's just the difference between the two. The voltage too. So the dose is higher for patients with defibrillation and lesser when you are cardioverting.
Very important, yes. In addition to what Dr. Laliko just said, when you are to cardiovert, you number one, you will press synchronization. It's on the machine. If you come closer, when you finish, you can come closer. We'll show you here. You will press on the synchronization so that it recognizes it. This machine that is here, this is Philips. Yeah, I think so. This is Philips. If you press it, you will see dot on top of the QRS complex. Once you press on the synchronize, you will see the button showing green light. And you will, on the QRS complex that comes up, you will see the dot on top. So that tells you that the machine has synchronized himself. So whatever you give the dose, it's cardiovert for you. But in defibrillation, you don't need to synchronize. You just put it and you charge. Both of them you will charge. So you just charge and you give your current. And as Dr. Naliko explained, in cardioversion, the current is, the charge or the dose is far lower compared to defibrillation.
Thank you, Doctor. Dr. Edafe. Please, what is triple vessel disease?
Okay, good. Triple vessel disease is when a patient has lesion or stenosis in 3 vessels. For example, if a patient has a stenosis, a significant stenosis in the left main coronary artery, you consider it a triple vessel because it bifurcates into 2 vessels. That is left anterior descending and the circumference. So because of that, you consider it a triple vessel. If a patient has a lesion in the LAD, a lesion in the ROCA, that is a double vessel disease. If a patient has a lesion in the LAD, in the ROCA, in the circumference, and that patient has had a bypass before, and that patient now had the lesion in that bypass, because if they are doing a bypass, either they use Lima, left internal mammary artery, or they use the saphenous vein, long saphenous vein. Any of them they use, and that vein become disease again. So that one is it's a 4 vessel disease. Yeah, thank you.
Thank you very much, sir, for that teaching. I want to confirm if the dosage of lidocaine you gave is intravenous. Because before you came, Dr. Iseko told us about somebody who mistakenly gave it instead of ceftriaxone, and it caused a cardiac arrest, and the person had to do CPR until the child got up. Now we're using it. Is it intravenous? And can you reconcile with what he asked?
I'm so happy with this question you asked. Very good question, because you want to collect everything and go home with it so that the difference is very clear. The dose I just gave are all intravenous dose. In fact, a few minutes from now, we are going to take a coronary stenting. We are going to do it from the radial. Sometimes I give it also. And the only thing you will do, once you withdraw the particular dose, double dilute it. That was what I would advise you. Double dilute it with either sterile water or normal saline. So if assuming what order you have, you want to give 40 milligram. That 40 milligram, because I'm an adult physician, so I usually use the 2% to calculate my doses. So I withdraw 2 ml, which is 40. I can dilute it up to 10 ml. Then I will over 5 minutes. It's fine. It will not do you anything. The patient may just feel some sensation of hotness, but it doesn't do anything. Once you give it at the right dose, in fact, if a patient comes to you with VT, ventricular fibrillation, ventricular tachycardia, if you don't have amiodarone, just calculate the dose and push it. You will be happy to hear the good results.
Thank you very much. Okay, there's a question there.
Thank you, sir. Please, you taught us how to interpret ECG, but you did not teach us how to place the leads.
Okay, sorry for that oversight. We just don't want to make the presentation bulky. So, to place the leads, the chest leads, there are 6, from V1 to V6. So, just remember everything is from 4 to 6. So, V1 is at the right sternal margin, 4th intercostal space to the right. V2 is on the other side on the left. V1 is on the right, 4th intercostal space, right sternal margin. Your V2 is on the left on the same level. Your V4 is the apex beats, 5th left intercostal space, mid-clavicular line. V3 is between V2 and V4. Then, just remember that 4, 5, 6 are on the same line. 4 is at the apex, that is mid-clavicular line. Then, anterior axillary line for V5. Then V6, mid-axillary line, all on the same level. That's for your chest lead, V1 to V6. Then your limb leads, the colors are different. So it's difficult to say, but most are red, yellow, green, and black. So red is for right, yellow is for left. Red on the right arm, yellow on the left arm, green is on the left leg, then the black, which is neutral, is on the right leg. So red, yellow, green, black. So, but there are some that the colors are different. But on the Abuja Cardiovascular group, there's a picture of the arrangement of the precordial leads on the group. If you check your WhatsApp, I've seen it there this afternoon. Someone sent it there. I think I've been able to answer that question.
Thank you very much, Chief. And just to add to what he said, sometimes you can get the pictures on Google and then the app, that software that runs your ECG, because I know as once you boot it, you see the color coding for placing the leads on it, just to, in case the colors are different. Okay. All right, thank you very much. Just a few announcements before we close out. First of all, I want to thank you very much for attending the 6th Abuja Cardiovascular Symposium. And you can agree with me, it was such a good time. We got that the value is just, we can't put a price on it. I want to thank you very much. We're just going to take the closing prayer, but just a few announcements. The certificates are ready at the back, and they are arranged in alphabetical order, but we're advised to please come row by row. And then let's not forget the highlights, the most important things we learned. Most importantly, never, ever, ever give sublingual nifedipine. And if you agree with me, after the heart failure session, the skeleton can now propose to his girlfriend, right? Because his heart is no longer failing. So we're going to call Dr. Awopsoe to please take the closing prayers.
Okay, so thank you very much, everybody, for coming. Hopefully you join us next year for that will be the 7th Abuja Cardiovascular Symposium, which invariably will be bigger and better one. I want to use the opportunity to thank our sponsors, to thank Limi Hospital, Cardio Care, Limi Children's Hospital. Hopefully next year we'll do that again. So can we take the closing prayer now, please? Can we rise for the closing prayer? Let's rise for the closing prayer. Father, we thank you for this opportunity to deliberate, to learn, to increase our skills, to increase our expertise, to network with each other. We pray that we'll be able to use these skills to improve our practice, to improve the lot of our patients, the communities we serve, to improve cardiovascular healthcare in Nigeria. Father, we pray that even as people depart to their various destinations, to their various centers, we pray that you continue to be with each and every one of us. In Jesus' mighty name we pray. Amen.
Please, can we just go table by table so the back is not crowded? Don't worry, it shouldn't take time if we go in batches because the certificates have been arranged alphabetically already. Thank you.
More music on trendybeats.com.
Ololade mi Asake.
If I enter your motor, I go make you to shout. Pum, pum, pum. Pum, pum, pum.